Shy about finding. We encourage people not to be shy about finding empty chairs.
Okay. You know you've got a success when you have a standing room only conference. It's really wonderful at 8:45 on a Friday morning. Welcome all of you. Last night we summoned into existence the brand new Solomon Center for Health, Law, and Policy. And the goal of that center, as we said last night, is to inspire scholarship in an industry that is understudied in the legal academy, and to become a valuable resource for policymakers in Washington and really throughout the world. And today we begin the first conference of the center, which is co-sponsored by the Yale School of Management, and which focuses on the new healthcare industry, integration, consolidation, and competition in the wake of the Affordable Health Care Act. And on behalf of myself and of Dean Ted Snyder of the School of Management, I would like to welcome all of you to today's conference. It is really a great way to begin the new Solomon Center because it focuses squarely on an issue of immense consequence. And it focuses on events that are poorly understood and that are rapidly developing. I want to begin the conference by thanking Dean Snyder and also Abby's SOM partner in making this conference possible, Fiona Scott Morton, who is the Theodore Nierenberg Professor of Economics at the School of Management. They have been, let me say, perfect and tireless partners in making this conference come to life. This conference provides an important occasion to reflect on recent changes in the structure and delivery of healthcare and to chart a course for the future. And that future will depend in no small part on the very people in this room. During today's panels, we will hear about the role of politics in American healthcare, about the enforcement of challenges associated with horizontal and with vertical consolidation, and about the blurring of traditional boundaries of health services. With us to discuss these topics are leaders from all the many corners of this complicated industry. They include doctors, academics, businessmen, CEOs, defense attorneys, and government officials. Among our guests are administrators who manage numerous hospitals and thousands of medical professionals, executives who oversee some of the world's largest clinical trials, and leaders of government agencies charged with regulating healthcare in America. Each brings a different perspective to bear in the conference, but they all share a deep and abiding commitment to thinking seriously about how to improve healthcare in the United States. Of course, this conference is meant to provide more than mere intellectual stimulation. I believe that our work today will produce insights about the consolidation of the healthcare industry that might inspire, in fact, positive change. And to that end, we are very grateful to have as co-sponsors Health Affairs Magazine and the National Academy of Social Insurance, both very influential organizations that will help us disseminate the insights that will be revealed in today's discussions. Yesterday, former Secretary of HHS, Kathleen Sebelius, kicked off a conversation that will continue with our two opening speakers this morning. In a few minutes, we will hear from William Baer, the Assistant Attorney General for the Antitrust Division of the Department of Justice, and from Maura Healey, who is the Attorney General of the state of Massachusetts. I should mention that Bill has gone to heroic lengths to join us today, although the Department of HHS called him to DC. He has evidenced his commitment to this project by agreeing to join us live over video conference. Before starting at DOJ, Bill headed both the civil and criminal antitrust divisions at Arnold & Porter. He has also served as the director of the FTC's Bureau of Competition, where he oversaw significant enforcement successes, including blocking mergers in office supply and drug wholesale markets. He has also successfully challenged exclusionary practices in toy, information technology, and drug markets. Attorney General Healey was sworn in on January 21, 2015, and since taking office, she has confronted, among many other challenges, the heroin and prescription drug abuse epidemic, escalating healthcare costs, and the major proposed expansion of Partners Healthcare. Prior to her election, Attorney General Healey was the head of the Massachusetts AG Civil Rights Division, and she was chief of the Public Protection and Business and Labor Bureaus. We are very grateful to her for taking the time to be with us this morning. Before concluding, I must once again thank the Solomon family for their generosity in creating the center. They have created an institution which I hope will create history. And I want to thank Professor Gluck, who is, in point of fact, the perfect person to push history forward by sheer force of dedication and commitment. This conference bears witness to her tireless energy and vision. I am delighted that so many of our alums at the Yale Law School have returned to celebrate this wonderful occasion, and we hope that this marks the beginning, the first of many times you will come back with us to think about these issues of health. So with that, let me turn the program over to our two distinguished opening speakers, whom we are thrilled to host at Yale. Please join me now in welcoming Assistant Attorney General Baer and Attorney General Healey, who will each open with remarks, and if time permits, Attorney General Healey will take some questions from Fiona and from Abby. So, Assistant Attorney General Baer, nice to see you.
Live from Washington, D.C. Thanks, Dean Post, Dean Snyder, Professor Gluck, for inviting me to help start the conference this morning. The turnout is a tribute to Yale Law School, the School of Management, and the new Solomon Center. I regret I'm not able to be there in person. We are celebrating today here in D.C. in the Great Hall of the Justice Department the 125th anniversary of the Sherman Act, and we are giving an award we've given out 10 times in the past to Judge Diane Wood, the Chief Judge of the Seventh Circuit Court of Appeals, the John Sherman Award. So we've got a big series of events going on in a few minutes downstairs, which is why I could not come up to New Haven to be with you. I also regret not being able to share the dais in person with Massachusetts' outstanding Attorney General, Maura Healey. She and her talented antitrust team have been tireless in ensuring that the citizens of Massachusetts benefit from competition in healthcare markets. We have been and continue to be proud to partner with her and with other state attorneys general on promoting competition in the healthcare sector. Now, you all know the statistics. Healthcare continues to be among the largest and the fastest growing sectors of our economy. The federal government spends as much on healthcare as it does on anything else. State and local governments are in a similar predicament. Businesses spend on average $12,000 per year per person to provide health insurance coverage for employees. Medical debt remains a leading cause of personal bankruptcy. Now, competition is central to the provision of affordable, quality health care in the U.S. It promotes innovation. It helps deliver the best health outcomes for the lowest prices. Consumers benefit when they have meaningful choices among insurers and hospitals, among physicians and therapists, between prescription drugs and medical device providers. The Affordable Care Act is premised on the idea that consumers benefit from robust competition in both provider and insurer markets. The ACA's health insurance marketplaces, the exchanges, depend on insurers competing based on the strength of their networks and the prices they offer. In turn, the exchanges make it easier for consumers to compare plans and give competitors additional access to a significant number of customers. On average, consumers can choose from plans sold by 5 different insurers today. Studies confirm what common sense already tells us. Consumers who have available to them exchanges with more competition enjoy lower premiums than those who have fewer choices. Maintaining, indeed even expanding competition among health insurers will bring more of these benefits to consumers. Now, the ACA also recognizes the value of legitimate collaboration by promoting accountable care organizations and clinical integration that can improve the quality of care while at the same time lowering cost. The Antitrust Division and our colleagues at the FTC work closely with the Department of Health and Human Services to support these efforts by providing guidance as to when and how traditional competitors can collaborate without lessening competition and thereby without harming consumers. The FTC DOJ policy statement on ACOs describes how they can benefit patients without violating the antitrust laws. They include safety zones for some ACOs and the standards under which we would apply the antitrust rule of reason to other collaborations. The launch of more than 700 public and private ACOs up to this point demonstrates the opportunities for new forms of clinical integration. Now, while the ACA promotes collaboration and integration, it does not and was not meant to give a free pass to, from compliance with the antitrust laws. Indeed, the very harms that result from the exercise of market power, higher prices, fewer competitors, reduced innovation, are contrary to the law's goals. Antitrust enforcement in healthcare should aim to prevent or remedy the acquisition and abuse of market power, just as it does in other industries. We don't pick winners, we don't pick losers. Our job is to block mergers that threaten to reduce competition. Our job is to challenge competitors who want to conspire rather than compete. And our task is to ensure that companies do not raise barriers that deny competitors the opportunity to enter new markets or expand their existing market presence. The Antitrust Division and the FTC, together with state attorneys general, have a long history of challenging insurer, hospital, and physician mergers that threaten to reduce competition. Over the past decade and a half, the Antitrust Division has either blocked outright or acquired divestitures from 7 health insurance mergers. We did this to protect individual purchasers, employers buying both small and large group insurance, Medicaid managed care enrollees, and seniors who rely on Medicare Advantage. We've also sued to protect competition in the purchase of physician services and have required divestitures to prevent anti-competitive reductions in physician payments. The FTC has done tremendous work stopping a string of potentially anti-competitive hospital mergers across the country, and recently winning 2 appellate cases blocking mergers that otherwise would have adversely affected the markets for physician and hospital services. Merger enforcement will continue to be a priority. We look to the future as the Clayton Act asks us to do. We don't take just a snapshot of the market as we find them today or as we found them yesterday. We assess how markets are likely to evolve, including trends towards increased concentration. We look at how companies that deliver services locally for some customers also may increasingly compete regionally or nationally. We consider whether a merger among hospitals may create greater bargaining leverage over insurers or vice versa, even when the merging parties do not compete to serve the same patients. And as always, we carefully weigh the benefits the mergers may provide. We recognize that mergers and other forms of integration can lead to cost savings and improved quality of care, and we will credit legitimate efficiencies that will benefit consumers of healthcare services. Now, it's important to note that not all acquisitions meet that test. Look at the stories about the underlying motivation for some recent hospital acquisitions of physician practices. It's undisputed that Medicare and many private insurers usually pay more for hospital outpatient procedures than they do for the very same procedures performed at a physician's office or an ambulatory surgical care center. We've heard concerns that some of these acquisitions are designed to take advantage of the higher hospital-based payments, even when there is practically no change in the care actually being provided. Now, Congress and President Obama recently took steps to reduce this incentive to consolidate. The Budget Act, passed just a week or so ago, requires that outpatient care at newly acquired or developed sites located away from a hospital's campus be billed to Medicare at the generally lower rates for physicians and ambulatory surgical center. It's estimated that this measure will save the government $9 billion over the next decade and will save patients from being on the hook for higher out-of-pocket costs as well. We've seen attempts to justify mergers on the ground that they will improve a company's negotiating position. Hospitals may want to merge to get leverage over a dominant insurer. Insurers may want to merge to get leverage over a dominant hospital. Courts have long rejected the notion that countervailing market power justifies anti-competitive mergers or agreements. It is not at all clear that consumers win where a merger is justified solely on creating more bargaining leverage, the so-called second 800-pound gorilla defense. As my friend and mentor Bob Pitofsky said about this argument some years ago in the healthcare sector, the antitrust laws reflect a fundamental premise that consumer choice, rather than the collective judgment of sellers, should determine the mix of price and quality options available in the marketplace. This is still true. Consumers do not benefit when sellers or buyers merge simply to gain bargaining leverage. Consumers benefit where there's entry, where there's expansion, where there's innovation, and where there's competition. Effective antitrust enforcement extends beyond reviewing mergers. We sued a couple of years ago to stop Michigan's dominant health plan from using most favored nations clauses to insulate itself from competition. And we saw policymakers respond positively. In Michigan, North Carolina, in other states, they incorporated those antitrust principles into law and regulations that outlawed anti-competitive most favored nation clauses. In Arizona, we stopped the Hospital Association from using its members' hiring practices to depress wages for temporary nurses. And in Texas, we told a dominant hospital that it could no longer use de facto exclusive contracts to discourage insurers from signing up smaller hospital rivals. Now, some hospitals and physicians think it's okay to reach anti-competitive agreements with their competitors so long as they don't agree on price. That's just not right. Earlier this year, we sued hospitals in Michigan who had agreed to limit advertising in each other's markets. And we've regularly challenged group boycotts by providers and their trade associations directed at private and public insurance plans. As antitrust enforcers, we also need to be advocates for competition. The Antitrust Division, together with the FTC, have worked over the years to improve our understanding about how healthcare competition works. We've tried to share that knowledge with the public. Recently, a new part of our Antitrust Division website chronicled the enforcement and advocacy efforts over the last 25 years. And we've tried to persuade state and local governments to avoid adopting or to reform existing rules that unnecessarily limit competition. The division and the FTC worked together a couple of weeks ago to urge Virginia and their state and local governments that certificate of need laws create barriers to entry and expansion, that they limit consumer choice, and that they stifle innovation. There's a lot more work to do, and your conference today is part of the effort to take on that task. Many longstanding characteristics of healthcare markets, low price transparency, imperfect information about quality, high barriers to entry, and vulnerable consumers can disrupt the competitive process. Antitrust enforcers at the federal and state level must remain vigilant. We must continue to watch out for anti-competitive mergers or other agreements that exploit these imperfect characteristics of the healthcare marketplace. We must ensure that incumbents do not stifle innovators working to provide low-cost care, whether through ambulatory surgical centers, telemedicine, or new types of providers. Competition has a critical role to play in promoting innovation and ensuring that American consumers have access to high-quality, affordable healthcare options. Once again, I thank you for allowing me to participate in your conference today. Thank you very much.
Good morning, Bill. It's great to see you. Happy anniversary. How about that? Anniversary of the Sherman Act. I hope you get cupcakes down there. That's a great thing. Very apropos, too. In all seriousness, I have the greatest regard for Bill Baer and his team. We had the opportunity in our office to work closely with them on a few matters, and we're really fortunate to have the terrific folks at the Department of Justice's Antitrust Division doing the work that they're doing, and doing it in a way that that they're able to work with state attorneys generals. I think that's really important, and we certainly saw in our working experience how invaluable it was for us as a state AG's office to be able to have our teams work closely with folks at the Department of Justice. I think at the end of the day, we're going to get a much greater result for the public interest as a result of that working relationship, one of collaboration, one of cooperation, and really a sharing in terms of values and principles of what we're trying to work towards. So I'm sorry I can't say hello to you in person, Bill, but again, many thanks to you and to the team. Okay, I can't see him. So look, Dean Post, thank you so much for the invitation to be here, and Professor Gluck for the invitation to be here. It's great to travel down this way. I've left Massachusetts, so when you get to New Haven, you get a little bit of, something's not quite, there's a lot of blue here. That's okay. This is the best I could do, guys. I still had to sport a little bit of the crimson color, but beautiful school, beautiful campus, and I just want to say how much I admire the initiative of the Solomon Center and what this is about, and creating a center that will focus on, as Bill Baer says, an issue of immense importance: healthcare policy, health law, and public policy, in the intersection that it has with so many aspects of society. I also want to say, and I'm just going to move this chair a little bit so I'm not awkwardly leaning over here. I also want to commend Yale Law School and the School of Management for its sponsorship of today's conference and discussion. Let me say at the outset, I'm just a JD, so I look around the room. There's only so much damage we can do, and there's only so much that we know. And I say that, and I think I speak on behalf of all of my terrific colleagues from the Attorney General's office who are here today, because I think we truly believe that we are part of the puzzle here, but we certainly continually benefit from the views, the opinions, the expertise of the likes of so many of you in the room. And I think to get at what seem to be at times seemingly intractable problems of addressing healthcare costs and affordability and access, we truly do benefit from an ability to work together and to harness the great thinking and expertise of folks outside of any law enforcement agency's office. So let me just share with you a few observations based on my extensive 10 months in office. I did work there before, though, for a number of years. I was head of the Public Protection Bureau, and actually had oversight of the Healthcare Division and the Antitrust Division, and later had oversight of the Nonprofit Public Charities Division. And it was in those roles that I came to develop more knowledge and understanding of the important way in which an Attorney General's office can intersect on the issues of health law and health policy. As some of you know, this issue of health law, of healthcare costs, of health policy really has been central to a lot of the work of the Massachusetts Attorney General's office. As the state's public law firm, our work on behalf of Massachusetts residents crosses many subject areas, from antitrust to consumer issues to health law issues, to our nonprofit oversight, where at least in Massachusetts, many of our major hospital and insurance systems are nonprofit. Proposed transactions, we know, can impact access to needed services, affordability of care, how we use charitable assets, and costs to employers and consumers. So it's a big job, and as I say, I'm glad we have a lot of partners in the room. Small P, Brent. Glad to see you too. In all seriousness, we need a lot of partners at the table as we think through and work through these issues. Exercising our parallel antitrust enforcement authority with the Department of Justice and the FTC, state attorneys generals can play an important role in the review of proposed transactions that affect our communities and affect our home states. Let me give you a little bit of the context for those of you who don't live and breathe sort of the Massachusetts scene. Massachusetts, I think, has a lot to be proud of in the healthcare sector. I know I speak from a less than objective perspective on that, but I think it's true. Our providers and insurers are among some of the finest in the country. I'm proud that we were the first state to bring universal healthcare reform to its residents. In 2008, our legislature gave the Attorney General's office a unique authority. That is, an authority to request documents. Another word for that is subpoena, payers and providers in order to take a look at what's happening with cost trends and cost drivers. We've used that authority in our office to try to learn critical information about the market and the market dynamics, what's working, what isn't working when it comes to our healthcare for consumers and for businesses. In 2010, a couple of years later, the legislature again acted by passing additional cost and quality transparency requirements that tied them to the development of market-enhancing initiatives such as tiered and limited network products. A couple years later, in 2012, the legislature was at it again, creating new agencies. We have something called the Center for Health Information and Analysis and the Health Policy Commission. Shout out to my colleagues in those respective agencies here today. Their job is in part to help us analyze the performance of market initiatives and market participants. So we're lucky that we have an engaged legislature. We have a legislature that is willing to work on and consider these issues. And a lot has happened in Massachusetts in the last few years. That said, we know that we have a lot of work yet to do when it comes to controlling healthcare cost growth. We want people to have meaningful access to care, and I don't want businesses or employers to go bankrupt trying to get it. I also don't want the consumers that we hear from in our office every day having to make these difficult choices between, am I going to be able to afford the copay or deductible, or am I going to be able to make a tuition payment or put groceries on the table? And that's the reality for many families, not just in Massachusetts, but across this country. And I think one thing that a state attorney general's office can bring some perspective on is we really are on the front lines in terms of hearing from families and consumers and businesses and employers about the impact of the decisions made with respect to healthcare policy. And hopefully it is that knowledge that will inform better decision-making and action out of an office like ours. So what do we do about it, or at least what can we do about it? Well, when I came into office 10 months ago, one thing I decided is that I really wanted to make this front and center of our effort. I also thought that to be more effective, we needed to reorganize a little bit within the office. That may sound boring to you, but I thought it was an important effort that we restructure the office and create, for the first time, something that didn't exist before, a bureau on healthcare and fair competition. That's what we called it. It's a lousy acronym, but it's an important function. And we brought within it, I think, the parts of the office that work in the healthcare space: our antitrust division, our health law division, our false claims division, our Medicaid fraud division, and our nonprofit public charities division. All these divisions that have natural synergies. And if we're going to be effective at looking at, and more importantly, addressing issues of healthcare and healthcare accessibility and costs, I think a more integrated approach will be more effective. So we started with that within the office. I'm delighted that Mary Beckman is here today, head of my bureau, Karen Sung, head of the healthcare division, Will Matlack is head of the antitrust division. So we're here to learn collectively. Second, apart from the restructuring, the work of the office has continued using those investigatory market sort of review tools that the legislature gave us a few years ago. Just recently, we issued what was, I think, our 5th cost containment report, where we basically published the results of what we looked at in terms of the data. We found in this most recent report that some of the market dysfunction that we identified in 2010 in the initial report still persists. We have more work to do. Providers continue to be paid prices, whether on a fee-for-service basis or a global risk basis, that vary widely and are not necessarily tied to quality, patient complexity, or other common measures of consumer value. Perhaps unsurprisingly, the higher-priced and better-resourced providers continue to draw significant patient volume in our state. A couple comments in terms of the perspective of healthcare consolidation. You know, I think as consolidations unfold against this backdrop, we as a public interest law office hear from the public regarding a wide variety of concerns each time a transaction is contemplated. And again, bringing the perspective of the Attorney General's office, I just want to share with you what form that takes. For example, hospitals, particularly in Massachusetts, major economic drivers, major significant employers. And when there is talk of consolidations or mergers, acquisitions, there is concern felt across communities about what effect that is going to have on employees and potential job loss. Loss of control of a local community hospital engenders a lot of agita, not just among elected officials, but folks within a community, folks who are used to visiting or spending time with. They have a real bond with their community hospital. And anytime we face the specter of a community hospital closing, know that our office receives a lot of calls and a lot of concerns about that. It may be easier for a large healthcare system to decide to close down a hospital or key services in one community than it would have been for a board at that community hospital, and that's just the reality. Moreover, most community hospitals are also public charities built up over the years with donations from the community, so that also raises issues with respect to the use of charitable assets. And as attorney generals, as an attorney general's office, we hear concerns voiced across all of these sectors in all these different ways. Let me talk a little bit about our antitrust work, because this is an event focused on consolidation. I want I mentioned how we've realigned things within the office, but I'll speak specifically about our antitrust division. You know, our antitrust division, as you might expect, is charged with reviewing proposed transactions between providers and evaluating the likely effect that those transactions are going to have on the competitive market. Competition between providers plays a vital role in ultimately providing the consumer with the best care and innovation at affordable prices. Preserving competition, we know, directly helps consumers get access to the affordable care that they need. Now, when I came into office 10 months ago, we had a proposed acquisition that was currently then pending before the district, before our state superior court. This specifically was the Partners Healthcare proposed acquisition of South Shore Hospital, a major provider in the suburbs south of Boston. This was a major healthcare transaction that the Attorney General's office had been reviewing for some time. Partners is a large healthcare system that owns 9 hospitals in our state, anchored by the Massachusetts General Hospital and the Brigham and Women's Hospital, and contracts on behalf of many thousands of doctors. Its rates are among the highest in the state. And while Partners facilities absolutely provide top quality care, studies have shown that the quality measures used to evaluate healthcare providers indicate that it is not providing higher quality care than at some of its lower cost competitors for certain services. So that was the lay of the land that I sort of walked into. At the time, our Health Policy Commission, the recently formed Health Policy Commission, head by law, reviewed the proposed transaction, had issued a report projecting that the proposed transaction would increase costs and lacked an indicia of quality improvement. Now, part of the fabric for the healthcare reform in our state was the creation of this commission, which was essentially an independent body of experts from different fields that would, among other things, review proposed transactions and advise the public, advise healthcare stakeholders, lawmakers, and our office about the projected effects of these transactions. The Health Policy Commission in Massachusetts is obligated to formally refer any proposed transaction to the Attorney General's office when it determines that the transaction is likely to increase costs in ways that meet certain statutory triggers, including that a provider has or will have a dominant market share. That's what happened in this instance. The Health Policy Commission had referred this to our office. And ultimately, while I was out on the campaign trail, what ended up happening is the parties negotiated a settlement agreement. It was an extensive, robust settlement agreement that was then filed with a Massachusetts state court judge for approval. The settlement would have resolved the investigation into the proposed South Shore transaction, as well as the acquisition of a smaller hospital system just north of Boston. In exchange, there would be in place tough regulatory style restrictions on partners' rates, as well as limitations on partners' future growth and contracting practices. So that was sort of what this settlement agreement looked like before the court. There was then a response by the public and the healthcare community. Several comments were filed in the court, number of comments and concern expressed that the deal wasn't going to do enough in terms of limiting size or potential bargaining leverage. And as I began my new job, the judge had already held a number of hearings concerning the settlement agreement, and at one point had asked that the new Attorney General, me, provide my views with respect to the settlement. Well, we took a look at things. I discussed the proposed transaction with the staff and ended up filing a notice with the court while the matter was pending that said that if the court were to approve the settlement, I would enforce its terms to make sure that the state received the benefits of the deal, consistent with, I think, the Attorney General's prerogative to protect the public interest and enforce the terms of any settlement agreement like that. I also noted that if the court rejected the settlement, my office would be prepared to litigate to stop the transaction from going forward, rather than attempt to renegotiate or refine the terms of the proposed settlement. The judge had expressed concerns about some of the terms of that settlement. What I also said is that I wanted to see if an entity could lower costs first within its existing structure, then seek to apply that proven cost savings ability to any proposed acquisition. I was and I remained concerned about providers proposing to acquire competitors before demonstrating that cost savings could actually happen. And that sort of became an overriding principle for our office. Show everyone, help us understand how a proposed transaction or consolidation is going to help bend the cost curve in the direction that we want before one seeks to grow and get bigger. Put another way, we'd like providers to prove it, not just project it. And that has sort of become an operating principle for the way we view proposed transactions and consolidations, at least in Massachusetts. Show us why it's going to be good for consumers. Again, that really is the focus of the Attorney General's office. How do we protect consumers? Show us improved affordability and access to quality care within your current system before you come to enforcement authorities seeking to expand. So many of you know how that particular chapter ended. The court ultimately denied entry of the consent judgment and settlement agreement, and the entities decided to forego that proposed merger. But I expect there will be other proposed transactions and the like in the time ahead, and we'll take each one in due course, looking at the law, looking at the facts. I imagine we'd have opportunities to work with our federal partners, again, as we have had in the past, and we'll keep an open mind about things. But I think from a state attorney general's perspective, the perspective and the focus is, how do we best protect consumers here, and are we using all the tools available collectively to work together to drive down costs? Because at the end of the day, and this is very simple, but again, I'm only a JD, this is about accessibility, right? The whole point of reform, I think, and the whole point about affordability is, how do you drive people actually being able to access care? And that continues to be the guiding principle of our office. We have and we will continue to apply our expertise to investigating future consolidation in the healthcare market, and we will work with our state partners as well, the Health Policy Commission and CHIA, to better understand the likely impact of any proposed deal. So I will close there, but I want to make one note for some of the antitrust lawyers in the room, and that is a comment about conduct remedies, because that is something I think our office had explored in thinking through the consent judgment, the settlement agreement that had been contemplated. One of the lessons that one might take away from that is the lesson about the complexity of trying to style an agreement that contains a regulatory style conduct remedy. I know one of the interesting things about being an attorney general's office is that you get to think in innovative and creative ways as to how you solve problems, but and how you settle potential enforcement actions. But I think a takeaway is that we were sort of what was revealed to us is that how complex it is to think about the effectiveness of actualizing a regulatory style conduct remedy that is going to work. And that may lead more folks to engage in a more binary analysis, either let the transaction proceed or sue to stop it entirely. But we'll just sort of have to see how that plays out in the times ahead. So again, thank you for the opportunity to be here this morning. Thank you for the opportunity to allow us to help kick things off, and know that in Massachusetts, in the Attorney General's office, we welcome your expertise, we welcome your thoughts, and we sure hope we can work together over the years ahead. Thank you.
I've been deputized to ask you a question, which I'm very excited about. I'm Fiona Scott Morton. I teach here in the School of Management. I wanted to focus on the Health Policy Commission. I think many states don't have the luxury of what the Justice Department Antitrust Division has, of dozens of professional economists to look at something. In Massachusetts, you are not only endowed with a fantastic set of providers, but also some of the best policy and economists in the healthcare area in the country. Mm-hmm. So it's just a fantastic idea, I think, to put those people together into a neutral group that can weigh in with expert advice. And that, I think, in a often partisan environment where you've got parties wanting to do something and then people objecting to them, having somebody neutral and expert to say, here's what we think the answer is, can be very powerful both in a legal sense and in a rhetorical sense. And I know you've tried to expand the role of that group, and I wondered if you could comment on that a little further.
Sure. Well, thanks for the question, Fiona, and I want to give a shout out to all the folks from the HPC who are here in the room today. If you have put your hands up. If you have specific questions about how that commission operates in practice, please seek out those individuals. Yeah, I think it's, from a layperson's perspective, I think it's really helpful to have a commission like this with a number of members from different fields who are really there with a staff. They have a paid staff, but then the rest are all volunteers who sit as commission members, and they regularly meet and hear things out and convene. I think it's really helpful to have that body of experts looking at any number of issues. One of the things, though, that became, I think, a concern, or at least something that we thought was important to clarify, that really came about through the litigation that I spoke of, was what is the import of a determination made by that commission, and what's the effect of something when they send it our way? Basically, what I said to you before is this commission is able to look at and conduct a cost impact analysis of a proposed transaction. And if it determines that a proposed transaction is going to increase dominant market share, will increase total medical expense, will lead to materially higher median prices, then they get to refer to the Attorney General's office for action. But a question was raised by some as to, well, what does that really mean? We would proceed under our consumer protection laws to block a transaction where we thought that public interest wasn't going to be advanced and consumers were going to be harmed. But we wanted to make it clear what that referral actually meant. The report of the commission could be used as evidence. That was already in law. But what I proposed, it was the first piece of legislation I proposed, because I just didn't want to have a fight about this going forward in the future. While we think we have that existing authority, we wanted to be crystal clear. And so the piece of legislation says that when and if the commission finds those factors are met, makes a referral to our office, then essentially it becomes a rebuttable presumption, essentially, in any action we take to stop, should we be put in the position of having to then take action to stop a transaction from proceeding. The proponents of any transaction will still have their full day in court, can still challenge any aspect of the Health Policy Commission's report and finding, but it at least makes it clear that we can get in the door and that we have a basis to get in the door and assert a claim under the law.
Okay. So we've now heard from AAG Bear, and we've heard from AG Healey, and so we've heard federal and state, but we haven't really heard anything about the respective roles of federal and state. So how do you see your role? Is it complementary? Is it combative? How do you see your role vis-a-vis the federal government in this kind of enforcement area?
Well, first off, I think it is very cooperative. I think it is complementary. It's collaborative. There are certain things that I think we bring to this as a state attorney's general office, and certainly there are things that the feds bring to this, including a lot more resources. When it comes to some of the analytics and the experts, the fact of the matter is that the Department of Justice is going to have more resources available to it than probably any state Attorney General's office. I think the Attorney General's office can bring sort of a perspective of the front line, of what is the reality on the ground in terms of who these providers or insurers are, what's the impact, what's the real impact on communities, on employees, on employers, on the healthcare market in that geography. And so I think it's complementary in that sense. I think that the Attorney General's office, for example, in Massachusetts, has some additional tools for consideration. I mentioned consumer protection law. I mentioned at times applicable nonprofit law and thinking about sort of use and role of charitable assets. And I mentioned the specific role we have in Massachusetts when it comes to a referral made by something like our Health Policy Commission and how we might be able to use that, which is something not available to the Department of Justice.
If you are a provider and you're itching to say something to the government enforcers, there are a lot of you in the room, do not fret. We have a whole day chock full of provider perspectives that is upcoming. And Brett Henry will have his turn on the final panel of the day. So this is just a tease to be sure to
It's
stay
bad when he has the
forward.
last word. It's not going to be fair. It's only right.
We also have about more than 30 people in an overflow room across the hall. So we're going to take about a 7-minute break, and please ask everybody to move to the auditorium down the hall so we can all fit for the rest of the day. Our next panel is an all-star discussion among some of the top providers and government enforcers in the area. So please join us down the hall in the Levinson Auditorium at 9:45.
Can I make one more comment? Here's where I need help, folks, okay? I just want to make, in terms of issues that are on my screen, and I really open this up, I've got concerns about mental health parity. We've got a severe opioid crisis, just roiling across communities in our state. How do we do a better job in ensuring access, coverage, and attention to mental health issues and substance use issues? How do we deal with some of the underlying inequities? I look at Massachusetts. I bragged how great we are. We got 96% of our people insured. But in Massachusetts, I got communities where if you're Latino, you are 3 times as likely in Massachusetts to not have insurance. How do we deal with some of those disparities that exist in the market? And I will tell you, I'm concerned about the pricing of pharmaceuticals. We don't want to stifle innovation, but I know in our system, pharmaceutical costs are really contributing to the rise in healthcare costs in our state. How can we get a better handle on that? So thank you for indulging me on some of the things that we're thinking about.
Down the hall, please. Thank you.
I think the audience can see for the prepared.
Okay. Thank you all for coming. I want to particularly express my gratitude and appreciation to Professor Abby Gluck and Fiona Scott Morton, who have made this event possible, and really acknowledge and show my personal appreciation for what Abby has done in launching this center. I don't think I can say enough words about how difficult it is to make something like this possible, and to see what she's accomplished in a very, very short amount of time is extraordinary. And I just personally want to thank her. We've seen blurred lines across the entire healthcare sector over the last 20 years. We've seen pharmaceutical companies, biotechnology companies, and generic drug companies blurring lines between them. We've seen hospital and facility companies blurring the lines with retail pharmacies, with big box retailers in the urgent care space. And we've really increasingly begun to see blurred lines between healthcare facilities and insurance companies' health plans over the last several years, and this has been accelerated by the Affordable Care Act. And a lot of the innovation that is occurring is being prompted by government and the innovation from the Center for Medicare and Medicaid Innovation Center. And these changes are happening real time in front of us. And while some people can tell you exactly where we expect to be in 10 or 15 years, I, for one, and I think most of us know that, the future is unknown, but a lot of change is occurring, and it's occurring quickly. We have an amazing panel with us today. I'm going to let them do the speaking. I'll just mention who we have on the panel, and then I'll turn it over to our panelists, and we'll make sure that we have enough time for questions from the audience. We're fortunate to have Michael Dowling from Northwell Health, the successor organization, or the newly renamed North Shore LIJ Health System, Dr. Ben Chu, who runs the Southern California for Kaiser Hospitals, Lou Sandy from United Health Group, and Troy Brennan from CVS Health, also newly renamed. And we're fortunate to have Brock Richmond, Professor of Law at Duke University and visiting Professor of Law at Harvard University, with us today as a commentator. So I'm going to turn it over to Mr. Dowling to take the lead.
Thank you very, very much, and thank you for the invitation. I'm delighted to be here to make a few quick comments, and hopefully I will follow what it is they asked me to comment on. Let me just, in general at the beginning, let me just say, following up to the introduction, that this is it's a real fascinating time in healthcare. It is probably one of the most fascinating that all of us have been involved in for quite some time. And in many ways, if you stand above it all and look at it from the balcony, what we're involved in is in a whole series of experiments. We're trying to figure out how do you pay for care better, how do you pay to get best value, how to deliver care to enhance access and convenience, how to enhance quality, to define quality, what it is, try to understand the difference between medical delivery and health. They're not necessarily the same. And across the organizations, across the country, and the big providers especially, there are extraordinary innovations going on. And it is true that the Accountable Care Act accelerated some of this, but I also want to make it clear that, in my view, lots of these things were going on before, accelerated by, but not necessarily initiated by. And it's an important point. And you will hear other things from some of the other panelists about that. So a comment about us, Northwell Health. We were the prior North Shore LIJ health system in New York. We're a big provider. And we are involved in the delivery side of the business, but we're also a huge academic teaching center with about 1,600 residents and fellows, 800 rotating students. We have our own medical school, a very innovative medical school that started 5 years ago now. In fact, people from the Yale Medical School were involved with us when we created this. Very, very innovative. First new medical school opening in New York in 45 years. And a couple of months ago, we started a graduate nursing school. We have our own in-house corporate university. So we're big into the whole education space. We also have a large research entity that does some phenomenal research. We also have our own insurance company, which I'll come back and refer to. So we span the full continuum. So we started as a system around hospitals. And I was asked to just mention why we now do other things other than hospitals, and I'll try to respond to that in a second. But we started by merging lots of hospitals in the New York area back in the early 90s and all through the 90s. Most of the hospitals we took over, it's important, this is an important point, were hospitals that were losing money, many in areas where they were the sole and only essential provider, but doing so poorly that they could not survive by themselves. Because we had one tertiary campus that was doing well, we were able to take on these other facilities, and over time, we have dramatically improved each of them, enhanced services to the community, improved quality, became more efficient, and all of these facilities today are doing quite well. We have also, in that process, moved lots of programs from one hospital to another, consolidated programs, closed programs that were not effective. You know, you don't want to be doing OB in a hospital and only do about 400 deliveries. That's unsafe, so you move those services and you consolidate. The point is that I could spend a lot of time talking about the benefits of integration and the benefits of consolidation, because without that, the healthcare access and care and quality in many of the communities around where we now are would not exist today if we did not have that foresight to create a health system like the one we've done. And we were the first health system in New York. When we started to do it, there was nobody else doing it in New York. They were very common and popular in the other parts of the country, but not necessarily in the New York market. Since then, of course, we have dramatically expanded into lots of other areas. We now have a very, very large complement of outpatient ambulatory services. We've got about 450 ambulatory locations spread across the whole region, and they are from large centers that house multiple clinical programs to smaller ones, to urgent care centers, to multiple primary care offices, to freestanding emergency departments where you don't need beds. These are not uncommon across the country, but in New York they did not exist. We opened up the first one. And the whole thing was about moving into the community and providing services local to where people live. And that has been our major expansion over the past number of years, the past 5 years. It's not about the hospital business, in our view, as much anymore, although that's a major key component. And remember, hospitals like to get all the blame for almost everything, but we have to keep in mind that you need hospitals. When you really get sick, you need hospitals. When you have a chronic condition, in certain circumstances and in many circumstances, you need hospitals. Hospitals do great things, and they provide phenomenal service. We have phenomenal success. So it's nice to be able to castigate the hospital sector, and I think it's often done unfairly. Now, as we expanded, of course, the ambulatory network of services, we have dramatically reduced the utilization of hospitals. We have moved all of the services I mentioned to you about in some of the ambulatory areas have come out of hospitals. So I don't think there would be anybody up on this panel that would disagree that there's about 30, 35, 40% of things that were always traditionally done in a hospital that can now be done outside. Because of the advances in science and the advances in technology, you can do more surgery outside of a hospital today, et cetera. So all of that transition is occurring very innovatively. We also have lots of partnerships with lots of other players, and I'll come back to that point. Troy Brennan and I have been talking about partnerships. We do some partnerships in the area. And the whole idea is to look at how it is you can provide access better than you did before. Now, by having the full continuum of services, we're able to manage care across the full continuum. You're able to be very innovative and use the resources to bring all of the pieces together to deal with the holistic nature of a person's condition, not the episodic nature. Now, we have an insurance company. People will ask, why did you want to get into an insurance company? Well, I wanted to have as much control as I possibly can over the premium dollars so that you can manage people's health and not just only manage people's illness. You also wanted to make sure that you had the control of the premium dollar as much as you possibly can so that when you reduce the utilization in a hospital, I get to keep some of the savings. Whereas we can do wonderful things to reduce hospitalization, utilization, but I don't get any of the savings. Insurance companies get the savings, I don't, I get the cost. They get the savings. So there has been traditionally a terrible misalignment of incentives. By being in the insurance business or partnering with an insurance company, you can actually align the incentives differently and better. And the issue of the blurring of the lines, which I know is the topic here, I think what you're going to see is a lot more partnerships. You'll see all parts of the health system doing things together more creatively in the future, and I think that's absolutely great. Insurance companies are getting into the provider business. Providers are getting into the insurance business. In fact, in this part of the country, having a provider be an insurance company might be unique, but in other parts of the country, it's common. And Ben will probably talk about this. There are some other large health systems around the country, and many of them that are quite successful and doing great work, all have insurance companies. So this blurring of the lines is not new. It's been around for a long time. It's accelerating today. And in the question that I was asked is, what do you want to be in the long term? Well, for us, I want to be in the health business, the health promotion business, the wellness business, as well as being in the illness care business. I want to be able to do both well. And to be able to set yourself up to do that, you have to have the right structure, you have to have the right delivery components, you have to have the right alignment of incentives. You've got to be able to benefit when actually you do one thing, and not only get hurt when you do one thing. And we want to be an innovator, and we want to be creative, we want to be out front, we want to disrupt. I would much rather be the disruptor than be getting disrupted. You want to be out shaking things up rather than being shook up by circumstances that you're not anticipating or not in control. So I think that there are lots of great things going on. The cup is always half full rather than half empty. Wonderful things going on. And I think we should feel very, very proud of some of the innovation that's occurring and some of the organizations that are doing spectacular things. It's very, very hard to motivate staff of tens of thousands of people by always talking about how bad things are. Things are very, very positive. And they've just told me I have a minute and I will be a good citizen and I will stop before my time is up, so I can't be blamed for delaying the events later on. So I know Ben Chu likes, I never want to take time from Ben. Who, by the way, is a guy, he and I have worked together for many, many years, so it's great. Thank you.
Thank you, Michael. Does that mean you're ceding time to me? No, just kidding, just kidding.
Only once.
It's actually quite an honor to be part of this inaugural colloquium. I'll just tell you a personal note. My very first class at Yale College 45 years ago was in this very room. Dr. Sidney Mintz taught me the value of cultural relativism in his anthropology class here. So it's really quite an honor to actually be up here at the podium. You know, I was listening to, thinking about the topic, the blurring of lines. And, you know, I don't know about you, but whenever somebody talks about blurring of lines, I think about my trips to the optometrist, right? Where you know how they do that? They put that thing in front of your eyes and they put these lenses in. It's blurry, it's blurry, it's blurry, it's blurry. Well, at some magical moment, they put in a lens that all of a sudden the world is totally clear, right? And from my point of view, what I want to see is that in that absolute moment of clearness, Kaiser Permanente. I know it's a risk. We're at a health law conference. The Attorney General was just battering us about, you know, antitrust, and I know it's the anniversary of the Sherman antitrust law, but it's not that I want to be Kaiser Permanente a national monopoly. I'm not talking about that. What I'm talking about is what you actually can do with the integration and all of the things that Michael was talking about, because some of you may, you know, many of you know us, but some of you may not know that we are the oldest group model health maintenance organization in the country. We've been in existence for 70 years. We take care of 10.2 million people across nine states and DC. The bulk of the members are actually in California, where we have 8 out of the 10.2 million in California. What is it that we can actually share with you about the value of integration that I think if you really look at it, it's not, and I don't really want to get into, you know, monopsony power and bargaining power. I think the health systems like Michael's system that are trying to build a larger presence and really integrating with the doctors are trying to do something that's different than really just having pure market power, right? So that's what I want to really talk about. You know, the linchpin of our success in Kaiser Permanente is a multi-specialty group practice, right? So we have doctors from all stripes, from highly specialized cardiovascular surgeons and neurosurgeons down to lots of primary care doctors who take care of, on a prepaid basis, which is the second linchpin. You know, we're totally capitated. We get a per member per month. And because of that, we have the freedom to deploy the resources in a way that hopefully is geared towards optimizing the outcomes for our members, right? So just to give you, we're next year with our 10.2 million members, we're probably around a $63 billion company. And in Southern California, where I'm primarily responsible for, we take care of 4,100,000 members as of October this year. And next year, my revenue base is going to be about $24 billion to sprinkle around. Not that we're just taking the money and not sprinkling it around. We actually have to provide the care. And that's the beauty of our system. You know, the multi-specialty group practice, the Southern California Permanente Medical Group has about 6,000 doctors, and they're a self-governing for-profit entity. We are actually a not-for-profit entity. The health plan and the hospitals are not-for-profit. So we capitate to the medical group, and as we receive the capitation, and that aligns our incentives completely, right? So that's what I think a lot of people are trying to build in the hospital world when they're trying to consolidate and bring the doctors together. Now, just because the doctors are together in a multi-specialty group practice doesn't mean they work together for the population's health, right? Because, you know, and I know it's a little bit, well, anyway, the one distinguishing characteristic about how we do that is our doctors are not only self-governing, but they actually are culturally aligned, you know, so they get together and talk about common protocols, they examine the evidence basis, and we actually devise strategies to actually take care of our members in a better way. think about the prepayment methodology, right? So the overall incentives are really, in the truest sense of the health maintenance organization, is to actually keep people as healthy as possible, right? We have all of the tertiary and quaternary care. We probably do more cardiac surgeries than anyone west of the Mississippi, just in Southern California alone. You know, if you add the Northern California volume, it's probably by far and away higher than most people. But one of the things that we've been able to do is, you know, we've blurred the line between public health and the care delivery system, right? Because as Michael said, health and healthcare don't always go hand in hand, right? You'd like to think that the more healthcare we give, the healthier the population is, but that's not necessarily true. And one of the things that we've been able to do, especially with our investment in the digital electronic health system, is we've been able to build population care management tools that actually scrub on a daily basis our 4 million members. You know, we look at what could we do that could actually keep them healthier based on all these evidence-based protocols, and we're much more proactive in our abilities and our attempts to actually get people as healthy as possible. So if you're 55 years old and you haven't had colon cancer screening, we'll actually go after you. You know, we'll actually go after you, not really literally go after you, but you know what I mean? We call you, we have IVR calls, the doctors, and every touch point. The other piece of it is that we've been able to build tools so that every touch point in our system will try to address those gaps. So usually you say, okay, there are gaps in care, give it to the primary care doctor, it's your responsibility. But the truth of the matter is, most people don't go to the doctors that much, right? You think about it, the average number of visits is 4 visits per year to a doctor, and that factors in all the visits to specialists, et cetera. And a visit is about 15 minutes. So 1 hour a year is not enough time to actually do the things you need to do to keep people as healthy as possible. So what we've done is we've been able, because we're not tied to fee-for-service, right? We can deploy our resources in lots of different ways. We're actually able to build tools that allows people to at every touch point, like the receptionist out front, or an appointment contact center person, to try to address some of the gaps that you have. So the first time that a receptionist pulled a lady in to get a mammography and we found breast cancer, you know, we highlighted that, right? We just plastered it all over actually all of Southern California. And that built an incredible dedication on the part of our 60,000 employees in Southern California to actually do the right thing. So the value of integration, if you really think about all of this, is that you can actually begin to do the right thing in a much more proactive way and get to better health. The last thing I will say, I know I had is that, and this is, I wanted to give a segue to Troy and others, the consumerism and digital revolution will actually give us many, many more tools to be able to blur the lines even more. So I'm going to let you go.
Well, good morning. I actually also want to add my thanks and say I am honored to be part of this symposium as well, and part of the launch of this new Solomon Center. Actually, Abby said this morning that some people think that health law is not a field, which I was astonished by, actually, but maybe we can talk about that later. I want to focus my remarks in 3 areas for the benefit of this panel. I want to start actually where Ben left off. I'm going to start with the outside in. What is the marketplace looking for out of healthcare and of health? And then use that to talk about how United Health Group has organized itself to meet the needs of the marketplace and diverse stakeholders. Since this is an academic symposium and a center, I wanted to actually suggest some questions in this space that might be worthy of study and analysis. And then I want to close with some personal reflections around cross-sector blurring. So, what is the marketplace looking for? I'm going to summarize. How many of you are health professionals or health policy people here in the audience? Good. So I can go quickly. All the estimates in the US that I've seen tend to converge that around 30% of all health spending is wasted in the US. It doesn't benefit the patient. And wherever you look, and we saw some examples last night from some of the work here, there are persistent, pervasive, and unexplained variations. Whether you look at the market, whether you look at providers, whether you look at health systems. So we have this kind of performance gap in healthcare that has been around a long time. And what we're seeing now, the marketplace says it's time to get at it. It's time to reduce those variations. It's time to drive the waste out. And then building on Ben's comment, the other thing that the marketplace is really asking for now, which is relatively new, is the demand by consumers for a different kind of an experience. And I agree with you. An experience, and that's driven by the fact that healthcare delivery and the health insurance sector, fair to say, that healthcare broadly has not been responsive to consumer preferences, needs, and wants. So fundamentally, what the marketplace is looking for is higher performance. And the triple aim is a good way to summarize that: better health, better care, lower costs. And the consumer and all stakeholders are looking for a more modern, intelligent, connected, and personal experience, like they get with Apple or Amazon or Zappos. So that's kind of what the marketplace is looking for broadly. So how has United Health Group responded to the needs of what we see the marketplace is asking for? And it goes back to our history. We're a large national payer, as many of you know. But early on, it was before my time actually, I've been with United Health for about 12 years, United Healthcare, the payer, recognized that in the course of analyzing and processing and paying claims, that there was intelligence that could be captured from that. The data could be turned into useful information to address issues of variation, to help inform the care delivery system, to work in a different way with other stakeholders and throughout the supply chain. And we made a very early decision that we were going to actually launch a separate business based on that. And that business was originally focused on data and analysis, completely separate from the health insurance benefit administration business of United Healthcare. They would sell to each other and so on, but these would be arm's length relationships. And over the years, that business has been now built out. It's called Optum, to be a diversified health services business. So now, when I talk about United Health Group, that's really a kind of a holding company label for two business platforms: United Healthcare, what we call our health benefits business, and then Optum, which is a diversified health services business that serves all the stakeholders in healthcare. And our mission is to help people live healthier lives and to help the healthcare system work better for everyone. And Optum is really the part of our business, of our enterprise, that focuses on the latter part of the business. It is payer agnostic, and it supports all the stakeholders in healthcare: consumers, hospitals, physicians, employers, other health plans, federal and state government, all the stakeholders. So it's not an extension of our payer business, of United Healthcare, but a separate business platform. And we've been very successful in launching that business, and it's the kind of an example of kind of creative, collaborative arrangements that Michael mentioned in his remarks. Northwell is a customer of Optum, as well as a partner with United Healthcare. Kaiser Permanente is a customer of Optum, even as Kaiser Permanente competes with United Healthcare in the health insurance business. So that's a kind of how we have decided to organize it. And that, I think, relates to this panel. What we think, and United Healthcare is not going to get into the provider business. We think that insurers like United Healthcare can support higher performance and a better experience by collaborating with high-performing care delivery systems and leveraging the collective expertise of both sides to achieve higher performance and a better consumer experience. And in turn, both payers and delivery systems can benefit from Optum's competencies in data and analytics, care management, and in connecting and aligning fragmented delivery systems. One of the key areas of performance improvement is the issue of fragmentation. Michael mentioned in his remarks, Ben has solved it in Kaiser by having everything under one roof. So that's how we have addressed this issue. And others may take some different approaches, but that leads to my second set of comments around questions that I think are worthy of study and analysis. My first question for all of you scholars is, how good can each model really get, actually? Kaiser Permanente, tightly integrated. I'm a big fan of Kaiser. I started my professional career at the Harvard Community Health Plan, a kind of Kaiser lookalike, which incidentally broke apart, unlike Kaiser, though Kaiser had some challenges along the way, too. But Kaiser has had challenges scaling up their model outside of their core market, and also has had challenges, and very driven by the HMO product, has also had challenges with what I would call product innovation. There are now ACOs some are led by legacy hospital-based systems like Michael's. Others are physician-driven. The physician-driven ACOs don't have the same issue as that hospitals having their legacy footprint. So which of these models will be superior, and what are the enabling market and regulatory conditions that will support innovation and success? And then the related question that I have, I'm really quite interested in, is around the promise of virtual integration. Does everything really have to be under one roof, or can you kind of stitch together virtual integration through technology, through data and analytics and arrangements that can achieve even higher levels of performance? So I think that's a really important policy and operational question. So in closing, let me close with my last personal reflection on this panel. Each side may look longingly at each other. Insurers may think, we can knock down this crazy variation that we see in care delivery and bring disciplined management to these clinical systems. I want to get into that business. And providers may think, why am I leaving all that margin on the table for the insurer? How difficult can it be to issue an ID card and pay claims? I want to get into that business. Kind of easy. Let me tell you, it's harder than it looks. Thank you very much.
I want to thank the organizers as well, and I thought it was interesting, at least the opening comments about a lot of talk about antitrust, and it brought back memories for me. I was a medical student and a law student here, and I used to kind of go sort of back and forth, do the medical school stuff and that first semester and then the law school stuff. But one semester I had a great idea. I was doing rotations over at the medical school, and I'll take a class. So I took antitrust, and I made it to the first class, but the experiment didn't go very well. I never made it back to another class except for the examination. So my knowledge of antitrust is very small, but fortunately, in that first class, they covered vertical and horizontal integration. So I don't believe there was a question on that in the exam, but so I would talk a little bit about sort of vertical and horizontal integration, at least from our perspective. I work for CVS Health, and most of you would know us from the retail pharmacies that we operate around the country. And for a short period of time, assuming that we get FTC approval for our purchase of the Target pharmacies before Walgreens gets approval of purchase of Rite Aid, we'll be the largest pharmacy retailer in the country. But that's only about half, or maybe a little bit less than half of the overall company. Another half of it, or close to that, is our pharmacy benefit management company, which we call Caremark. And we compete with a couple of other very big pharmacy benefit managers, including Optum, where Lou works. That part of the business is basically the managed care part of the business. So if you think about it from at least our narrow pharmacy view, we've got the providers, that is the retail pharmacies, and we also have a large insurer, which is the PBM. And I think I worked at Partners Healthcare in the Brigham and Women's Hospital for about 20 years, and then over at Aetna for nearly 5 years. So I have a kind of good view of the managed care opponents, that is, sort of the hospitals and providers and the insurance companies. And very simply put, if you're a provider, by and large, you make more money by doing more, by offering more to individual patients and doing more procedures and more tests and more visits. And if you're an insurer, you make more money by doing less. That is, making sure that only the care that's necessary is provided, following sort of evidence-based guidelines. And you can see how those two things are really at loggerheads with one another. And I think about the American healthcare system, the major metaphor is just the trench warfare between the people who are negotiating on behalf of the insurers versus the people who are negotiating on behalf of the doctors for rates. But if you bring those two together, you do develop different views. And I think the most important thing for us in terms of bringing together the retail pharmacies and the PBMs, they hated each other just as much as the providers hate the health insurers. But bringing them together, you do find a lot of places where there's collaboration and knowledge transfer. So in our retail pharmacies today, we're much better able to explain what's going on with trying to sort of how we go about on the PBM side, reducing healthcare costs by following evidence-based guidelines, and providing a series of services to our consumers that otherwise insurance companies have a real difficult time doing. We have about 8 million people who come in our stores every day, so we do have a good knowledge of what the consumer's expectations are and needs are. And then on the PBM side, you get a much better sense overall about the kinds of challenges that people are facing with their medications and the kinds of challenges that the distribution system overall is having from the point of view of the retail pharmacies. So I think that the integration, this vertical integration, has upped our game tremendously, both in terms of the kinds of services that we're providing through the PBM or the insurance side, as well as the programs that we're providing on retail. On the horizontal integration side, I would just say we're trying to basically sort of extend what we do throughout pharmacy. So we've recently finished buying the largest of the pharmacies that does long-term care facilities and skilled nursing facilities to better understand the continuum of care that's going on for our individual patients as they go out of a hospital and into a long-term care facility. We also just bought the largest home infusion company, and we operate the largest specialty pharmacy in the country. So with all those assets, we can actually sort of track what's going on with people across the entire continuum of healthcare, at least with regard to their pharmacy. Now, the horizontal part is that we are moving a little bit sort of towards the providers. We operate the largest group of retail clinics in the country. We call those Minute Clinics. Actually, my Minute Clinic team is down in D.C. today announcing a series of organizational structures and sort of rules of the road in terms of the way in which we operate with the American Association of Family Physicians at the National Press Club. So we've come to collaborate on our retail pharmacies very closely with primary care providers, understanding kind of what we can do as opposed to what the primary care provider can do. We're not, as skilled in terms of our medical knowledge, nurse practitioners and physician assistants, as the good primary care doctor is, but we do offer convenience, and we have very high satisfaction associated with the visits in those clinics. And the way I have sort of seen those things developing is something that the NHS in Britain went through in one of its major sort of changes that they then abandoned. It was a matter of putting sort of skilled nurses in the community who could address basically the lowest level of primary care. And that's kind of where we stay in terms of sort of counseling, acute care, moving into chronic care, but emphasizing evidence-based guidelines and really trying to sort of concentrate on some of the things that the healthcare system doesn't do well at all, especially around counseling on medications. For us, the biggest public health threat that we address, and also our biggest profit driver, is just that people don't take their medications. So combining all of these assets, we feel like we can effectuate change in behavior and get patients to be healthier and overall to sort of reduce costs. So I think that integration like that, whether vertical or horizontal, can be very beneficial for the healthcare system. And I certainly see that. Obviously, we work with people like North Shore, Long Island Jewish, and Kaiser in ways to sort of reach out to them so we can make sure that our information that we're gathering can be ported to them electronically using the electronic medical record. But I see in terms of what they're doing with regard to integration and the steps that United is taking, especially on the Optum side, is all good for the healthcare system, so long as we can convince the regulators that this is all pro-competitive rather than anti-competitive. So let me leave it there.
So I'll also say it's a real honor to be a part of this. I, even from afar, harbor a lot of enthusiasm for the Solomon Center. I have long been what I thought was Abby's biggest fan. I learned last night I have enormous competition for that role, but competition is good, right? That's part of the theme of today. One great benefit of the orientation of the Solomon Center, and one real attribute, enormously attractive attribute of Abby's perspective on the health world, is the value of interdisciplinarity and the value of different perspectives. And what you'll see today is fairly typical of the interdisciplinary conversation. You have people from industry talking about the enormous creativity and vitality and benefits of collaboration, of partnerships. We were told explicitly by Michael that things really aren't that bad, things are good. And then we get a panel of economists coming up next, and they say, actually, things are really that bad and probably worse than you think they are. And then you have a panel of antitrust enforcers who say, well, what are we supposed to do? We're supposed to decide what's pro-competitive or anti-competitive. Our tool is an injunction or a stick. We have to tell people they can't do certain things that we're being told that are going to be really attractive. And then I guess the last panel is usually policymakers from CMS who say, well, look, I think that Model A is better than Model B. Let's tell everybody to pursue Model A, or we'll add some more money to people who pursue Model A. And you have a conversation that on one hand is filled with angst. You know the stakes are high. We do know that we are spending more than we should be, and we're not getting the quality that we should be, and that is a national economic crisis. But you also really aren't sure what the next steps are, especially when you hear the kinds of terrific ideas that we've heard from this panel. And the policy instruments generally are either the antitrust enforcer that says you can't do that, or CMS that says you have to do this. And I think that the challenge is perhaps best illustrated by a conversation that Ben and I had before this panel. I told him about an article I always assign to my class at Duke. It documents Kaiser's effort to enter the North Carolina marketplace. And before saying anything more, Ben said, "Oi, we lost our shirts." And there are a lot of really interesting details to that autopsy. Why Kaiser had trouble signing up docs, why it had trouble signing up subscribers, why it was being crowded out by the hospitals. But the larger message is much more important. The healthcare marketplace in the United States is one where an attractive model, a Kaiser model that has proven to provide higher quality and lower costs, is not sweeping the marketplace. We have something about the way we have constructed our competitive system. We do not reward the party with a better mousetrap. And that's deeply, deeply frustrating. Now, to be sure, antitrust policy is part of a solution. We've got to make sure that in local markets there's adequate competition. We have to be very skeptical about collaborations that preclude competition. We have to be very skeptical about vertical integrations that, even if they do have some efficiencies, prevent entry and enshrine the current market structure. And to be sure, we have to think about how we reimburse providers, and we have to think about how CMS can think creatively about pay for performance and other sorts of payment models. But ultimately, we have to make sure that somehow or another, the better mousetrap is the one that wins the marketplace. And that, I think, requires a different kind of policy approach. Lou, I think, touched upon it when he said we have to figure out how we establish a regulatory and market structure where the better ideas out there are the ones that dominate the marketplace, or at least can get some kind of traction. And in that sense, I think we need to think a little bit more creatively than we have been. We need to think more beyond typical antitrust enforcement and beyond typical payment reform. We, with all due respect to the great ideas up here, have to be very careful about collaborations. that preclude the possibility of a new idea entering the marketplace. But we also have to think about the regulatory structure that sets the rules of the game. Think about how we regulate insurance, how we regulate providers, not just doctors, but also nurses, how we can perhaps use digital technologies to really create additional options for patients and consumers, and how we can think creatively about establishing new kinds of networks, including those that really transcend local geographic markets that really are dominated by a lot of monopolists. So with all that, I encourage the continued conversation to pursue creatively and to encounter every terrific idea with a healthy amount of skepticism.
So we'll happily take questions if you want to line up at the mic, but I figure that a good launch point is Professor Richmond's point about Kaiser, and why is it that the Kaiser model isn't so easily exportable, explainable? I mean, we've seen many experiments, and I think you can talk individually about them, but are we at a different point in time right now where the Kaiser model could be used in other parts of the country and expanded?
You know, I think that one of the biggest problems, so I think what Barack was referring to is in the 90s, we tried to expand into the New York market, North Carolina, we expanded into Texas and Kansas City, and really lost a lot of money in all of those endeavors, because we tried to take a model that was very much a group medical model, and we tried to move into a market with a network approach. So instead of the traditional, group model where you have a really cohesive medical group trying to drive care and services, we just had contracts with people that you adhered to a protocol or not, it didn't really matter. And we didn't have the mechanisms to try to culturally bring those doctors together and to bring those hospitals together. So I think that's actually a very important point. Unless you have the will of physicians and systems delivery system to come together and actually do some of the things that Michael was talking about, really figure out how to be consumer oriented and distribute the care in the settings that really make sense for people, and you can bring yourself to downplay the fee-for-service incentives to just optimize everything to you, you're going to have trouble doing this.
Just to follow up, I mean, so much, change is so much about culture. And, if you look at the New York market back 10 years ago, when we started to create a group model, we have a large medical group model today, where you're dealing with a mom and pop physician environment out there, 2 docs in a group, 1 doc in a group, all educated with the concept of autonomy. I mean, medical education is essentially taught people, you're in a little silo, you'll graduate from here, specialize in it narrowly, put up your shingle, and you're autonomous. You are in charge. Now you go to any of these individuals and say, by the way, you should share. You should work together. There should be interdisciplinary work. There should be a concern and a respect for nursing and work across professions. Unless you're actually on the ground trying to do this, you have no idea how hard it is. From an intellectual, academic perspective, it seems like, well, that's nice, just put it together. Well, it doesn't work like that. And going back to something Barack said, one of the frustrations increasingly is that, regulation, I'm not against regulation. I spent 12 years in government, so I was a regulator at one time. But it has got so much, it is now, thousands of regulations. So it's very, very hard to be innovative and creative in a culture of compliance and a culture a regulatory culture that is oppressive because it forces standardization and not allowing the creativity that you need to have to be able to move in a different direction. So, I mean, I'm a big fan of Kaiser, and if you were to ask me, when people ask me what would I like to create in New York, we're the biggest provider in New York. We've got 14,000 docs. I mean, it's not easy to manage 14,000 physicians. Our hard to work with 14,000 physicians. In fact, sometimes it's hard to work with one. And I know we have physicians in the room, and I have high respect for physicians. I spend all my time with them. But to try to move into the New York market with a Kaiser idea, it's probably possible. It takes a long time. And also remember one other thing. Kaiser has been doing this since the 1940s. Long history. Where we are today in a place that it would have been hard to imagine we would ever have been if you were in our location 15 years ago. Takes time. And everybody, and we're getting into this problem with the Accountable Care Act. Everybody wants quick results. You pass something, a month later or a year later, they do this study saying it has succeeded. Well, nothing has yet fully succeeded. We just need the time to get to the end goal here.
Question there.
Hi, my name is Ashley Hopkins. I manage the federal quality incentive programs for a large academic health system. But before I did that, I worked for an insurance company. And the biggest difference between the two is that insurance companies know more about the health system's population than the health system knows about its own population. So my question is, in moving from being a provider to a provider and a payer, what can you do now that you couldn't do before, now that you supposedly have actionable data?
Well, in our insurance company is relatively young, right? And we're the only one in the New York area, and everybody thought we were crazy when we did it. One of the things, just one thing, we have data. We have information. We know more about what's going on. We contract with other insurers. They have the data that I need to be able to manage the care, but I don't have that data. They have it. Now, that over time will change, I think, because with partnerships, you will get to cross that barrier. And between payer and provider, it has been quite confrontational over the years. And I think more and more we're beginning to develop, relationships where there'll be a lot more sharing. But having an insurance entity teaches you how to do care management better.
Right.
You have the data. It forces you. One of the reasons I started our insurance company is to force a cultural change across our organization, that we had to be a lot more concerned about keeping people well than just having people get ill and only get reimbursed for episodic care. So it forces a cultural shift, and it provides us the information. We created a major care management entity inside our organization because we have the insurance company. Because remember, one of the things people don't fully understand, for decades and decades together, you got paid for a unit of service only after a person got sick. That was the business model. And everybody would say, why don't you try to keep people well? There's no reimbursement to do this. So that goes, the move away from fee-for-service gradually over time, I think will accommodate this. Having capitation like Ben has is a wonderful idea if you have the structures and the tools and the talent and the skills inside to figure out what to do with all of that data and that information when you have, and that takes time as well. At least one last thing, and then I'll stop. As healthcare evolves over the next decade or two, we will need a different level of leadership, different level of skill and talent. You cannot move into the new world with the way we educate people in the old. And most educational institutions educate people for the old, not for the new. That's why we have got into the education business big time, including starting a nursing school. So, and the leadership requirements, especially when you're in the digital world, when the consumer will be increasingly king, when there'll be more transparency. The idea of transparency in a traditional hospital is like, what do you mean I'm transparent? I hear doctors say, I don't want to be transparent. I know everything. I'm the guy that knows everything about my patient, but the patient doesn't know everything. So it's a whole cultural shift. And it's been a great benefit. Now, how successful it will be, I don't know. It's small, it's big, it's tough business. Insurance is a tough business. Lou is right, it's a really tough business, but I'm not afraid to fail in the process of trying to become successful.
Can I ask just a quick question about that? So clearly, the access and possession and use of data is going to become increasingly important in providing value to patients, and also actually in creating value from that delivery system. But also, it can be a source of enshrining market power. So I was curious if, in the effort to accumulate data and figure out how to use it, if there also would be a commitment to make that publicly available in order to make sure that we facilitate competition in the marketplace.
Oh, I think more and more you'll have much more public transparency in this area, big time. I mean, we are very transparent with our metrics and our quality metrics and our service metrics. We were the first in the New York area to put everything on a public website. I'm all for the transparency. The key with having all the data, and Ben can answer this better than I because he's been at it a longer time, and Louis here can answer it better than I. You need the skill to figure out how to analyze all the data you've got. Data in itself doesn't do anything unless you can figure out how to turn it into information. And you can die with data, but you need to know how to get the analytic ability is key. We don't have that yet.
Yeah,
These guys have it.
I would completely agree with that. And what we've seen, we have in our collaborative, United Healthcare's collaborative arrangements with ACOs around the country, one of the key value adds is not only the sharing of the data, but also an approach to analysis, because you're absolutely right. And what I see sometimes in fledgling ACOs is they kind of don't know, they may have the raw information, but they don't quite know how to turn it into useful information that can have an impact. And then I think the trend is for broad open transparency. Some of you may have seen last night analysis out of the Healthcare Cost Institute. We were early proponents of the idea of taking claim data, not only from us, but also from other payers, and essentially turning it into a public good, turning it into a resource that could be used by analysts, by researchers, and to augment, since so much of the policy world in terms of cost trends was driven by Medicare data, we thought there was a gap in truly what was happening in the private marketplace. So a vehicle like HCCI is, we thought, is a public good. Optum itself engages in a collaboration called Optum Labs with a variety of partners to take de-identified data, claim and clinical data. The Mayo Clinic was a founding partner. A number of academic institutions collaborate. So I just think the trend is going to be towards transparency. But having said that, there may be some actors that view their data as proprietary and as a resource.
I would just say I think data is really important, and we love to talk about data till we're blue in the face. But it's easy, kind of. I think the answer to your real question is that Michael's currently got doctors who are prescribing. We talked about high-priced medications. Prescribing high-priced medications, they make more money in a fee-for-service world when they prescribe high-priced medications because, by and large, with those specialty medications, they have an arbitrage associated with it. They go at risk, they're in the same pool in a capitated payment like Ben's doctors are. What they're going to do is use equivalent, every bit as effective, inexpensive medications. So, the simple thing is the shift in economic incentives. And when you shift those economic incentives, presumably what you should see is move to a more efficient healthcare system.
So kind of along those same lines, I'm Alex Rich, I'm a healthcare management student, and I had a great conversation with a friend the other day about her move to Texas and the development of a passionate love affair with biscuits and gravy for breakfast. She was able to tell me what that did to her cholesterol level, and I thought about it, and in 10 years of being a pilot and having mandated healthcare stuff every year, I had no idea about my cholesterol, but I could look down every day and see what my engines were doing. And every gauge had a green and a yellow and a red area, and so I could see what was going on, and that influenced my behavior in the airplane. I've got no equivalent inside healthcare. So inside a capitated environment where these things would be advantageous, are you doing anything to open up transparency to the patient, some kind of dashboard?
Yeah. I think the new electronic health records with patient portals enable that. And actually, we post a lot of that data for our members on the portal. But it's not just posting it, right? Because it's one thing to have that information. It's what do you actually do with it? How do you actually work with our members to actually try to optimize the opportunities that the data presents? And that, I think, is something that we are constantly trying to work with. How do you shape the data? How do you leverage the power of the large health system? How do you use different tools, the new digital tools perhaps, to actually get people and give them a sense of what they could be doing that would lead to a healthier outcome. And that, I think, is the real challenge. It's not just about dumping data. By the way, it's data that has to be real-time and actionable, right? So I mean, I think claims data can give you a lot of insights, but there's nothing like merging the claims data with the clinical data and then really looking at it on a daily basis to shape, some strategies to actually get to better outcomes. So, absolutely.
You raise an issue that we need to talk an awful lot more about, and that's lifestyle behavior issues, which are the primary determinants of ill health to begin with. And this is the disconnect of where medical care and health are not the same. Medical care is a piece of it, but it's not the whole thing. But just one comment, it will not be too long before you'll be wearing a device, a digital device attached to you'll have on you that will be able to detect the kinds of intake that you with food. If you just imagine all of the digital mobile units, things that are going on today, and all the wearables, it'll be phenomenal what will happen in the long run. The question is whether or not people will comply with it.
Shock you if he's in bed. I'll shock you if he's in
Yeah,
bed.
I mean, yeah, it's like putting the collar around the dog. The dog goes over the thing, he gets a shock. We can do something like that. You eat bacon, you get a shock. You have everybody in the restaurant going like this. But it's not beyond the bounds of possibility here at all.
I don't want to be contrarian about it, but I think there's a lot of promise out there, but the depth of human irrationality is incredible.
Yes.
The patients who are being released from Yale New Haven Hospital today after having a heart attack, if they take 4 medications for the next year, they'll reduce their chances of having a second heart attack by 80% and their chances of developing congestive heart failure by 90%. Yet, at 6 months, only half of them are simply taking their medications. So I think, the lab companies, Theranos is the one that people know best, but a number of other lab companies, their drive is to get these devices in the home and, provide more and more empowerment for individual consumers. And I think that's a great thing. But I think we just have to recognize that we have a lot of work to do to get people to do relatively simple things to take care of their health.
That raises the question is if you want to talk about health reform, some of the reform will really occur when people start taking responsibility for themselves.
Actually, I think the business opportunity is to make the better biscuit.
Thank you very much for being here. My name is Dan Levis. I'm a student at the School of Management. I think one of the great things about this panel is that you represent both traditional healthcare providers, traditional payers, and then also new entrants into the healthcare market. And I want to ask a question about these entrants, because I think one of the most interesting things happening today is that you see lots of new entrants, particularly consumer-focused ones that are effectively trying to disintermediate traditional payers and providers. So something like an IORA that's saying we can do primary care in a different and better way, or something like Oscar saying we can do insurance in a better way. Or to me, even more significantly, a company like Teladoc or Pager or Heal that's saying we can provide services to consumers in a much more accessible, convenient way. And I'm curious, as incumbents in healthcare, as these entrants are coming in, what's your take on them? Do they frighten you? Do you think that you're just going to start offering these services and they'll fade away?
Yeah, I'll talk about that for a moment. I actually like all of these ideas. I really think that we sort of comb those ideas for for things that we could be doing. I think that the problem with being so big is that you sometimes get cumbersome, and it's really hard to be nimble and do things quickly. But Teladoc is a great example. And just last week, actually, we put into place a Teladoc-like service for our members that it's actually much more comprehensive, and it's for our members, so there's no additional payment stream, but on a variety of conditions they can get a doctor on the phone, or by the end of the year, by the middle of next year, they'll be able to actually do it on their telephones. We can actually do a video visit for people with reasonable, so you can eyeball what the conditions are and then make the triage decision going forward. I think these are really great innovations that we're in peril if we don't pay attention to what the consumers are looking for and how it could make it much more convenient.
I'd like to add to Ben's comment. It's a really important question, and since it's a regulatory policy audience, there are two stories I'd like to tell. First one, I was on a panel at Stanford with a group of entrepreneurs who were trying to get into the health space, and there were 4 of them 3 of them said, I think there's a great opportunity, but the regulatory barriers are so insurmountable. I'm going to pivot and do games instead. And the 4th said, the only way I can deal with this is this was a social media platform. I'm just going to have to become a HIPAA-compliant social media platform and deal with HIPAA. So I think one of the issues really is the regulatory barriers to innovation, and I think there's a lot of dynamism potentially, and telehealth is one of them, that in many markets around the country, telehealth is having significant challenges because of issues relating to state boards of medicine and what rules and regulations they promulgate. And so I just think this whole area is another area for further evaluation, analysis, and potential innovation on regulation.
I just welcome all of these new ideas. I actually encourage it. I think it's fantastic. And in fact, inside our own organization, we've created a large ventures group. So we try to, you go to our docs and our nurses, they come up with unbelievably innovative ideas. We try to make businesses out of those and try to create this, a lab of innovation inside your organization. So I think it's fantastic. And just one thing following up on what just said, most of the people who regulate live in the old world. I spent 12 years in government, and you have CON states, and it was mentioned earlier, and it's all about protecting what was, not as much about opening up the doors to new innovation. And while regulation is important, if it is moving you forward, but not if it is keeping you standing still. And it's a real frustration for those of us that want to be creative all the time. I see myself as an entrepreneur. I like to be disruptive and creative. I like to have the opportunity to fail. But because success is built on the back of failure, remember. You've got to try things, it doesn't work, you try again, you keep moving. But when you can move forward, and I've had numerous instances recently that things that I want to do that I just can't do. Then you got one side of government telling you go do it, coordinate. Then you got the other guy of government says, you better never sit with these people and coordinate. So it's a whole, complex area, and it's not playing victim. It is, though, a frustration for those people who want to move forward and be quite innovative. You've got to break with tradition.
So this is terrific. So I think the Solomon Center can, in addition to having these conversations, start fostering political coalitions to lead these changes. Because it is true, the best way, the greatest possibilities of bringing value to the healthcare system come from the software engineers who are working in their basements, but they need data. They need to be able to manage the regulatory environment that's currently dominated by the professions. And it's going to take a political coalition to change that. So maybe this is the beginning of that.
So I'd like to make a comment and then ask a question. The comment is that at the start of the day, we heard from the Justice Department people that competition was going to drive value. But in this country, we've had competition sort of as the premise of our health system since the Second World War. And we've ended up with a really expensive system which doesn't deliver very good quality. So I don't think it's quite as simple as that. We need regulators to sort of manage the competition. And I like to sort of pick up a little bit on what I think Barack was trying to say that the emperor has no clothes if we think we're just going to get value out of competition. Now, the question is, I'm a primary care doctor. I hear people from insurance companies tell me about how important they think what I do is. But in some ways, Michael, you like to be a hammer, not a nail. I feel like a nail most of the time, being kind of told by everybody what to do. And I think providers are voting with their feet by not going into primary care. So the question is, what can we really do to support primary care if you really think it's a valuable enterprise in our healthcare system?
Well, you take the second part, then I'll take the first part.
Okay, whatever. I've always believed, I mean, we're big into the primary care area, but I believe that a big part of it is money as well. The reimbursement over the years has always benefited more the people on the specialty side than the primary care side. A lot of policymakers talk an awful lot about primary care. If you're in New York State and you want to take the lower income people, for example, in the primary world, you don't get paid enough for it. You just lose your shot by doing it. That's a real problem. When you get into a capitated environment, or a company like ours take more and more risk, there's all the benefit in the world economically and healthcare-wise to be able to invest much more on the primary care side than on the specialty side, because you're trying to keep people out of expensive hospitals and you're trying to keep people well. So I think a lot of this innovation that's occurring with the LAR system at the moment is moving in that direction. The other thing, and this is complicated, hard to discuss in about a minute, I am a very firm believer that we got to allow doctors have a lot more say. They can't be double-checked every time they do something. And there are insurers, and we fight with these insurers all the time, where a doctor makes a decision about a patient, his clinical knowledge is reassessed by somebody who never met with the patient, never saw the patient, is not near the patient, has no responsibility if something happens to the patient. But if the doctor doesn't do the right thing or the health system doesn't do the right thing, they're the ones that are slapped with the lawsuits, not the insurer on the other side. And our insurers are terrible at this. We fight with them all the time. We have issues going on currently at the moment. It's this balance between following evidence-based principles, but also allowing the freedom for the doctor to make decisions about a patient when the patient is standing in front of them and not be second-guessed all the time. I don't know exactly how to get there yet, but I am in complete favor with some of the docs that get completely frustrated. It's like, I mean, if a plumber comes to my house and he decides that he wants to put in a new toilet, I don't have to call somebody in Minnesota. I'm not necessarily picking on you, right? I'm not really picking on you. Let's say Washington, to say, by the way, you can't put the new toilet in, you can only put a second one in, or you should fix the pipe underneath. It gets a little bit ridiculous on a day-to-day basis. But there's a multi answer to this. But I concur with the essence of what you're talking about.
I'll just say very briefly, I don't want to preempt the next panel or the panel after that, but in spite of the best efforts of many antitrust enforcers, there has not been a very effective antitrust policy. We have not, as a nation, done a very good job of maintaining the possibility of meaningful competition, especially among providers in local hospital markets. And there's an abundance of evidence that when there is competition, you have lower prices. When there's less competition, there's higher prices. And when there's less competition and prices are held constant, more competition means better quality. So you have an abundance of empirical evidence. And I think that if you look at the last 30 years, especially from 1980 to, say, 2000, you do not see an effective pro-competition policy.
Can I just make one last point? I'm sorry. One last point. Issue on quality. One of my dreams is that the regulators, primarily Medicare is a big driver here, picks 5 or 6 quality metrics, and that every day, but we make uniform, and they say these are the metrics that we are going to have you be accountable for. We get hundreds and hundreds and hundreds of metrics. No human way possible can you actually manage an organization when you get 20 new stupid metrics every month, half of them ridiculous and dumb. So, for example, let me give you one. Set as a goal that we, the provider world and the insurance world, working together, have to reduce sepsis, the incidence of sepsis, to 0, let's say, of some percentage over the next 5 years. If we all did that one thing, which is doable, we'd make a phenomenal change in healthcare outcomes, including mortality. Instead of that, we have the list of metrics that come out from Medicare would stretch from here to the wall. Listen, the person on the floor, or the doctor on the office, you can't, it's just impossible. There's an industry, there's a metric industry that is being created, and they benefit by putting out new crap all the time. Oh, yeah. I'm not passionate about this.
The only thing I would say about primary care is that, it's not easy to be a primary care physician anymore, right? Because your inbox is totally crowded. you have all these metrics you have to meet, and really there's not enough time in the day to actually do it. So, and I know California is very different than large parts of the country, but some of the things that we do is we really build systems to support primary care and have other caregivers actually do a lot of that work. In addition to that, by the way, we recently actually increased the salaries of primary care doctors by about $40,000 a year because, the market's tightening for our primary care doctors. So I think, it depends. And I'm a big believer in larger group practices because you can shield and build systems to help the plight of the doctors, particularly the primary care doctors, if you were to do that.
There's no final comments from here. I want to thank the panel, which has been fantastic and engaged. Really appreciate that. And there's coffee and snacks during the break right now. 15 more minutes, come back.
I think the main thing is
if it doesn't revive.
Oh, there you go.
Okay, exactly right.
Got it. All right, everybody, let's get started with our second panel. Wonderful. All right. Well, thanks everybody for coming. This is our second panel looking at horizontal integration. So thinking about what happens when firms come together. And there have been some pretty remarkable changes in the healthcare landscape over the last decade. If we look at the insurance side, we're seeing mergers between Aetna and Humana, Anthem and Signum that potentially will take the insurance market from having 5 big players down to having 3. If we look at the hospital space, we've seen 200 deals go through over the last year. That's more than double what we saw a decade ago. If we look on the side of pharmacies, we're now seeing the 2 big chains operating with approximately 50% of the market. And this raises some questions. Why is this happening? Who benefits from these transactions? Are patients worse off? Are we paying more? How does this affect innovation? And we really could not have a better panel to discuss these issues. So I'm going to introduce them briefly, and then they're each going to take a second to give an opening address, and then we'll open it up. We'll have a conversation, then take out questions from the floor. So Marty Gaynor. Marty is the E.J. Barone Professor of Economics and Healthcare Policy at Carnegie Mellon University. He's the former director of the Bureau of Economic Analysis at the Federal Trade Commission. We've got Limor Daphne. Limor is a professor of strategy at the Kellogg School of Management at Northwestern University. Her research examines competition in the insurance market. In 2012 to 2013, she served as deputy director for healthcare and antitrust at the Bureau of Economic Analysis at the FTC. Peter Muccetti is the chief of Litigation 1 section of the Antitrust Division of the U.S. Department of Justice, which investigates and prosecutes civil cases for healthcare, paper, food products, and other industries. He's also a graduate of Yale Law School. Alex Azar is the president of Lilly. In addition, previously he served in government as the deputy secretary of the Department of Health and Human Services. Prior to that, he was the general counsel at HHS. And then Tim Greeny, who's the Chester A. Myers Professor of Law and the co-director of the Center for Health Law Studies at St. Louis University School of Law. Before joining the law school there, he served as an assistant chief in the Department of Justice's Antitrust Division, supervising healthcare antitrust litigation. And so we couldn't ask for a better panel to discuss these issues. So Alex, you'll kick it off.
Well, Zach, thank you very much. I'm neither an economist nor an antitrust expert, so I don't know what the devil I'm doing on this panel, so I hope you'll forgive me. And I don't have Troy Brennan's excuse, because I actually did take antitrust law here, and I actually did attend class, and still the most frequent thing I ask is, let's see what the antitrust lawyers have to say about that. But maybe I can give a little bit of a real-world perspective from sitting on the inside of the intersection, frankly, of every one of these players of what's going on from a business perspective. So I wanted to cover 3 topics quickly today in opening. The first is how market and government forces are driving the trend of consolidation with a particular focus on the Affordable Care Act and its impacts. The second is how these trends are changing the business models of 2 of our industry's biggest customer groups, payers and healthcare providers. And the third is how our industry is adjusting to those customers' evolving business models to create better value for them. Abby asked me, though, to start out by talking a little bit about pharmaceutical and biotech company consolidation that is going on. I don't really find that topic too interesting, so I'm not going to say much about it, because, to be honest, it's scale and cost cutting. That's what it's acquiring growth, and it's scale and cost cutting. Very few have demonstrated the ability through large-scale M&A in the pharmaceutical business that you actually enhance the R&D engine that's the value creation model long-term in our business. And it's really just about if you can aggregate your businesses, cut costs as a result of aggregating that, but it doesn't lead to better R&D. In fact, it's pretty disruptive of the R&D model, as we've seen from many of the consolidations that have happened. And in terms of respective market power of pharmaceutical companies in this matrix that we're going to be talking about today of providers, healthcare plans, PBMs, the actual size of the pharmaceutical company is not terribly relevant. Your brands are more relevant because you really deal with PBMs and healthcare plans on a brand-by-brand basis, not whether you're a $200 billion company or a $10 billion company isn't really terribly relevant to them or to you. So now let me turn to two areas that I do think are pretty interesting, which is areas where I think the Affordable Care Act has been a very relevant driving factor in consolidation, and that's among providers and payers. So first, with respect to providers, you'll see on this chart that it's very important to keep in mind that providers' margins are relatively quite low, well below 8% generally, as you'll see on this chart. It's a tough business that they're in. And if you look on the right-hand side of this, you'll see just one of the impacts alone, just calling out one aspect, which is health IT requirements and health IT investment that's required. I mean, look at the size and scale of the investment required from a health IT perspective just to be in the provider business and comply with electronic health record requirements. In addition to the fact that you have margins in the provider base that are often less than 8%, have increasing cost requirements, you now have up to 9% of a provider's reimbursements are now going to be subject to effectively reduction if they don't comply with various government mandates, meaningful use, hospital-acquired condition penalties, the 30-day readmit reduction program, and then the newer hospital value-based purchasing program. So by 2017, 9% greater than their entire margin is now at risk based on compliance with these requirements. Then you look at the recently passed replacement of the sustainable growth rate. So on the physician side, again, by 2022, 9% of physician reimbursements are put at risk based on compliance with various requirements there. So again, margin compression happening there. So what do we see happening? We see, as a result, hospitals reacting to this margin compression by doing what one would do, which is horizontal consolidation so that you can lower your overhead and acquire more patients, acquire growth, as well as vertical integration, because as you have all of these various mandates and quality requirements on you that now put 9% of your business, your margin at risk there, or 9% of your total business at risk, you want that vertical integration so you control the outcomes better. You're being held accountable for the outcomes, and you say, okay, I don't just want the acute part of it, I actually need the primary care physicians. I need everyone built up there so I control the entire impact on the person through the system. So you get much more of a cradle-to-grave vertical coordination of care from their perspective. Another thing that's going on, I think this is a bit more less altruistic aspect of consolidation, are various payment issues. For instance, the 340B program, it's been documented by Avalere Health, is a major impetus to hospital vertical integration. So hospitals basically acquiring physicians so that they can move site of care into the outpatient setting so they can get access to 340B prices there. That's why there's almost no such thing left in the United States since the Affordable Care Act of the private practice oncology practice, because they've been bought up to take advantage of 340B. I think that's an issue we have to look at, honestly, in our system. You see then not just the hospitals getting together, and as I mentioned, you get the vertical integration that includes physicians being incorporated into these hospitals and integrated systems. So in addition to site of care differential reimbursement and just the revenue issues associated with that, there are two other factors that I think are driving this vertical integration. The first one is just cost infrastructure. So I showed you the IT commitment of the hospital systems. Well, the IT commitments of the practice are very similar. And so the IT, the quality reporting requirements that we just heard about on the previous panel, it is very hard now to contemplate the idea of going out of medical school and putting up your shingle and having to build the infrastructure to comply with all of these requirements. The second is, frankly, a demographic mentality shift that's occurring among people coming out of medical school. You're seeing folks coming out of medical school now who do not have that same entrepreneurial spirit, who want to build their own practice, own real estate, their medical offices, et cetera. You see folks coming out now looking more for often a 9-to-5, 5-day-a-week, ownership model, predictability, and they actually want that systemic way of practicing, want to be part of that approach. So there's a ripple effect, of course, to this consolidation. So you get the provider consolidation, the horizontal and vertical at the provider levels, and the payers then say, well, I need to deal with this market concentration in local markets. So the payers feel the need that they've got to leverage better negotiating power against these locally powerful systems. They face, of course, their own margin compression coming out of the Affordable Care Act due to requirements such as community rating, MLR profit controls, and increased exchange-based insurance business, which is unbelievably cost-sensitive, as well as, of course, since the recession, employers have become incredibly cost-sensitive on their purchasing of their insurance, and so a lot of demands on the payers to bring their cost basis down through consolidation, but also increase their power as a negotiator against local provider concentration. You're seeing, of course, similar consolidation on the PBM side there also. So the effect of this consolidation on my industry is incredibly significant. 10 years ago, 40 payers accounted for 80% of U.S. covered lives. Today, only 8 payers will account for 80% of lives in the United States, assuming that the Aetna, Humana, Anthem, Cigna deals are approved. So this consolidation at the payer level, at the provider level, it's definitely creating margin compression and challenges for the biopharmaceutical industry. So what do we do in reaction? What can we do in response to this? Well, we know in part we've got to meet our customers where they are. We've got to look at how they're organizing themselves and start figuring out what their needs are. So part of this is, from the payer perspective, we've got to develop better real-world evidence, health outcomes data, so that we can establish the value proposition of our existing and new medicines to them to meet their demands of what they're trying to do of cost effectiveness. For health systems, we've got to build up our account management, we've got to build up our medical support for consolidated systems. We've got to basically create a value proposition that is a pull model where they want to be working with us and seeing us, rather than the old style push model of trying to push information and education, but rather, what do they need? How do we connect with them on their terms, the way they want to connect with us? And then from a patient and provider's perspective, how do we offer reimbursement support, hub services, one-stop shopping, a kind of envelopment for the patient to make this very difficult process a better, easier process for them as they navigate through that system. So all of this is focused on how do we enhance the value proposition of our medicines for our customers. And then finally, this one shows just a sense of how integrated everything's getting at the systemic level, with payers now owning providers, the IHS integrated hospital systems, with the D-suite people that are making formulary decisions, specialty pharmacy connected into the payers, physician group, D-suite leadership now making formulary decisions and pathway decisions that drive physicians being consolidated, having their own formularies and pathways underneath them. So all of which says that I think we as an industry have to organize ourselves much more around these localized systems that are all, I mean, I've actually calculated over 92 different actual regional systems in the country, regional markets, very few of which are alike in any way. So we need to organize ourselves around how these integrated systems are becoming even more organized. So thank you very much, and look forward to Q&A.
Fantastic. I'm Limor Daphne, and I want to start by thanking the Solomon Center for putting together this fantastic conference, and Professors Gluck and Scott Morton for inviting me to participate. It has been a very interesting experience so far, and I'm looking forward to the rest of the day. So my role today is to talk about consolidation in U.S. health insurance markets, and there will be 3 of us who will touch on these issues on the panel. So my job is to do 2 things. First of all, set it up, give you some basic facts, and then second, to play that role of dour economist that was foreshadowed by the previous panel, that things are bad and they're even worse than you think. So let me get on with it. Let me start out by telling you why it's such an important sector. If you didn't know already, 2 out of 3 non-elderly Americans have private health insurance, and the statistics in the chart over there are actually pretty hard to come by. They're my rough estimates, but what you can see is that more than 70% of the market, of the privately insured non-elderly market, receives insurance through large employer groups. Okay? Now, these figures do not count public insurance programs that rely on private health plans to deliver benefits to enrollees. So these are things like Medicare Advantage and managed care. Collectively, think another 70 million people. Okay? Very, very important industry, one. Then second is it's incredibly expensive. So the latest figures from the Kaiser Family Foundation find that the premium for a family of 4 now exceeds 16 grand per year, and deductibles are up, and out-of-pocket co-payments are up. So this is an almost car that our families are buying every single year, and we have to buy it. Okay, so it's mandated. If you don't have public insurance coverage, if you read the paper for the last 5 years, you have to have private insurance coverage, and the federal government is subsidizing the purchase of that coverage to the tune of $37 billion in 2015 for the low income. So bottom line is, it's an incredibly important industry. It's the kind of industry in which there is a significant public interest for it to be competitive and robust and vibrant. So let me tell you what our industry looks like in terms of the supply side. These figures are also hard to come by. They involve a whole lot of annual reports and our best efforts to try to limit the sample to just commercial lives, so take them with a grain of salt. But what this graph shows you is what's called the 4-firm concentration ratio. That is the sum of the market shares for the 4 largest firms, and here I'm taking the entire nation as a whole. I'm not saying that's a relevant antitrust market, but just to get a lay of the land. And what can you see from this? Well, first of all, notice all the blue. Okay, the blue, that represents Blue Cross and Blue Shield, and the hash marks is also Blue Cross and Blue Shield affiliates, but those that are aggregated under Anthem, which owns the companies that have all of the for-profit blues. And you can see that Blue Cross is the dominant player in our health insurance sector. They are the market leader in 46 of 50 states, okay, and they have well in excess of 50% share of commercial non-elderly health insurance nationwide. Second point to take away is those numbers are climbing up over time. Okay? And we're now at 83% for the 4 top carriers. If you want something to compare it to, you might consider the airline industry. Okay? Also not a case where there's a big national market. There are local routes and markets, and insurance is purchased for many locally. But that 4-firm concentration ratio is 62%. Okay? Yes. All right, this is just for fun. I'll leave it on for a moment. Of course, many health insurance markets are local and even smaller than the state level, most typically at the metropolitan statistical area level and then outside the MSAs within a state, but data is very hard to come by, and if I have time at the end, I'll make a plea for more data, as I did when testifying to the Senate recently. But the best we could do with the data that we have is graphed here, and you can, and the takeaway here is the darkest red represents the most concentrated markets, okay? And 61% of the U.S. population lives in a state where the fully insured market would be considered highly concentrated, which is the standard set by the Department of Justice and the Federal Trade Commission when they consider whether a transaction, a merger going forward, is going to be presumptively anti-competitive. Okay, you might ask, how did this all happen? And lacking the time to tell you a whole lot of stories, let me just summarize what is really in bold. Well, mergers and acquisitions happened. Okay? And that was in part because of the backlash against the HMOs. So the HMOs were struggling, faltering. They were acquired by larger players that had PPO presences, and we saw growth in the PPO sector. There were provider systems that had health plans. Those folded largely and sold out to the bigger ones as well. Regional insurers wanted to get bigger and then become national. And there was limited entry because there are significant barriers to entry, as we'll hear from panelist Greenie as well. The antitrust enforcers generally didn't object, notwithstanding what we heard from Assistant Attorney General Baer this morning. Most of these mergers, they really went through. And small divestitures were required in some cases, but most markets were thought to have enough sizable insurers. And I tell you, when I started studying this industry shortly after becoming an assistant professor, people in the industry said to me, I can't believe you're interested in this. The insurance market is so competitive. It is cutthroat, and you're going to find nothing. That didn't pan out. Okay. So what? So it's a big industry, so it's consolidating. Maybe bigger is better. It certainly could be. And I've got 3 minutes, so I won't take more than one on each of these. Well, what's the impact on costs? So-called merger efficiencies, and we'll set aside whether they're cognizable for antitrust purposes. There is no empirical refereed evidence on the relationship between insurers, scale, and administrative costs. One, there's got to be some minimum efficient scale. We just don't know what it is. Two, there is some evidence that when insurers get bigger, they pay hospitals and doctors less, but there is no evidence that that gets passed through to consumers, which brings me to the second point, the impact on premiums. There is significant evidence, and I've listed all of the markets in which economists have studied this question. There's evidence that when you have a reduction in the number of insurers competing or an increase in market concentration, that we see premiums go up. Okay? So the past does not bode well for consumers looking forward in terms of these mergers. But the last one is the unknown one. This is the exciting one. What about the impact on quality and innovation? Perhaps if these insurers merge, they will be able to develop new collaborations with providers and innovative new product designs, and that it's scale that is holding them back. That is the vague argument that we read about. But there's no research on that. So I couldn't resist doing some for this panel in this fall. And so here's what I have for you. The main innovation here, I'll hold off for a minute. The main innovation in insurance markets of late is the creation of narrow networks, which is selective contracting. So you only have a certain set of hospitals or a certain set of doctors included in your health plan. I have to say that if that is innovation, it's a little disappointing, okay? But that is the main big exciting thing that's happening. Now, how narrow your networks are for hospitals is going to depend a lot on the market power of the provider systems. You may have, as an insurer, great difficulty constructing a narrow network if you can't leave out a lot of these systems. And then there's also state regulations. So let's not look at hospital systems. Let's look at the narrowness of physician networks. An insurer ought to be able to construct a high-value physician network where the physicians are working together and following their protocols, streamlined patient care, and so forth. You might see more innovation in physician network breadth in markets where the insurers had larger scale if you thought it was scale that was holding them back because of the significant costs, say, associated with implementing such plans. So this data on physician network breadth came out from Penn in the fall. They gathered information on the fraction of physicians covered by every single network that was offered in every individual exchange plan. Okay? And we constructed a measure for the standard deviation of that variation at the state level. And here it is, a simple correlation between that on the y-axis and on the x-axis market concentration. Okay? Slopes down. What does that mean? As markets become more concentrated, you see less, not more, variation in the kinds of products that are being offered. And when we correct for the fact that some markets that have few insurers are smaller and have a smaller number of networks, so you just control really for the number of networks, we still don't see a positive correlation. So to sum up, the bit of evidence that I could pull together on innovation in insurance and its relationship to scale suggests that scale is not associated with innovation. But I would love to see more studies like this, and I thank you for your time.
All right, before you start the clock running, let me make a couple comments about the Solomon Center. My law school, St. Louis University, has been the #1 ranked health law center for the 10 of the last 11 years. And we're always happy to see new entrants into this market. And I encourage, especially from a struggling startup, so I'm very happy for the Solomon Center. And you couldn't be better equipped. When I get back to St. Louis, I do plan to try to construct some barriers to entry. I think I'm going to propose a certificate of need or something like that for health law centers. But you couldn't be better served than the people you have. And Fiona and Abby have put together just a remarkable conference here, an all-star cast. And just one word to health law students out there. I'd really urge you to take advantage of the interdisciplinary advantages that this program offers, because every health lawyer I know tells me he or she is doing at least 50% of his work in the private sector, advising on the business structures, advising on the finance and those kind of things. So you really need to take advantage of those things. And clearly a sound grounding in economics, business, and those things really serve you well in practice, especially in government as well. Okay, that ends the commercial part of the broadcast, and we can go on to what I want to talk about, which is the justifications for health insurance mergers. I'm going to return the conversation back to law, since this is a law school. First of all, you've heard about the concentration. What the law does is attach a presumption of illegality once concentration and market share exceed a certain threshold. And the presumption is a very strong one, at least to the extent that the government can rest its case based on the data alone. Now, it doesn't do that, but that's a very big arrow in the quiver of the government. I'm going to talk about the kind of justifications that might overcome those high market shares. And we've seen from the AHA and the American Medical Association claims that there are 800 or perhaps 1,000 separate markets in which there is high concentration. So before I get to that, let's just remember, what are the harms from mergers? What does the law regard as harmful? Well, the first is coordinated pricing, that the few competitors will act in lockstep and raise their prices. The second is unilateral effects, that maybe the two merging parties have such special characteristics or power, they can raise their prices or reduce quality without regard to what others do. A third problem is monopsony, and you heard that referred to earlier, the fact that in some cases the government has brought, they allege that the large insurers have artificially depressed the prices, the payments they pay to physicians below a competitive rate. And the fourth one is among the most interesting aspects of this merger, which is potential competition. Potential competition is concerned with the risk that, but for the merger, one of these insurers would have entered another insurer's market, and that's a loss. And remember, as Limor just said, the effects are not just on premiums. That's certainly a big effect that the government will look at, but also quality, network configurations, and so forth, and innovation. Okay, so there are just different kinds of rebuttal evidence, but the legal standard is pretty clear. The evidence that the defendants have to show is that the merging parties will not exercise market power. Well, what would lead them not to exercise market power if they have that market power? Well, one is ease of entry. Will there be new entrants? Another is countervailing power. Third is regulatory constraints, and fourth is efficiency. So I'm going to talk briefly about a couple of those before I get to countervailing powers. How do judges do this? Stare at this picture for a minute, and you'll see what this is the gestalt of negative space. What I think some people now really realize is that judges really do a sort of combination looking at various factors and reach a conclusion that isn't completely scientific or based on a weighing of one specific item. They try to assimilate a variety of issues, and there are a variety of defenses here. So let me start with ease of entry. The legal standard is, as evolving in the courts now, is not that someone will enter the market at some point, but that entry has to be timely, likely, and sufficient to mitigate the anti-competitive harm. And the Justice Department prior cases have found that it's not so easy to enter an insurance market. First of all, network formation is a big factor. There's sort of a chicken and egg problem with forming a provider network. You have to the new entrant needs to get customers to get discounts from hospitals and physicians in the market. At the same time, the new entrant can't attract new customers if it can't get the discounts. So That has proved, and the government has alleged, that's a sizable barrier to entry. Another is brand recognition. People want to choose an insurance plan with some reputation and history. And in the market, we've seen sort of a mixed bag. If you look at the co-ops that were formed under the ACA, they've been a dismal failure. Half of them have gone under. Those were startup insurance companies. What about the hospital systems we heard about this morning? There's some question about how well they'll do. Some will succeed, but remember, the hospital systems that enter the insurance market have to offer a network with their rivals in the market, and it's not clear that they will be a sufficient entrant. And the new entry into the exchanges post-ACA has been sort of a mixed bag. Some states like California have seen a lot of entry, others not so much. And there's sort of a slippery slope with the entry. At the Senate hearing, one of the senators, Senator Lee from Utah, was questioning the CEOs of the two acquiring insurance companies, and they were saying, well, yeah, entry's easy, don't worry about it, lots of companies will come in. And he said, well, if that's the case, why don't you enter the Humana and Cigna markets yourself instead of acquiring them? And remember, entry is a central goal of the ACA. The ACA was really designed to encourage more competition in insurance, and that's why the public option was actually put aside, because the assumption was with all this new business there would be entry. I'll just go quickly over the regulatory situation. Several defendants in hospital mergers have advanced what I call the ACA made me do it defense to the merger, saying, well, we had to do it, we had to integrate, they put a gun to our head, that's why we're merging with other hospitals. That has been unsuccessful in several cases. But there is another set of issues that are out there, which is this Trinco case, an antitrust case. There is some case law that says, some people call it soft immunity, where regulation has a role to play in how competitors compete and how much they are constrained in raising prices. And that's certainly going to be raised, has been raised in the Senate and House hearings by the merging parties. Lee Moore did a wonderful job in the Senate hearings, and if you want to learn about this, just listen to her testimony. My good friend Jamie King, who you'll hear from later this afternoon, testified in the House. Watch hers, and I testified too, but I'd watch those two first. Anyway, the regulatory defense is another one. The one I want to just focus on is what I call the sumo wrestler fallacy, though. This is countervailing power, and the argument here is, well, will the consumers be better off when we have the two sumo wrestlers in the market, the dominant provider and the dominant insurer bumping bellies in the middle of the ring? Does that produce better results for consumers? And that has a certain intuitive appeal, but it's important to think carefully about it. There's a difference. There are two issues here. One is monopsony, and the risk that where a large buyer, a large insurer, confronts a fragmented provider market, fragmented physician market, for example. And the economic case there is very clear. That is anti-competitive. It results in higher prices to consumers and lower quality. Even though there are lower prices being paid to the physicians, the consumer winds up with higher premiums. The other part of countervailing power, though, is that maybe in some cases the large insurer will get these discounts and they will be to the benefit of the consumer. It turns out that at least the economic studies that Lee Moore has done and others have done show that even where lower prices are negotiated with the dominant hospital by the dominant insurer, even where they do get lower prices, they don't get passed along to consumers. And there's a lot of interesting experience here, but again, if you go into the case law, you see a lot of interesting examples where dominant insurers who were bargaining with dominant hospitals have found a strategic solution. Mutual back scratching, and the Partners case is one that got a lot of attention a few years ago. The Boston Globe ran a story called "A Handshake That Made History," as the partners agreed with the dominant insurer. And so my analogy is sometimes the sumo wrestlers shake hands rather than wrestle. And those of you who follow sumo wrestling closely know there's been a history of collusion actually in sumo wrestling, so maybe you don't know all that. And the Most Favored Nations cases illustrate that as well. And I won't talk about it. My favorite case is West Penn v. UPMC. It's in my case book, but that's a famous menage a trois in Pittsburgh where the dominant hospital, the dominant insurer got together to beat up on another hospital, and they've gone back and forth changing partners. But one final comment, and I just set this up for Peter because Peter and Bill Baer have an enormous task on their hands, potentially investigating perhaps 1,000 markets if the AHA is right, and trying to decide what to do. The current Vegas odds on the outcome of the insurance investigations going on is that there probably will be spin-offs, divestitures where in those markets where there is substantial overlap. But that itself is a pretty dicey business. I called it a bridge too far here. I'll skip over the state AG regulation history, which we heard about this morning. But remember, to spin off a health plan, it's not like spinning off a cement factory. You have to find buyers for the replacements for one of the insurance companies that are capable, that are not themselves a problem from a competitive standpoint in terms of being too big, and able to maintain a favorable provider contract. And that's the key to be a successful replacement. And you need judicial and administrative supervision over divestitures. There's a number of studies showing that divestitures don't always work out so well. So is it practical? Can it be done with 1,000 buyers? I don't know, but my heart goes out to my former colleagues in the Justice Department because they're going to find a way to solve the problem. Thank you.
Try again. Thank you, Zach. Well, thanks again to the Solomon Center, to the Solomon family for having the vision, the generosity to create it, to Fiona and Abby and Yale Law School and SOM for sponsoring the conference, and to all of you for attending. This is really an extraordinary event. Let me talk a bit about consolidation and competition in healthcare. I'm going to focus on the provider side. We've heard a lot about insurance, and these things are not in some sense sort of neatly divisible, but in order to talk about things, we do have to do those. And actually, in practice, the FTC handles provider side competition issues, and DOJ handles insurance side competition issues. Now, Tim's talk was pretty practical and down to earth, being an academic economist, or back to being an academic economist back from government. I operate where the rubber meets the sky, so let's sail back up to 30,000 feet. I don't know how to use this thing. Oh, there we go. So I think we all know that the U.S. relies on markets for provision and financing of care, and that means that our healthcare system is only going to work as well as the markets that underlie it. One analogy to use is we could think of markets as like the chassis for a car. And markets are the chassis that underpin the healthcare system, and reforms like the ACA may have a brand shiny new body, a more powerful engine, various options, but if the chassis is broke, that car won't go. By the way, Connecticut, I heard, was shopping for a new healthcare car, and they liked the 2010 model, the ACA model, and they said, yeah, the ACO comes standard with that, I like that, and a Medicaid expansion option, I like that too. Now, Texas said, we don't want a new car at all, and no, we don't want that Medicaid expansion option, but they did ask if it came with a gun rack on the back. Now, these markets don't work as well as they should, but we need them to. And one thing I want to say is you don't have to be a fan of markets to recognize that given the current system, we need them to work as well as possible. Now, if any of you are market fans, by the way, I have an offer for you. You know those foam hands that people wave like at the Yale game, they're blue hands with a finger, says we're number one. Well, I have a bunch of those back here. Of course, they're invisible hands, so you can't see them, but yeah, come see me later. So we got some problems here, and this matters for the healthcare system. It matters for the ACA. It matters for what we need to do going forward. Or not. Oh, what do you know? So we know that healthcare spending is high. It's increasing. We had sloth recently. All that meant is that the rate of growth slowed. It did not mean that the level dropped. The rate of growth slowed, but it's ticked back up recently. If you look at the rate of growth in healthcare cost over time, it goes like this. It cycles, and what goes down has gone up in the past. I think it's a reasonable expectation that will go back up. How high, of course, no one knows, but I think that we should expect to see increasing spending again in the relatively near future. And this is a big deal. The sector I'm talking about, providers, hospitals, and doctors, are about 9% of national income. That's more than computers, cars. Beer is about 1/10 of 1% of GDP, in spite of the best efforts of my sons and their friends and college students everywhere to increase the share of GDP devoted to beer. That's just not happening. We have problems with prices. They're high and egregious. Billing practices, Stephen Brill, who will talk to us at lunch, of course, documented a lot of those things in a very compelling way in his Time article and book. We know that prices are a major driver of private health spending increases. They're also spillover into Medicare. When prices become high, there's pressure on Medicare to increase its prices. It also potentially creates access problems because serving patients who have Medicaid or Medicare, if they pay a lot less than private payers do, that becomes relatively less attractive. So there are large impacts. We have concerns over quality. There are concerns over innovation, efficiency, and service. In some sense, these are the bigger concerns. Prices and quality, of course, are hugely important. But going forward, dynamically, what happens in these markets will have the biggest impacts of all. Well, at least it's art. So this is a real drawing, or it's an image of a real drawing by Andy Warhol, who's a Pittsburgh native and a Carnegie Mellon alumnus. It was available at the Christie's auction house a few years ago, listed initially at $15,000. Of course, I told my wife, we should buy this. It'll be a great investment. Well, that didn't happen. So I went to my dean and I said, look, here, this is policy, economics related art. We need to buy this. Then I went to the provost. Anyhow, I did have our IT guy capture an image off the internet, so I have that, and it was very inexpensive. So here's a little documentation on the impact of prices from a study by the Healthcare Cost Institute that Lou mentioned earlier. Hospital consolidation. Over 1,200 mergers in this industry since 1994, basically since the failure of the Clinton Health Plan. From 2010, we have 457 mergers. Somehow, there are still hospitals left to merge with other hospitals. I don't know how they're finding each other. Maybe one of those apps online, Meetup or something a little more nefarious than that. Most urban areas are dominated now by 1 to 3 very large hospital systems. We've heard about Partners with the capital P in Boston. There's Sutter in the Bay Area. And of course, in my hometown of Pittsburgh, there's University of Pittsburgh Medical Center, or the Evil Empire, as we like to call them. Cleveland has 2, University Hospital and Cleveland Clinic. But this is increasingly becoming common in many, many markets across the United States. By the way, this graphic comes from the American Hospital Association, who are kind enough to document this and produce pretty pictures. So if you're interested, they have a lot of great material. There's been a lot of consolidation in terms of hospitals acquiring physician practices. Physician practices also have grown bigger, but except in certain markets, like very specialized areas, there still would be a lot of independent practices, but for the acquisition of physician practices by hospitals. And you don't have to think too hard about this to see what's happening, right? So you can see the example on the slide. Suppose there are 2 hospital systems, there are a bunch of practices. Each system buys up half the practice, as now you have 2 competing physician practices. And that's a real issue. This is the kind of issue that came up in the recent St. Luke's case in Idaho. There's a St. Luke's, seemingly at least one, in every market in the U.S. I actually asked one of my colleagues who had the proper religious upbringing was, I don't know from saints. It was St. Luke, the patron saint of monopolists. And he said, no, St. Luke was the patron saint of doctors or something like that. So that helped to explain that, but I was a bit puzzled. Let me talk a bit about potential benefits of consolidation and potential harms and what the research evidence is. For hospitals in particular, we have lots of evidence. There are lots of good data on hospitals. This has been going on for 30 years or more, so there is a tremendous evidence base here. So you don't have to think too hard about why this is appealing. You kind of first blush, say, well, okay, hospitals, doctors, insurance companies, et cetera, they're all interdependent. Put them together, they can coordinate care better, drive down costs. All that sounds good. When you think about it a little bit further, as some other folks have pointed out, it's not clear that they have the same objectives or they benefit from the same things. And consolidation and integration are not the same thing. Integration is hard. Not that consolidation is necessarily easy, and the evidence does not support the claims. The evidence does not show that costs are lower. I can go into a lot more detail on this, but I won't here. There is some evidence of improved quality in some cases, but overall, not consistent evidence. I'd say most of it points either no improvement or the opposite direction. There is no evidence that charity care is increased when there's consolidation. You might think, well, if some hospital systems consolidate, and maybe they do increase their prices and gain some profits, they might be nonprofit, most of them are, and maybe they act like Robin Hood, right? They take from the rich and give to the poor. That doesn't seem to be the case at all. Nonprofits, by the way, there's no evidence they're cheaper or better. But outside of that, actually, it seems to be working well. The vaunted reputation of integrated delivery systems does not hold up to inspection. For some reason, a lot of us have drunk the Kool-Aid that integrated delivery systems like Intermountain, Geisinger, Mayo, UPMC, what have you, are better without actually any hard evidence on this whatsoever. When subjected to inspection, it does not appear that IDSs actually do better in any of these ways. What about concerns? I think, again, the concerns are obvious. If you combine close competitors, get higher prices, you get lower quality, less investment in care coordination, quality improvement. You can get resistance to better forms of payment or contracting. This isn't often discussed, but it is a real issue. You get a less dynamic, innovative marketplace. I said earlier, in a sense, that's sort of the biggest issue going forward. What will these marketplaces look like? Are they open to new innovation, new and better forms of organization? So the evidence is, for hospitals, very strong. Consolidation leads to higher prices. There's a very large evidence based on this. Many people in this room have contributed to that research evidence base. There's more research evidence on hospital acquisition of physician practices. It's new that research is not perhaps nailed down quite as tightly, but all of it points in one direction, that these acquisitions lead to higher prices and more spending. There is strong evidence that reduced competition harms quality when prices are regulated, and I should say some of that evidence comes from the National Health Service in the UK, which is a single-payer system. So even under a system like that, and some of it comes from Medicare, which is, in a sense, a mini, not so mini, single-payer system, quality is harmed. I think the strongest study we have on Medicare shows that Medicare beneficiaries with heart attacks, AMI, had one-year mortality rates almost 1.5 percentage points higher in the least competitive markets compared to the most competitive markets. That's a lot, and that's terrible, and that is not acceptable. Oh, just one last thing. When prices are market determined, the effects on quality are less clear. The evidence is more mixed. There's some that points that competition improves quality, some the other way. So I'd say there it is less clear. Okay, why should we care? Well, we know healthcare spending is high. It's unsustainable. We're mortgaging our future and our children's future. higher healthcare spending is paid for by workers. Healthcare costs are passed on dollar for dollar by employers. Insurance companies don't eat it, employers don't eat it. It comes out of workers' pockets. The average American family has not had an increase in their real income, net of healthcare costs, in a long time, 20 to 30 years. It's a disproportionate burden on the least fortunate among us. The poor bear a greater burden of high prices. They have less access because, for example, Medicaid, as I mentioned earlier, becomes less attractive because it's less lucrative relative to private payers, and there are concerns about quality. I've talked about these rigidities in healthcare market, so I won't repeat those. Let me say something about what we might do. I don't think that coverage expansions are on the agenda. We can think about policies on the demand side, but it's not realistic to expect individuals to drive the market for the reasons I state here. They're heavily insured, as they should be. There are behavioral rigidities. So we need to focus on the supply side. That means payment incentives and competition. Those two things go together. They're not really separate. And to conclude, competition policy is a collection of policy levers. Some of the antitrust is perhaps one of the very critical, but there are lots of other levers that states and the federal government control, and those all have to be brought to bear in order to drive us forward. Thank you.
Hi, my name is Peter Michetti, and as mentioned, I'm the Chief of Litigation 1. And for those of you who may know how the agencies work, Litigation 1 is the part of the Justice Department that handles all of the healthcare civil antitrust matters that go through the department. But of course, there's many healthcare antitrust cases that also go through the Federal Trade Commission. We work very much hand in hand with our partners in the State Attorney General's office. Many other agencies also very much have a role in healthcare regulation and antitrust enforcement. I'm very happy to be at this conference because there is so much learning that comes together and ideas that are presented at this event that I will say that as a government enforcer that's in charge with enforcing the antitrust laws, we very much use the work from the studies that people and universities put together, the ideas that come out of this conference, the factual information that is presented. It very much affects what we do. We're eager to hear new ideas and to learn about the effects, whether it's merger or business conduct. So thank you very much to Fiona, Zach, for putting on this conference. Abby, we really very much appreciate all of those efforts. I do need to point out that I'm talking on behalf of myself and not on behalf of the Justice Department, and that I can't speak to what the Antitrust Division will do with regards to any specific transaction. But one issue that's come up a couple of times today is what is the impact of the Affordable Care Act on antitrust enforcement? And I wanted to address two sides of this. First, where the Affordable Care Act actually does not affect antitrust enforcement and where it does. And I think the big idea, stepping back from health insurance and looking at the healthcare industry in its broadest sense, including pharma, including medical devices, including providers. What the Affordable Care Act doesn't change is it doesn't change the standard for antitrust enforcement. The standard in the healthcare industry is still, will a transaction or will business conduct substantially lessen competition? That's the same standard that there is in any industry. And it's not as if the Affordable Care Act said, no, actually now we want bad outcomes from consumers. That didn't happen. And in fact, there's an antitrust savings clause in the Affordable Care Act. A corollary to that idea is that transaction and business conduct that helps consumers and doesn't substantially lessen competition is still legal like it always has been before the Affordable Care Act was passed. So when we talk about collaboration and coordination, if it's collaboration and coordination that produces better outcomes, lower prices for consumers, better quality of care, that doesn't substantially lessen competition, that's still legal even after the passage of the Affordable Care Act, as it has always been. Another issue that's come up today is that antitrust is just one tool that we have in the healthcare industry to try to create good outcomes for consumers, and I think that's right. But it's a very important tool. And the members of the Antitrust Division, Federal Trade Commission, the state attorney generals were all very dedicated to the idea of aggressively and appropriately enforcing the antitrust laws. We believe in our hearts that competition benefits consumers because it forces, for example, providers to produce higher quality outcomes when they have to worry about losing patients and business to another provider. It can produce lower prices. Yet at the same time, when there are transactions that don't create antitrust issues, then it's important for the antitrust agencies to let those transactions go through so that businesses can conduct their work and continue the many very beneficial practices that hospitals, insurers, pharmaceutical companies, medical devices do every day. I wanted to talk briefly about how the Affordable Care Act can affect antitrust analysis. It affects antitrust analysis in the sense that the Affordable Care Act does create a framework that will bear on many of the issues that are fundamental to antitrust enforcement. What's the product market? How easy or hard is it for new companies to enter the market and start offering competitive services? So in this sense, the Affordable Care Act is just like any regulation or any law. In any industry, there are laws that set essentially the ground rules for how competitors get into the industry. And it is very important for the antitrust agencies to look at, well, what are the regulations that are affecting how competitors in this industry can compete? And let me give a couple of examples using the Affordable Care Act as the regulation that does help inform the antitrust analysis. One thing that's new with the ACA are the healthcare marketplaces or the exchanges. Now, 5 years ago, we didn't have this, but today we do see the exchanges, of course, operating throughout the country. And in some markets, we have seen new entrants enter the market. In other areas, we have seen co-ops enter the market and then exit. And part of our job is to take a look at the entry and exit and determine how competition has been affected by this regulation. Another change that comes with, that we've seen in recent years, and this has been touched upon a couple of times, is the move to narrow networks. We are seeing a lot more individuals being insured with individual plans as opposed to group plans. And one of the changes that this brings is that individuals are more willing to accept narrow networks than an employer. Generally speaking, an employer wants to offer a plan that has broad appeal to many employees. An employer may have employees coming from the north side of town and the south side of town and therefore needs a broad network. But an individual can say, I only need a product that has my particular hospital or the physicians that I'm interested in. I wanted to mention this because yesterday, one of the questions that came up with Secretary Sebelius was the question of how broad should network adequacy requirements be. I think this is an issue where there's two competing considerations. On the one hand, it could be that with narrow network plans, consumers save money because often providers will offer especially lower prices in order to be one of the only providers included in a narrow network plan. So consumers can get particularly low prices with narrow network plans. But on the other hand, there is another policy consideration of consumers, when they go to a specialist that they hadn't anticipated seeing, they want to know that they're going to be able to have a specialist that's in their network. And so I think that the difficult question here is, how broad do you make those network adequacy requirements? Because the broader they are, the harder it is to create narrow networks, and the less insurers and other payers may be able to create narrow networks that will save consumers money and actually give them more access to health care because those health insurance premiums are more affordable. Zach, I'm going to hand it back to you with that. Thanks, everyone.
Thanks.
So I want to follow on Brock's comments this morning and pose a question to the panel. There's sort of been this element of men are from Mars, women are from Venus to this morning, where if we listen to our first panel, you're the problem, right? You've over-regulated. Everybody on this panel is a regulator, and if we listen to this panel, it's providers. Why is there that much tension? Is this unique to healthcare, and how do we know that regulation isn't what's stifling? If you guys just got out of the way, how do we know that the world wouldn't just get better?
Well, antitrust regulators are the good regulators.
Naturally.
Well, you know, it's funny because we hear criticism on both sides. We hear some people saying there's not enough antitrust enforcement. There's certainly many players in the healthcare industry that will say there's too much antitrust enforcement. I think that discussion and all of that criticism is very important to have. It's helpful to us. You know, we want to hear that. So that's very helpful. I will use this opportunity to talk about some regulation that's probably not helpful, that is not helpful for competition, and that's the certificate of need laws. There are about 35 states in the country that have certificate of need laws that make it hard for new competitors to enter the market. It gives the incumbent healthcare provider an incentive to always object to a competitor asking for a new certificate of need to compete. This is an area that the Federal Trade Commission and the Department of Justice have been very active in over the years, and I think that's a good example of a place where regulation ought to get out of the way so that we can have more competition entering the market.
You know, I always bristled when they called me a regulator when I was with the Antitrust Division, because the mission there is to promote market competition, really the antithesis of regulation. And they do a lot of intervention at the regulatory level to discourage the kinds of regulation that curb competition. And I think there are a lot of areas where deregulation is still possible. One interesting piece is, just to back up for a minute, I think there's a real consensus, as Marty and others have pointed out, that provider market power is the source of a lot of the cost problems in America. And those are incumbent monopolies or oligopolies, and they're very hard to deal with. So on one hand, you have people proposing rate regulation or some kind of heavy-handed regulation. On the other hand, others are proposing something that encourages more competition. One interesting area might be to reconsider what came out of the Affordable Care Act, which was a curbing of physician-owned hospitals. Now, there were good reasons to curb them because of the cherry picking they did, but there's new evidence suggesting that perhaps that can be controlled, and that is one source of new competition. So I think as we go forward, some of the solutions that might come forward are injecting new competition. And Barack Richmond and I are authoring a piece for the American Antitrust Institute on some of those solutions.
Oh, okay. If I may, I want to pick up on Peter's idea of talking about a regulation that isn't about promoting competition. We all, just a comment on that, we all recognize that it is a public good, and on this anniversary of the Sherman Act is a good day to recognize that. For the highways to work, we need guardrails, we need police officers, we need speed limits, and antitrust enforcement helps to ensure competitive markets. All right, but that said, there are other regulations in place that impact the functioning of the markets that are ACA related and that could influence interpretations of mergers before the various enforcers today. And I just wanted to take a moment, since we didn't have time before, to talk about the minimum medical loss ratio regulation, which, as many of you are aware, was passed as part of the ACA, that insurers have to spend at least 85 cents for large groups on medical claims or quality quality improvement activities, 80 cents for small groups and individuals. And some insurance executives had said, look, because we have this regulation in place, you shouldn't worry about us merging because we're going to have the same profit margin no matter what. All of your research, Daphne, was from before this regulation was passed. And I just wanted to make a couple of points on that. One, in this competition kind of a panel to make is that price is only one of those dimensions, and profit is only one of those dimensions that consumers care about. So if you have, one insurer competing for your business, taking 15% versus 3, you might get very different kind of service. So that's one element. The second is that actually the regulation only pertains to a subset of the population, which is fully insured, 45% in the figures that I showed you. So it doesn't even pertain. And then the third is we don't actually have good information on where that 85 or 80 cents is binding, is in fact a floor, so actually matters. So it's just an example of how, yes, regulation can enter the mix and potentially impact competition analyses.
And I would just add, in thinking about this kind of at a higher level, not unique to the healthcare industry at all, there's a wealth of economic literature that says regulation will never get you to the competitive outcome. It's incredibly hard to regulate the quality of service. So given a choice between competition and regulation, competition is much more likely to get consumers a better outcome. And the other item I'll point out is with any regulation, there's always the possibility that the regulation gets repealed. And if you are relying on that regulation to protect consumers, then where are you?
I mean, I want to push a little bit back on what the panel's saying, even though I agree with you. Is we go back to Ken Arrow and the way that healthcare markets differ from other markets. And I think one of the common critiques is that healthcare looks so different that we can't expect competition to produce the same outcomes. What is the pushback on the sort of seminal Arrow work?
Yeah, that's just not right. Look, I think we now have, healthcare markets don't look like other markets, that's correct. But again, to an economist who studies markets or somebody who does antitrust, all markets are unique. They all have their unique aspects. And so we wouldn't use it's not a one-size-fits-all thing. This market does operate differently. Competition is in the form of two-stage competition. Providers compete to be included in a network, and once in the network, then they compete for individual patients to go to them. That's not like the market for paper clips, but that doesn't mean that we can't understand how this market works and that less competition leads to worse outcomes for consumers.
So I'm going to open it up to questions from the floor. Before we get to that, I'll ask one final question for the panel. We're at a law school, and what we've seen is that a lot of these arguments have not been upheld in the courts on the provider side, that a lot of these mergers have been allowed to go through. Why have the courts at times said that it is okay for these mergers to happen, it is okay for hospitals to get bigger?
I think the government lost, 7 merger cases in a row back in the 90s, and those decisions were just flat out wrong. I mean, subsequent economic studies have shown the courts were drawing ridiculously large geographic markets, and now they're on a winning streak, and better economic evidence has been produced in the winning cases the FTC has brought to look at likely effects, and that has changed the game.
Perfect. So we're running a little short on time. So what I'll do is we'll take a question from each side together, and then the panel can sort of address both. So we'll start.
I found your comments very interesting that hospital acquisitions of physicians does not lead to really any benefit that you could point out. My clients are all private equity funds buying physician groups and aggregating them through these physician practice management company models. So they remain quasi-independent. They're affiliated with these practice management companies, and then they contract with the hospitals as independents. So I was wondering if any of you had a view on all these multitude of practice management companies around the country as an alternative to the physicians being bought by hospitals or health plans, because they really can't stay independent in onesies and twosies anymore.
And then
Maybe in Upper Manhattan.
We'll take a question from the other side, and then I'll open it to the panel.
Great. Just on a couple of points that were raised. First, on the piece of just the MLR.
Could you possibly address not the MLR in a vacuum, but I guess the three-legged stool of their actual price caps, now post-ACA? There's rate review authority in 50 out of 50 states, rate rejection authority in 30 states, and at least for the MA program, there's explicit post-ACA rate rejection authority. Number one, that's on the price. Secondarily, you get to the MLR as a margin cap beneath that. And third, you have effectively a benefit floor. So post-ACA, with essential health benefits, with age bands, rating bands, community rating guaranteed issue, you have a protection against the degradation of quality. So first, you could address those not simply as the MLR, but in totality what that does. Secondly, as to some of the data that was cited on MA, I think Bill Baer and some of the panelists have talked about more players have led to lower prices. I wonder how much that, if we have the data yet to see, is that a function of the number of players, or is that a function of, let's say, 12 of the 23 co-ops that have now gone out of business having done unrealistic, unsustainable bids, and from United Health not actually playing in a lot of those markets year one. And then lastly, to the sumo and the countervailing powers piece of it, again, I wonder is when the managed care companies have restrictions on pricing, on margins, and on how they structure their product, if there's a concern from the government as to why the price hikes are there and you look under the hood, how much is it to sumo wrestlers versus you can then see a duopoly in labs, 60-70% nationwide, a duopoly in dialysis, as some panelists have mentioned, local dominance of some of the providers, hospitals, and others, and for the drug companies in isolated cases, some amount of monopoly power there that they are negotiating, and that's where the price rises are coming from.
Perfect. I'm going to take one final question, then we'll give each of the panelists a chance to respond. There were a lot of questions wrapped in there, so a brief question at the end.
I think part of my question may be addressed with some of the previous questioners' questions, but one of the impacts on consumers that was mentioned was narrow networks, and I'm also very concerned with cost-sharing design. There was an article that came out about HIV meds and how, when you change from copay to coinsurance, how the price can really, really change for the consumer. So just interested in your thoughts on that.
So we'll open it up to the panel to respond.
Let me, I'll start out a bit with the last two questions, actually. I think when we get into profit caps and cost controls, it's very important to then think about it. It would be nice to think about them in advance, what the impacts would be that are counterintuitive, behavioral, et cetera. But certainly now that we have them, we really ought to have more people studying what happens as a result of that. We see, for instance, that with the benefit designs, whether it's in Part D or with the exchange programs, individual consumers are frankly very cheap when it comes to buying insurance as individuals. They basically do a lot of underinsurance because, of course, with community rating and no pre-existing conditions and annual open enrollment periods, they can basically underinsure until they achieve a health condition. They then increase their level of insurance. So it ties to the last question, which is, connected to that, is we really do have to look at how plans do benefit design and ensuring non-discrimination in benefit design, essentially creating cream skimming of the best beneficiaries and trying to steer the worst beneficiaries away from your plan as you try to manage your population. So are plans intentionally not covering certain diabetes therapies or oncolytics in order to avoid changing the risk profile of their patients? I think in Part D with the 6 protected classes, that served a very important purpose of policing against that type of beneficiary cream skimming. I've not seen the same level of focus, frankly, in the exchange marketplaces on that. Then back to the fact that consumers really underbuy insurance a lot of times in these exchanges. That then leads to benefit packages that have extremely high deductibles, extremely high cost sharing. And I just think we need to have a better debate around whether is that genuine insurance at that point. There's a lot to be said for high deductibles, a lot to be said for good co-insurance, skin in the game, consumerism, et cetera. Don't get me wrong at all about that, HSAs, et cetera. But we do have to think about some of the perverse impacts that can happen there with extremely high cost sharing when you end up having a patient, a provider, and an insurance plan all agreeing that the medically necessary thing, the thing that will lead to the better health outcome, is the patient on a certain medicine. I'll just, talk about HIV, AIDS medicine. Nobody's taking that voluntarily. Nobody's taking that for fun. Everyone has agreed this is the right therapy, and yet we build the benefit structure to create every financial incentive against compliance and adherence. I'm not sure I understand that. But we need to study it because there's no easy answers on this, but I do think it's a very important question that you've raised.
I'm going to turn to Limor for discussing the MLR.
Okay, I'll make two comments here. First is we did spend a little bit of time talking about the adverse consequences of regulation. We should also talk about some of the beneficial consequences. And we heard a questioner inquire about essential drugs and also about the narrowness of networks. There is a role for what's called network adequacy for insurance regulators and what are truly essential benefits. And I think our markets do function better when we have those kinds of regulations in place. The question is, are those regulations going to be set up so that they protect consumers or so that they protect competitors, okay, and suppliers? So stay tuned for that front. And then the second, we did have a questioner asking about whether insurance competition matters, and is it the number of players, and what about these co-ops that have folded? And on that, we do have some research that resulted from the fact that in the first year of the exchange, a major national player who might have been on the last panel did not participate in any of the individual exchanges, and because that payer had different individual insurance presence across all the different states, we could see how their choice not to participate impacted the exchange premiums, and we found a significant effect that was correlated with their presence. So in fact, competition does matter even after the ACA.
So I think much more could be said and should be said, and that's probably a good way to end it. So we'll finish there, head to lunch, and hopefully the discussion continues.
Don't get up. We have some announcements. Okay, thank you. Don't clap. You can save your clapping for after the announcements. But because we have so many people here, which is just wonderful, we have to be a little more complicated with our lunch plan because we are a law school and we must obey the fire code. And so what that means is that just to make this easy to categorize, we're going to split the lunch into 2 rooms for picking up your lunch purposes. So if you are a enrolled student, your lunch is in 127. If you are not an enrolled student, there's lunch in the dining hall. We're also not going to be able to have Stephen Brill speak in the dining hall because we're not allowed to have all of these people in the dining hall. So we will eat our lunch for about 45 minutes and reconvene here at 1:20 for Stephen Brill. 2 more things. While I have a captive audience, I would like to thank our student volunteers and our incredible AV team for making this all possible. And let's thank our panel. Thank you. Okay, thank you. Thank you, guys. Enjoy lunch.
in and take your seats. We're about to get started. So my name is Amy Kapczynski. Come on in and my name is Amy Kapczynski. I teach here in the law school, and among many of my interests, health and particularly global health and the pharmaceutical industry are among them. And so it's a particular pleasure for me to get to introduce Stephen Brill here. I'll be brief because Stephen doesn't need much introduction. He is quite simply, I think, one of the most influential and incisive writers thinking about the American healthcare system today and also the pharmaceutical industry in some of his most recent work. And it is our privilege to have him here with us. He's a graduate of this law school, the author of 4 books, 3 of which were New York Times bestsellers: America's Bitter Pill, Money, Politics, and Backroom Deals, and The Fight to Fix Our Broken Healthcare System, Class Warfare, Inside the Fight to Fix America's Schools, After, How America Confronted the September 12th Era, and The Teamsters. He's also written widely for magazines, including The New Yorker, The New York Times Magazine, The Time, Harper's, etc., and has won many awards for that work, probably most prominently for this audience, his National Magazine Award for Public Service in 2014 for the extraordinary Times Magazine cover story, Bitter Pill, Why Medical Bills Are Killing Us. Stephen's not just a writer, but also an extremely original thinker and entrepreneurial force. He founded and ran Court TV, the American Lawyer magazine, regional legal newspapers, Brill's Content magazine. Some years ago, he founded Journalism Online, LLC, designed to help figure out how to monetize content and earn revenue for newspaper, magazine, and other online publishers. And also, he's been extraordinarily generous in giving back to Yale. He and his wife, Cynthia, founded the Yale Journalism Initiative to create ways for our young and extraordinarily talented undergraduates to move into the field of journalism. And Stephen was teaching this morning and teaches here in the fall a course in the college and mentors our exceptional undergraduates into the field of journalism. He also continues to write extraordinarily important work in most recently a 15-part docu-serial and podcast. Typical Stephen is sort of path-breaking in terms of its form, but also its focus. This is a piece published by Huffington Post called America's Most Admired Lawbreaker, examining Johnson & Johnson's off-label marketing of Risperdal to children and the elderly. So I think we'll hear from Stephen now about some of these important issues, and please join me in welcoming him here.
Thank you, Professor. Quote, a new center focusing on the governance, business, and practice of healthcare in the United States, unquote. That's how the press release announced the Solomon Center and described its mission. For me, this center came way too late. As I set out to write about something that I knew nothing about, which was how come healthcare costs so much in the United States, and as I began examining patients' medical bills so that I could follow the money, I kept wondering about the state of law and public policy that had created what I was seeing. How, for example, could a $38,000 a year school bus driver in Bridgeport, Connecticut, who went to the emergency room at Yale New Haven-owned Bridgeport Hospital after she fell down in her backyard, have left a few hours later, just a few hours later, with a bill for $9,800, a bill that included $6,500 for CAT scans that the same hospital would have charged Medicare $800 for. And how, as I found out, did it come to pass that we in the United States use CAT scans and MRIs at 5 or 6 times the rate that other countries do, and with no difference in results? Could it have something to do with our tort laws and the fact that if you Google CAT scans in emergency rooms, the ads you will see immediately pop up are for trial lawyers? You can try it yourselves in your seats. How could that hospital, the Yale New Haven Hospital, have sued this school bus driver and collected every penny of that money, claiming she had contractually obligated herself to pay Yale New Haven by virtue of a form she signed as she was taken into the emergency room? Now, I have a vague memory of something, I think it was called Fuller and Eisenberg, which was my contracts book here, I think it was, if I got that right. That was our contracts book. And I don't remember any hypotheticals or any real cases of someone delirious in an emergency room agreeing to pay $9,800 for about $600 worth of health care. How, in fact, could it be that Yale New Haven was allowed to own Bridgeport Hospital and St. Raphael's Hospital and Greenwich Hospital and a high percentage of the doctors' practices and clinics and labs in and around New Haven? How did antitrust law apply to hospitals? Was the supposed nonprofit status of this amazingly high-profit hospital a factor? Now, again, those of you who are from Yale New Haven don't get offended by this because I've just told you I knew nothing about this stuff, so I was just asking the questions. Now, the truth is that I actually had no idea, as I've just said, about any of this. So I'd have given anything to attend a panel like the ones we've had this morning. And my dilemma, as I got deeper into this and as I wrote the book about Obamacare and learned what an ACO was, my dilemma, which I'm guessing is on the mind of some of you who've been at the panels this morning, is that as someone from the health insurance lobby said to me, AHIP, one man's cutting-edge ACO is another man's antitrust violation. But I didn't understand that stuff. But I had gone to Yale Law School, which I credit not with teaching me that much black-letter law, but certainly with contributing to my instinctive curiosity, and definitely to my exuberant willingness to admit my ignorance and find the right people to ask. And also to approach everything unembarrassed, to have an outsider's perspective. Now, for example, I sat here listening to one of the panels this morning and heard people, the president of Eli Lilly, for example, talking about the struggles of the healthcare industry under Obamacare and the tough times and the challenges. And I thought I had just dropped down from another planet. This is the most prosperous industry in the world. Everybody, including the gentleman who spoke, is really doing really well. We should all have those challenges. I look at the Form 990s for Yale University and then Yale New Haven Hospital, and I don't know enough because I don't live in this world and I haven't studied this, so I kind of am so ignorant that I wonder, why does the CEO of Yale New Haven Hospital make 40 or 50% more than the president of Yale University? I don't know. Why does the CEO of Greenwich Hospital, which Yale New Haven owns, and which is about the size of this room, make more than the president of Yale University? I don't know. Maybe it's an alternate universe economy. But I was eager, as you can say, I kind of delight in it, to ask those kinds of questions. The problem was, at the time, I couldn't really find a place where I knew the right people might be gathered who focused on these issues. Issues which now involve a sixth of our economy and the single most important, complex, intimidating, and emotionally charged aspect of commerce in our country and in the world. couldn't find where everybody was gathered to know this stuff. For example, in just looking at the antitrust law, I was lucky enough to have a daughter who had graduated from here a few years ago, and I called her and said, you know, do you know anyone who knows the antitrust law of hospitals? And she pointed me to a classmate of hers who ended up pointing me to someone else, and I ended up with Bill Sage in Austin, which is probably as good as it gets, right? But it was a long process. And what I ultimately found, and in fact was musing over when Dean Post and Professor Gluck called to tell me about the Solomon Center and honor me with this invitation, was that one could frame an entire law school curriculum, not just at Yale, where one could imagine a curriculum about anything, but at a real law school too, you could frame an entire curriculum around issues related to healthcare. So let me give you some examples, and these sort of illustrate why I'm delighted that this activity is going on, and I think these examples also illustrate the challenges and the opportunities that the center faces and offers. Campaign finance reform. The healthcare industry spends 4 times as much on lobbying and 4 times as much on elections as the next largest industry, the much dreaded military-industrial complex. And if you want to see the results of that, read any of the pages of the Affordable Care Act. Antitrust law. Well, we've talked about some of it. Hospitals and their consolidation, you know, which are today's subject, and of course, insurance companies. But the issue of bundled care, which obviously presents competitive issues. Now, I will tell you, just as an aside, that as someone who started the American Lawyer magazine and wrote forever about the economics of law firms and quoted general counsel every year for more years than I'd like to remember, saying, you know, we're going to get rid of the billable hour and we're going to start a law firm economy where we pay based on value, not on how much work you do. I'm skeptical that, with some exceptions, you can ever really pull that off, except in one instance. And again, this is where a legal analysis, where there's lots of legal analysis that needs to be done. And that instance is sort of the ultimate bundled product, and that is, as I proposed at the end of my book, merging insurers with providers. As long as Yale New Haven, which is a great hospital, a great system, is going to be so dominant, wouldn't you rather buy your health insurance from a brand and from people associated with Yale New Haven than from United Healthcare? Why shouldn't I be able, if I live here, to pay the Yale New Haven health system $15,000 a year to keep me and my family healthy? That would be my insurance premium. That would be my deal. That's the ultimate bundled product. But as I discovered in thinking about this, and as I described at the tail end of the book, the problem is, how do you regulate them? Once you say you're going to provide, you're authorized to, and we encourage you to sell healthcare insurance directly to the people in this community, what do you do to make sure they don't do what insurance companies are accused of doing, which is skimp on the health care? So I proposed in my book that you treat consolidated systems like that, or like the Cleveland Clinic, as oligopolies or monopolies, and then you regulate them heavily. And I was criticized after the book came out by a lot of really smart people as being hopelessly naive in suggesting that these oligopolies or monopolies actually could be regulated effectively. Now, the critics may be right, but I suspect that a place like the new Solomon Center, especially if it can recruit many of the people who are so expert from around the country who are gathered here today, if it can recruit them, maybe it can shed really important and credible light on an issue like that. And I will tell you, as someone who scanned all the stuff and read everything I could, there's a real gap there. Another issue, the whole issue of privacy. Now, I will tell you one thing, that hospitals and doctors and providers, that when a reporter calls, they will use privacy, HIPAA, as an excuse not to tell you anything. I had this wonderful conversation, actually with someone at Yale New Haven, who explained how, explaining to me why they charge 4 or 8 times as much for a CAT scan for a $38,000 a year school bus driver with no insurance as they charge someone with Medicare, would violate the HIPAA rules. So, and I said, well, why? And he said, well, it's really complicated. And I said, well, if you speak really slowly, I will try to get it. I had another hospital tell me that, that to comment on why they charged $38 for the cuff that goes around your arm when they take your blood pressure would violate HIPAA. Go figure. But there are real HIPAA issues and privacy issues. And again, I don't know of a really good place that is looking at those issues and watching them develop, because they're also really dynamic issues. Cybersecurity, slightly related. Can the FDA regulate cybersecurity for medical devices? We now know that's a big issue. Can Medicare regulate cybersecurity for hospitals? Look at hospitals and say, hey, you know what? You're not secure enough, and we're gonna penalize you, or we're just not gonna allow people to use you. Contract law, but I already mentioned the obvious question of is someone knowingly contracting for medical services in an emergency room situation? That's kind of obvious, but I think the whole issue is really interesting in the sense that how much do people really know about the care that's being offered to them? Do they really know what the charges are going to be, except that it says we're going to charge you whatever we charge you? So what really constitutes patient acceptance? But there are some other issues related to contracts. Gag clauses in contracts between hospitals, for example, and medical device companies, or between hospitals and other suppliers. There are routinely gag contracts imposed so that supposedly the effect of this is that prices stay up higher because people can't see that others are getting a discount on the prices being charged. Now, I really wonder whether getting rid of those gag clauses as sort of violations of public privacy, legislating against them, would actually lower prices or raise prices, in the sense that if a hospital, if a medical device company giving hospital A a discount knew that that discount was automatically going to flow to hospital B, maybe they just wouldn't give the discount. I don't know, but the whole point is I don't know. The point is these are the kinds of issues that need to be studied. Similarly, and a much more interesting one, I think, and a bigger one, is pricing transparency. There's a big movement. In part, my article in Time sort of inspired some of this, some might argue, for real pricing transparencies. How much do hospitals charge for everything? How much do doctors charge? Again, I wonder whether it will have a positive effect or an adverse effect on raising prices. I wonder how meaningful it is, since you really don't know what you're going to need until, in most situations, until you need it. It's easy to say that here's the price for this artificial hip or this artificial knee, but most medical care situations are not that simple and easily quantifiable. To me, the real transparency and information challenge is quality. What are the effects of the absence of real data on quality? It's one thing to know that that doctor charges $100 less than that doctor, but what good does it do me if I don't know which one is any good? On the other hand, can quality really be measured? Are there any credible measures? Will people care? I have a suspicion that when it comes to health care, most people will prefer to buy the more expensive product on the assumption that it must be better. And the one thing I don't want to screw around with is, my daughter's health care. So if you tell me it's the same price for A versus B, but B is, it's the same quality, but B is much more money, I'd really kind of like to be safe and go with B just in case you're wrong. Then the issue becomes, if there really is transparency, does it create its own set of legal issues? I'll give you an example. As those of you who might have looked at the book know, I had to have open heart surgery just as I was finishing the book. And it turns out New York State has a really good, although kind of hard to use, website that gives you the success rates, the mortality rates of heart surgeons all across the state. And they even, so they say, control for situations like how old the patient is, how serious the case is, all that stuff, so that in theory you're really looking at a quality measure. And I got fortunate enough to have someone who was ranking very high. That's not my point. My point is, suppose the transparency measures were absolutely credible and absolutely good. Who is going to accept and not go to court to fight over having the 80th percentile heart surgeon when you can see that there's a 99th percentile heart surgeon? And what are the equal protection arguments that go with that? If you really know that, if transparency really delivers on quality, I suspect that the rules and regulations and even legislation attached to that could get interesting and complicated. And it's nice to know that there's going to be a center here that maybe will look at that stuff. Similarly, transparency for clinical studies, which Yale is already working on. That couldn't be more important, as I discovered in doing this piece that I did about Johnson & Johnson selling a drug called Risperdal and contrary to, and promoting it contrary to the FDA's restrictions, promoting it to children and the elderly. And there was a lot of litigation around what were the clinical studies that they carried out, what was their integrity, how much did they disclose. That is a big issue. One other issue before I come to the end, actually two others, tax law. That's kind of an obvious one. Are these hospitals really nonprofit? The profit margins of the nonprofit hospitals, at least according to McKinsey's data when I was doing the Time article, the profit margins for the nonprofit hospitals are actually higher than the profit margins of the for-profit hospitals. Go figure. But at a time when the IRS is spooked into ignoring obvious abuses of tax-exempt status by political fundraisers, is it really going to dare to go after the community hospital, which overcharges and is aggressive about billing and is, in many cases, not following the clear black letter restrictions, new restrictions in the Affordable Care Act about the billing practices they can carry out if they have a tax-exempt status against people who need financial help? I don't know. But that whole tax-exempt status is a big issue. I think I read yesterday or the day before that there was a case in New Jersey where a state judge just nailed a nonprofit hospital and said, for the purpose of local property taxes, you are no longer exempt. There's been another case in Pittsburgh where the mayor sued, a new mayor came in and rolled over and ended the suit, but this is not going to go away, and it's a really interesting issue. Obviously, torts and tort reform, I happen to believe that the real potential benefit of tort reform is not the money it would save on insurance costs, but that abuse of litigation is either an excuse or the reason that so many hospitals overtest. And whether it's the excuse or the reason doesn't matter, but the data is clear that we do dramatically over-test. I had one hospital executive, when I was doing the Time magazine story, tell me that his instructions are that anyone who comes into the emergency room and uses the word head gets CAT scan. That's just it. They just use the word head, CAT scan. I have a headache, I fell on my head, or I want to head to the men's room. If the word, there is no discretion. The word head means CAT scan. I think that's real, and I think that needs to be looked at. I don't think it's a panacea. Then, of course, there are the practice regulation issues. Can telemedicine doctors practice across, across state lines? There are a lot of other practice regulation issues associated with who can do, quote, medical care, how much can be done by paramedics, by nurses. There's, of course, the issue, which I will say rather immodestly, that I predicted would be the big issue in my book for this year, which is the price of prescription drugs. We kind of know, I think we kind of know we should stop being the only country in the world that doesn't control the price of drugs to whom we give a monopoly patent to. But how do we do it? What's the way to do it? Can we do it? The intellectual property issues, everybody here can appreciate, although now they also have sort of an international trade twist to them with the TPP. And there's now constant litigation over agreements to head off the use of generics by plaintiffs engaging in the kind of litigation that only someone who went to Yale Law School could have thought of, where the plaintiff sues and settles with the defendant by paying the defendant. I mean, you really got to love that. But we know that's what's going on. And then, finally, I will end with this, because this is a real serious one that I think is going to occupy, I hope is going to occupy a lot of time of the people at the center and should occupy everybody's time. And that is what I consider to be the looming First Amendment issues. There's a bunch of that I try to cover in that Johnson & Johnson series that I did. And I'm certain a lot of you are familiar with the recent cases, both the ones specifically relating to the FDA and the Supreme Court cases relating more generally to speech and defining types of speech. But let me tell you that in talking with lawyers for Johnson & Johnson, executives there, they have a firm belief, and I think the industry has a firm belief, that that the First Amendment really ought to get the FDA off their backs. That if they have a sincere belief, in this case with this drug Risperdal, that if the FDA may think this drug is dangerous for children or the elderly, but if they believe passionately in their hearts that it's a great solution, as long as they don't say something that is provably, not debatably, but provably false, they don't think their speech can be stopped. And the industry is moving ahead with litigation to establish that. That when we're saying something that we believe that can help tragically sick people, that is the way they will frame it, the government shouldn't be getting in the way of that. And I think ultimately the goal line there is basically not having prescription drug labeling at all, and certainly not having restrictions on the promotion of drugs in contradiction to what the label says. Now, all of this is a long way of my saying that as someone who has none of your expertise, but lots of curiosity about a critical subject area, I'm really glad to be here and honored to be here to celebrate the launch of this center. And I'll just step back for 1 second and just add this, that the bad news actually is that we need this center at all. Because in any other country, so many of the issues I outlined would have been dispensed with so logically and so simply that we wouldn't have to tie ourselves up in the kind of knots that we tie ourselves up in over most of these issues. But we're not any other country. We are who we are, and for the most part, we're all pretty proud of that. So I'm glad we have the center, and I wish you all luck. Thank you. I'd be glad to take questions. $2:15. Come on, give him a break.
All right, 2:15.
Started me late, you know. I didn't want to do a Marco Rubio during the speech, so.
Okay, so I think, well, let's I'll let you point at people.
Sure.
But we do
There's
have
nobody,
time for
everybody,
questions.
there's no one with a question. It was all so clear. Oh, there we go. No. This is not a Yale Law School audience where no one asks questions.
So we did hear a lot this morning about the benefits of classic neo-economic style market competition. Be curious, and did you hear the panel just before lunch? You referred to some of it.
Just before lunch, I heard some. I heard my fellow alum from Eli Lilly talking about the hard times.
Well, in any event, see, you went to the Yale Law School, so you can opine on anything. So my question is, do you think sort of normal market structures and forces conceivably can work if we
No,
get
of course,
all-
that's just nonsense. I mean, this is the one product where you cannot have, and I love a free market. I mean, I've started companies. I am the ultimate entrepreneur. I'm not someone who instinctively says, let's curb markets. But and I write about this some in my book from my own experience, that healthcare is not like any other market. You typically, when you need it, you're desperate. You know nothing. You have no idea what the price is going to be. If you knew the price, it wouldn't matter because you don't know what you're getting. And you can't make a rational decision. And anyone who thinks, well, gee, if only you were making the decision and not your insurance company and, God forbid, not the government, then everything would be okay. So I was on one of the Sunday shows with George Will. And George Will said, this is after the Time magazine article came out, and George Will said, well, the problem is people don't have enough skin in the game. And I had just finished talking about a guy who, a $45,000 a year family, he had just started his own business, couldn't get decent insurance, and was held in a waiting area at MD Anderson Hospital because his wife had to get a check cleared for $85,000 for his first cancer treatment and his first drug transfusion. He had 100% skin in the game. What good was that doing him? The other obvious thing is, let's just look at the giant science experiment we have done over the last X years, which is every other country did it one way, and we did it another way. And every other country spends less, and the results are just as good, or more typically, they're better. That's pretty empirical to me.
Hi, I'm Alex Rich. I'll admit up front I've got a little bit of a bias in that I'm a healthcare management student. So you talk a little bit in your book about the importance of having a clinician in the chief executive position of healthcare systems. And I'm wondering if you
sorry about that.
No offense taken. I think I'd like to hear a little bit more about your perspective on that, why you think that is, especially in an era where we're seeing more and more data transparency and a shift from a previously more paternalistic environment where physicians knew all and did all to an environment where the culture is a little bit different. So,
well, first of all, I'm not sure, as a patient, I kind of like the paternalistic environment, if you don't mind. I want my doctor to treat me that way. The reason I had that suggestion in a bullet point list of 7 different suggestions about how if you're going to allow these oligopolies, let's make sure there are a bunch of things, such as the kind of regulation I talked to, an ombudsman for people to complain. And I said at the end of the day, I am a big believer that culture counts. And that my experience, and this is certainly not a reflection on anyone at Yale New Haven, because I wouldn't categorize Yale New Haven as in this negative bucket at all in this sense. But it is a good thing when someone who trained as a physician, and better yet, woke up in the morning, still wakes up in the morning once in a while and acts as a physician, is making the ultimate decision and has the ultimate responsibility at a healthcare system. I kind of like that. I think that doesn't mean that there aren't a lot of doctors who are awful, and it certainly doesn't mean that there aren't a lot of managers who aren't doctors who are terrific. But just in terms of sort of upping the odds, I think that's not a bad thing. And I was asked about this the other day, I forget where, but and the example I used was there's a guy who until very recently ran the Partners Health System, which is Mass General and Brigham and Women's, and I got to know him, and he had started out life practicing as a geriatric psychiatrist. There's a term for that. I don't remember the term. And I remember saying to my wife, how bad a guy can that guy be? I mean, that's what he wanted to do, and he was doing that. I mean, that's not terribly rewarding. It must be just miserable doing that kind of a practice as opposed to doing, fixing knees for people on the Knicks or something. I mean, must be a pretty good guy. So that's sort of my kind of touchy-feely way to approach that. But again, it was one of 8 different criteria. Yes, sir.
As a practicing physician, I've been delighted to hear some of your comments. What we have learned is that the 2 really important things in terms of delivering effective care are the relationship the doctor establishes with the patient, and once that relationship has been established, the continuity of care. These 2 factors have not been mentioned until now during this conference. And I've approached this microphone with some trepidation because I felt that I had to, because I didn't think, unless I mentioned them, that anyone would. They are important. I don't know how you attach a monetary value to that. I don't know how you regulate it, and I don't know how whether antitrust law applies to these factors or not, but they're important. I've been a patient as well, and my family have been patients, and I've seen the importance of these factors. I suspect that as a patient, you appreciate them as well. And I wish that there was more discussion of how you institutionalize these factors in the new constructs that are being discussed.
I think you're right. And part of the issue is the size of healthcare institutions. It makes whoever is in charge, whether it's a doctor or a non-doctor, really remote from the stuff that everybody cares about. I'll just add one other thing to that, which is that when I talk to doctors and I give talks like this, I'm always stunned by the fact that doctors feel they have no control over the system, which they don't. And one of the things that surprises me about that is that if you read, and I covered for a few pages the history of healthcare reform in the United States, and I noted that in the 50s and 60s with Truman and Kennedy, when they tried to do healthcare reform, the AMA stopped them. And if you read the news clips at the time, the AMA really sounds like the NRA. If the AMA didn't want it to happen in Washington, it was not happening. Now, cut to 2010, the Affordable Care Act, and the doctors are sort of a non-entity in the whole thing, and they're so disrespected and disregarded that when it comes time to drop out of the Affordable Care Act something called the doc fix, dealing with Medicare payments and billing. The White House and the Democrats in the Senate, they're marking up the bill and they're well, gee, we got to save $200 billion in this thing over 10 years. Let's just screw the doc fix, the hell with it. And they take it out, and then they forget even to call the AMA. They care so little about them that they have nothing to do with it. So what you end up with today is a system where the medical device industry has tons more power in Washington than the doctors, as evidenced by the fact that the one piece of reform that everybody's talking about, bipartisan reform of the Affordable Care Act that might happen, is a repeal of the 3% tax on medical devices. And that is the most bogus issue imaginable. You couldn't create that issue on Saturday Night Live if you tried. It has had no effect on the fortunes of the fabulously profitable medical device industry. Jobs are up, profits are up, and the profit margins of Medtronic make Apple look like a hot dog stand. And the profit margins are higher since the tax. So, why do we, and even the sainted Elizabeth Warren is in favor of repealing this tax because Massachusetts is number 2 in the medical device industry, and the sainted Al Franken is leading the charge because Minnesota is number 1. What does that tell you? That the financial interests that have nothing to do with healthcare, nothing to do with the nurse or the doctor I'm looking at when I'm lying desperately on a gurney, terrified, are controlling the system. And that's probably the craziest thing going on in this whole environment.
I think this will be our last question, and then we'll stop.
Hi, I'm Sophia. I'm a student at the Public Health School. So you outlined a lot of political and legal challenges, and in many ways at the Public Health School, it kind of feels like we've been on the back foot for a long time. I was wondering what your perspective was on, do you see any winnable political battles and legal battles in the next 2 or 3 years, considering our political climate? And then do you see what kind of allies we can recruit into winning those battles?
I think this is sort of like infrastructure in the United States. It's like a slow-moving, really bad crisis. In this case, the crisis is that every middle-class family, certainly poor families, but every middle-class family is seeing their deductibles go up, their co-pays go up, a harder time dealing with their insurance company, none of which has anything to do with Obamacare. I mean, this was going on before Obamacare, and because the core issue, the cost of all this stuff, just keeps going up. So sooner or later, if you have someone making $60,000 a year who's paying with insurance, $8,000 for health insurance, and it's an $8,000 deductible, and the copay, the maximum out of pocket is $15,000. That's untenable. It's becoming increasingly untenable. So sooner or later, I think this will become a big issue. To me, one of the ways to deal with it, where you could sort of gradually change to a system that is like every other country's, gradually put the toothpaste kind of back in the tube, would be if you just lowered the year of eligibility for Medicare by 1 year or by 2 years every year. So in 20 years, you'd be down to, to 25-year-olds. I think I got that right. And basically, you would have wiped out the system we have today, but it would take you 20 years to do it. So the insurance execs and that guy from Eli Lilly would still get his bonus for the next 5 years. He'd be okay. Even his successor would be okay, and everybody would sort of gradually just sort of get off the heroin. But I don't know how you do it any other way, and I don't even think you're going to do it that way.
All right, so we now have dessert and coffee in room 122, and please join me in thanking Stephen for his remarks.
Thank you all.
The next panel will start in 10 minutes, so.
I do have a bunch of slides because they took. Do you have slides? There are three presentations, and well, I could do mine without actual slides, or I could do them with the slides. That's really well. Just want the name.
So, welcome. I'm Bob Alpern. I'm the Dean of Yale School of Medicine, and I'll be moderating the session. The session is Building an Accountable Care Organization. What services do you need? What should you do without? And what is the impact on the physician? We have a really great panel today. I'll just briefly introduce them. Robert Berenson, Institute Fellow at the Urban Institute, Cecilia Montalvo, Vice President of Business Development at Kaiser Permanente, Paul Taheri, CEO of Yale Medical Group and Deputy Dean at the Yale School of Medicine, William Sage, James R. Dougherty, Chair for Faculty Excellence, University of Texas School of Law, Professor of Surgery and Perioperative Care at the Dell Medical School, and Michael Chernow, Leonard D. Schaefer, Professor of Healthcare and Director, Healthcare Markets and Regulation Lab at Harvard Medical School. So I thought I would start just so that we're all on the same page by defining what an accountable care organization is. And it's somewhat been defined just by what it does, and I think there's a lot of confusion as to what exactly is an accountable care organization. So I decided to do a thorough literature search and went to the best source. So this is how Wikipedia defines an accountable care organization. A healthcare organization characterized by a payment and care delivery model that seeks to tie provider reimbursement to quality metrics and reductions in the total cost of care for an assigned population of patients. So we're tying payment to two characteristics, quality of care and the cost of care. And I hope one of the things that will come out in this discussion is it really quality of care and cost of care, or is it just cost of care? But we'll let the discussants address that. So I think we will start with Robert Berenson.
This one is, it is hard to control this thing. There we go. Okay, it's a pleasure to be here. First, a disclaimer, I have had no affiliation with Yale Law School at any time in my past, but some of my best friends have been here. I have been watching Republican presidential debates, and I have learned that one can change the subject pretty quickly. In fact, it used to be that you had to make an attempt to answer the question before you went to your talking points. Now they've sort of shown me you don't even have to do that. I want to take 2 out of my 8 minutes to just make a commentary on what I heard before, and then I promise I will talk about some aspects of ACOs, in particular their relationship to payment, which is sort of the dichotomy between you either believe in competition or you believe in regulation. I come at this whole area from being concerned about prices. High prices and highly variable prices, and there's pretty good evidence, I think, that it is high prices that are the reason the U.S. healthcare system is so expensive. And I would look for both regulatory and market-based solutions where I can find them. And in our country with such a diverse set of states and cultures, it's likely we will have different mixes and matches of all of that. But so one thing I want to talk about very specifically is the potential for having competition among insurers and among providers, and at the same time having regulation of transaction prices. And so basically I'm suggesting that the state of Maryland, which has controlled through rate setting, the unit prices of hospitals for now 35 years plus, and is now embarked on a new approach around global budgets. At the same time, has pretty robust competition, or has had as much as most states in the 80s and 90s amongst HMOs, including Kaiser Mid-Atlantic going into Maryland while they had rate setting going on. Currently, there's more competition amongst hospitals in Maryland than there certainly is in Northern Virginia, where partly because of the Certificate of Need apparatus permits a monopoly hospital system to prevent competition from coming into its area. So next week I'm going to be co-authoring and releasing a paper on rate setting. And we're going to be very straightforward about the potential for regulatory failure, regulatory capture, which we've seen in the past in those attempts. And yet, for part of the sort of general discussion of how do we deal with this issue of consolidation going forward, I would suggest that it is probably not either or. It is some combination, and it probably varies at the state level. And with that, let me get on with what I was going to do, is talk about some aspects of ACOs. And I'm going to get into this by starting with sort of the general theme that there's a national commitment to move from volume-based to value-based payment. It's about the only area of health policy that Republicans and Democrats actually agree on. Republicans want to repeal the Affordable Care Act, but actually not the parts of the Affordable Care Act that are testing demonstrations of medical homes and accountable care organizations and that kind of stuff. And then they got together to pass the Medicare Access and CHIP Reauthorization Act, that was basically the repeal of the SGR and the quid pro quo, and that was the language that the Hill used for passing this legislation. The quid pro quo for giving docs relief from the SGR is a new merit-based incentive payment model in which almost a 20% swing in a physician's fees are based on their performance on some quality measures, and then strong incentives to move to what we are calling alternative payment models, to be continued on these slides. So an alternative payment model provides a 5% bonus if the physician has a significant APM participation. And then by 2026, they get, these dates are wrong, by the way. That was in an earlier version. They then get more annual increases. I find it interesting that you have to pay more to get physicians to save money, but that seems to be the strategy here. APM must involve risk of financial losses and have a quality measure component. Then there's some details about how that will happen. HHS, for its part, prior to passage of this law, created a framework for the evolution of payment models. And one of the points I think is important to keep in mind, the difference between a payment and a delivery system model. Some people say, oh, ACOs, we're going to pay, that ACOs are a payment model. No, ACOs are a delivery model, and there's various ways in which one can pay ACOs. But let me go through this evolution of payment models quickly. Category 1 is fee-for-service with no link to quality. So none of those measures that Michael Dowling was talking about, just straight fee schedule for doctors, DRGs, et cetera. And then by the time you get to here, you're beginning to talk about ACOs. It is alternative payment models built on a fee-for-service architecture, which means the cash flow is still going fee-for-service to the various components of the ACO, but the ACO has an interest upside only in Category 3, meaning they can get a bonus. By the time you get to Category 4, probably you are either into what we used to call capitation or two-sided risk, substantial risk, up or down. So this is where the ACO thing really comes into play, is moving to Category 4. HHS has established targets for all of these things. I'm somewhat sort of contrarian on some of these things because, for example, I think you can improve value a lot more by fixing the flaws in Category 1, where we overpay for procedures and tests and we don't pay enough for time spent with patients, that you can improve value more in Category 1 than by picking a couple of half-baked quality measures and saying you're doing value-based payment. But for our discussion today, we are talking about ACOs, and you heard the definition. It's basically you have to achieve performance on quality, and you have to try to achieve savings. Let me proceed. There's a lot of information. I want to focus on this bullet right here, that classic multi-specialty group practices, which I would call prototypical ACOs, often organizations that have the last name of clinic, pretty reliably are reported to negotiate levels with their health plans at 250% or more of Medicare as the reference point. But now, as they've integrated, they're doing it for hospital and physician services. And I would make the point that high prices eat low service use for lunch. Basically, I'll go to this one. MedPAC analysis shows that, right here, that there's about a 30% spread across geographic areas between the 10th and the 90th percentile once health status is correctly factored in on service use. This is in Medicare, where prices are administered and are pretty much adjusted across the country. So there's a 30% split or spread on service use. There's at least 100% spread between the 10th and the 90th percent on price. So the issue to me is, how do you make up on lower service use when you're getting 250, 300% of Medicare on price? And where I want to go with this one is that in the payment models for ACOs, we rarely discuss, indeed we generally accept, variations in baseline spending, which often reflect price variations. In other words, we're using a payment model in Medicare, but what I've seen in commercial insurance as well, you take an ACO's historic spending as its base, and you provided you're interested in restraining their rate of increase, and that's how the shared savings are calculated. I think we need to, there are many ways in which one could adjust that over time, try to have the high-priced organizations converge towards the community average. You can't do that on day one. It's not gotten a lot of attention. To me, it is a way in which ACOs could be an engine of good change for addressing price. And then let me finish with this one last slide. For all the enthusiasm of ACOs and delivery system change, and I hear from Massachusetts, and I hear about Advocate Health in Chicago, and there's some other great examples, I want to do this quote. This was from a recent article in the Washington Post, a cancer boom funneled by economics and an aging population. The economics of it are good, said Patrick Duke, managing director at CBRE Healthcare, which is a real estate organization, sells healthcare real estate. It's a touchy subject for some people, but it's the reality. There are lots of patients out there. It affects everybody. The procedures and the drugs are well reimbursed. It's a big business. So while we're all talking about population health and shifting the curve down, there is still an engine of volume-based payment that I would argue remains dominant. There are places where other things are happening, but I don't think we should ignore what's happening in mostly across the country. Thank you very much.
I think you've just set the schedule. We're ahead of schedule.
Okay.
So the next speaker is Cecilia.
Thank you very much for having me. I must admit, I was telling some others that I've been to a lot of industry conferences in my day, but I have never been to a legally oriented conference. It has been very fun to hear what is talked about in a forum like this. I also should start out by explaining my job at Kaiser, particularly given the discussion this morning about Kaiser's history. I was hired there about 3 years ago by a new CEO, Bernard Tyson, because Bernard had a more ambitious agenda for Kaiser than Kaiser has had in the past. And what he asked me to do is to start a function and to lead a function within Kaiser that would enable us to go to new markets across the United States. And that job just sounded too exciting to turn down. My kids were grown. I thought, I'll give this a try. I think it was within the first few days that I was on the job, they handed me the set of articles that had been written. One that I especially remember was written by Alan Enthoven. It was called The Rise and Fall of Kaiser's Expansion Regions in the 1990s. And having read that article, I almost wanted to run away, realizing what a poor history they had had. I think today is different. I think there's a reason that Kaiser can do things today that we never could in the past. I do, as I travel all around the country, I do see organizations almost everywhere, not everywhere, but almost everywhere, that are trying, they don't want to be fee-for-service organizations. I think leaders in healthcare understand that our payment model has created an incentive they don't want. But getting from here to there is really problematic. It's been problematic for the payer sector. It's more problematic, in my view, for the provider sector because their capabilities have to be so fundamentally different than what they are today. What I see as I travel around, most of the organizations I talk to are trying to live in two worlds, but as much business is being done with Medicare and other commercial payers and these things that we now call ACOs, it's a tiny, tiny piece of their business by and large. I know of only a few organizations, maybe more than a few, but there are rare organizations that have even crossed that threshold where the majority of their business is paid that way. And I would postulate that so long as it's only a fraction of your business, it really can't fundamentally change the business model. I do believe, however, I have to be the contrarian with Bob. I think that so long as we are talking about unit prices and fee-for-service and how high they are, we're talking about the wrong thing. Because I can tell you that if you broke down Kaiser's unit cost, which we have a hard time doing because we don't know how to do that, but if you did, it would be quite high on an individual visit basis, I suspect. And that is because to be successful in arriving at a premium price point that is at least 15% below our competitors in all the markets we're in, we have very, very sophisticated infrastructure that is wrapped around medical practice that needs to get paid for, and that it does not get paid for in the fee-for-service world at all. And what I have seen with the groups I talk to is there's just insufficient investment in the care model itself to innovate. But they're all on a spectrum. So I believe that what we call ACOs today, and by the way, I have a new definition, Bob, of ACOs. Somebody once said to me that ACOs are unicorns. And what that means is that ACOs are actually, you conjure up an image in your mind, and that is what you think of as an ACO. There's a lot of variability, not so much in the top line idea, but how it's executed, what it looks like underneath that, variability is rampant. They are typically built around hospital systems because community hospitals have been the organizers of the medical staff in many cities. And they also typically set up a structure where your whole medical staff is in. So yeah, you could leave out a few people, but if the entire medical staff is in and it's just wrapped around a hospital, I would argue that this is not a collaborative, team-based sport. You have a sponsor that's entered into a contract that says, yeah, we'll take upside if we lower costs. the individual physicians aren't practicing usually any differently at all. And I'm really quite surprised that we've gotten some of the results that we have. Again, it's interesting listening today. We are at Kaiser, and I am personally, from my prior career, a huge proponent of multi-specialty group practice. And I believe that the multi-specialty group practice at the core of the Kaiser model is what delivers the value that we get. It is a physician organization that is prepaid based on population management and peer-based teamwork. And I think it's really important. That, its culture, and its infrastructure. And I think that if ACOs are designed to move us towards a continuum, then I think it's a small step, but it's not, we have not gone all the way by any effect. Now I have to make my final comment about regulation and what I heard this morning about competition. I truly believe that fragmentation of our industry has been a terrible thing for consumers. They're not getting good quality, and they certainly aren't getting affordable prices. And I realize that the legal antitrust sector calls it consolidation, but I would say it's the elimination of fragmentation, and that will deliver better value to consumers. Thank you.
Speakers Paul Taheri.
Good afternoon. I'm Paul Taheri, and I'm actually a general and trauma surgeon by training. I'm currently the CEO of the Yale Medical Group. When Abby and Fiona asked me to do this, they really asked me to do this because I'm sort of one of the people on the ground who's dealing with issues of payment reform and sort of consolidation and many of the things that have been talked about earlier this morning. So I'm going to take you not with a long story about our medical group, but just 2 quick slides to show you this org chart. It's really not that eventful, other than the fact is it's very straightforward and it's pretty simple, and it's how we sort of govern ourselves as a medical group. What I want people to begin to think about is this is how we're set up today, and this actually kind of works. We've got our issues like everybody, but what's happening with the changes in the environment of price transparency, massive consolidation, different relationships between provider groups, insurers, provider groups, and hospitals, et cetera, really puts a lot of pressure on the sort of the historical or older kind of governing processes and structures inside medical groups. And you know, this slide, I'm not going to go through it. This kind of gives you just a brief idea of the kinds of things we do inside a medical group. It's purposely kind of small so you can't read it, so there's nobody sure what we do every day. But the idea here is there's a lot going on already. I mean, just some of the things you're hearing about today are causing massive shifts inside medical groups about who should be doing what, how are we organized, how does the funds flow, who's on first, who has what decision rights. So while sometimes the waters look kind of calm on the top, I think you should understand, one, that the groups themselves are undergoing enormous change. All the time, the focus of virtually every provider is to maintain the doctor-patient relationship. We don't want the patients to get a sense of this, that there is a lot of sort of uncertainty, but the fact of the matter is there actually is. So I won't, again, bore you with some of these kind of gigantic items that are happening in our marketplace, but I do actually want to focus on sort of the last bullet point here, which when we talk about reform of clinical delivery, it is very complicated sort of on the ground. There's lots of things we can talk about in Washington, payment reform, let's do the bundle, let's capitate this, but how that manifests itself at ground zero is very difficult and very different. So for example, when the collective we decide to embark on an ACO, that's really a joint initiative between the Yale Medical School or the School of Medicine and the hospital, Yale New Haven Hospital. They're separate corporate entities. that are bound by an affiliation agreement. So we're in this together, no matter how we sort of want to look at it slightly differently about how are docs incented or not, or whose salary is what. The reality is we have to figure this out together. This is a big ship, and this isn't really any different than many academic medical centers around the country. There's lots of idiosyncratic details that are different, whether it's in Chicago or Alabama, but the reality of it is most organizations are bound with very deep roots. So when you sort of impact one side, it's going to come out on the other. So these changes that are occurring at the high level really begin then to start to manifest themselves sort of, if you will, at the lower level on the day-to-day operations and thinking of the physician practice. So a couple of the bullet points here I think that are really important to us that we think about as providers are, how are we going to govern ourselves? What's going to be different? What kinds of relationships do we need to have to really be much more nimble and much more proactive and not always in a reactive mode? We really need to understand how to do clinical integration. This is a term that lots of folks use around the country, and quite frankly, it's not clear even what this means when people say it. It means very different things to different people. So the reality of it is also very hard to execute on, sort of maintaining that continuum of care in a seamless way. We just, Celia just mentioned the issue of fragmentation. It's rampant everywhere. But if you ask people, are you integrated, are you coordinated, everybody says yes. Well, we're not, just in case you're wondering. So we got a lot of work to do. It's just the reality of it. IT is another area. Massive investments have been made in hospitals and by physician groups to go onto these IT platforms. They're actually okay. They're not great. They're not good at all at decision support. They really rarely help us at the bedside other than to create more steps and more work to do for the provider when they're looking at the patient. So this is not to complain about them, but to sort of make it clear that these are not yet particularly helpful at the bedside. They're starting to merge, but it's pretty basic stuff at this point in time. So for those of you who aren't at the clinical interface, this is an area that there needs to be vast improvement before it really is truly a decision support to really help the provider at the bedside. And I suspect Harlan may have a few words on that later this afternoon because he's one of the few experts probably in the world on this area. But we have a lot of work to do there. When we talk about quality, again, a very nebulous term. Really, most of the quality we've done so far today has been reporting on things that, and how did those metrics get decided on? Lots of work groups, lots of thought went into them. But in the end, it was also things we could actually report. So it's a little bit of a circle there. So we report stuff we know we can report. So we can check the box. So the reality of it is we have a lot of work to do on defining quality and getting it organized. And I'll skip some of the issues of financial risk because I'm getting my cue card here that says get going. So this is really my second to last slide. And it's really about what are the key elements of an ACO. As Robert mentioned, a lot of these things, it's not really just a payment model. It's how the care is organized. It's what are the issues we need to deal with. I mentioned a little bit about the relationship of the hospital and the physicians. Key issues, though, are how do we rationalize care, what should be done where, and what part of the health system, who decides. As soon as those decisions are made, people get very political. They go sort of, I go in the dark politics. That's my term. I don't know what that means, but it sounds cool. But the reality of it is a lot of stuff that goes on underneath as soon as these decisions are sort of made. We certainly have to have a substantial primary care network, but we also have to have other things in a larger care delivery system, such as skilled nursing facilities, durable medical equipment, delivery mechanisms, home health, et cetera. So all these things are going to really round out a robust kind of delivery system that some people refer to as an ACO. The only other thing I wanted to say is once people sign up in whether it's in a capitated manner or in a sort of the ACO manner where they're assigned, the reality is we have an obligation to deliver excellent care to them because now they're not supposed to go anywhere else. So this notion of the patient experience and how we do that is very important. So actually we have to up our game when we get into these kinds of contractual relationships with the patients, because they have less choice at the end of the day. So my last comment really is, I think it begins to start for us as physicians to question how we're organized, how we're governed, how we should really focus on going forward in conjunction with our system. And the last word I have is actually to do all these transformations that are going to be required sort of at ground zero, you have to have a lot of trust. And that trust needs to be between providers, between the system players, between the payers. And right now, there's a lot of work to do on trust across the continuum of care. So I'll stop there and turn it over to Bob. Thanks.
Got it.
I'd like to start by thanking and congratulating the Solomon family and Abby Gluck, Fiona Scott Morton, all the people at Yale, Dean Robert Post. This is an extraordinary law school and an extraordinary university, but I think for the future of the Solomon Center, what makes it really extraordinary is it's also extraordinarily intimate. This is a university where all the people who are great thinkers and leaders in health and health policy can work together and work together effectively. And I think that's a distinct advantage over any other health law or health policy center that I've seen. So wonderful job. Abby and Fiona asked me to talk about the changing role of physicians in ACOs and other new care delivery models. I'm instead going to talk about changing physicians. Because a seldom recognized truth about physicians and any other profession is we're just people. And we're diverse in any given time, but we also change quite dramatically over time. And as generations of professions change, what those professions do and are interested in doing and are capable of doing changes quite dramatically. And we tend, especially in the interest group politics that characterizes a lot of our healthcare system, to caricature professions. The nurses think this, the doctors think this, the lawyers think that, and we forget that this will change over time. So what I actually want to do is tell an upbeat story about what I'm calling the promise of generational change in physicians. So this is Pete's neighborhood ACO. Back in 2010, when the ink on the Affordable Care Act was barely dry, I was flying home from Washington, D.C. with my family. I'd been in an IOM meeting with a lot of discussion about the ACA and new delivery models, including ACOs. And so my daughter, Abby, who was then 10 years old and a competent artist, was sitting next to me. And for lack of something better to do on the plane, I said, "Would you please draw for me the following?" And you can see what she drew. This is Pete's neighborhood ACO. It's a small building. It stands on a street corner. It has on its awning Pete's in clear letters, and then a whole bunch of things that have been crossed out: HMOs, PHOs, home health, physician-sponsored organizations, and now ACO proudly displayed with a sign in the windows that says, "We happily accept Medicare." Okay. This is not what we're trying to do. Okay. But in fact, every generation of health reform has tried to capture the enormous trust we place in physicians, in both their expertise and their ethics, to be the leaders of the new form of system. And we've done this in each generation, as I've said, and most recently we've done this in the ACA, among other things, around ACOs. Now, if you take, so let me frame this generational transformation first in terms of physician leaders. So let's start with a physician leader, Dr. Bill Kissick, who served in the federal government in the 1950s and the 1960s, was there at the creation of Medicare. And he is one of the people who's most associated with the notion of health policy as an iron triangle of access and cost and quality. An iron triangle meaning that a gain in any one comes at the expense of the other two. And you see a quote here from Kissick's 1994 book that says, "No society in the world has ever been or will ever be able to afford providing all the health services its population is capable of utilizing." So that's a physician thought leader a generation ago. We've gone from Bill Kissick to Don Berwick. Don Berwick's frame is entirely different. Don Berwick's frame is the IHI's triple aim. It's improving the patient experience of care, it's improving the health of populations, it's reducing the per capita cost of healthcare, and guess what? It's doing all three simultaneously. It's not an iron triangle. And associated with what success will mean is the IOMs crossing the quality chasm, 6 components of an effective, high-performing healthcare system. So let's just look in terms of the framing of the physician's role at the transition from Kissick's iron triangle to another triple formulation, Berwick's triple aim. The Kissick formulation doesn't let doctors do much beyond their usual capable work, except it raises the specter of physician participation in rationing. It's kind of an invitation to bedside rationing. This is a zero-sum system. All care is scientific and necessary. If doctors are going to do anything other than the best thing, it's either because they are under the influence of financial conflicts that should be erased or avoided, or because we're recruiting them to do something the traditional physician ethics opposes, which is ration care for individual patients. Other groups run around trying to medicalize all their problems in the hope of accessing this incredibly generous stream of funding that is subject to a not usually honored iron triangle, and there's some hope that in the future there will be a definitive political settlement that'll work this all out for the United States as it's been worked out in other countries. That's the old frame. It's still relevant. It's still there. Redistribution is real. Rationing is probably real, but the Berwick frame is entirely different. The triple aim takes us way off the Pareto frontier, where there's all sorts of things that can be done that makes essentially everybody better off. It's about reducing waste, reducing inefficiency, moving to preventive care, moving into what we call as the upstream of healthcare, focusing on social determinants of health as well as healthcare efficiency, and importantly, it's not about definitive political settlements. It's about incremental change from within, and incremental change from within that can be led by physicians. Now, you put this transition in the world of the old generation of doctors, and ACOs look scary, difficult, challenging. And I don't want to caricature the comparison, but I do want to be hopeful at the end. The traditional generations see this as a battle between primary care, which we've always undervalued on the physician side, and physician specialists whom we've tended to overvalue. At least it's framed by the older generation. It's a battle for clinical control, physicians versus hospitals versus health plans. It's a question of whose patient is this? Is this still my patient, or back in the 90s, doctors said, I now rent my patients from managed care organizations. They're not my patients at all. It's about this scary thing called population ethics that gets into the notion of rationing one patient's care to achieve some greater good. It's the weirdness of the electronic medical record. It's the discomfort associated with being observed and measured, and it's about changing from an undercapitalized, day-to-day cash flow financial basis to something that is either risk-oriented or at least corporate with a substantial capital investment attached. And all of these things in ACOs are deeply disturbing to the older generations of physicians. But here's the hopeful story. Emerging physicians actually are not trained this way and are not the same people. And for emerging physicians, working together in interprofessional teams, thinking about systems of care, orienting to the patient, not I own this patient, this is my patient that I need to take care of, but I'm going to work with the patient. Thinking about population health systematically, working with big data. It's not some electronic medical record and I have to sit at a keyboard and isn't this weird and counterproductive. It's what can we really do with data to improve the system? And being accountable. Being transparent, being accountable for performance is now in the newer generations an ingrained aspect of training, as is the notion that they are going to have, someone called it less entrepreneurial lives, I might just call it more balanced lives, where they're going to work in more industrialized, more corporate settings, and they're going to be happy in those roles, whether they're as clinicians or as leaders. And how do we get there? And this is my last slide. Over the last 5 to 10 years, there has been an extraordinary transformation in medical education. And this transformation is not, to my mind, matched in any sense by what's happening in legal education. I wish it were. The first changes were about how physicians learn, and the more recent changes, still beginning and ongoing, are about what physicians learn. Physicians now learn by building portfolios, accumulating work that people see over a long course of time, about flipped classrooms where they work in groups and solve problems, about competencies and milestones where they're subject to constant scrutiny and assessment, but the assessment is intended to be formative, not just summative, not just the final exam and what you get to do. And a strong commitment that I think is real in many, many institutions to interprofessional education, working with nursing students, pharmacy students, social work students, and others to deliver healthcare in a much more ACO-compatible population health orientation. And now we're learning new things as well. We're learning communication and teamwork. We're learning data analytics. We're learning, as primary care physicians, population health management skills, and we're engaged now at the training stage as well as the practice stage in redesigning how healthcare delivery occurs. And if you think about this, I mean, the hopeful story here is this is really very compatible with the Berwick triple aim formulation, and not totally leaving aside Kissack's iron triangle of cost, quality, and access. This is something that I think new generations of physicians are eager to do and quite capable of doing. Thank you.
So while I try and figure out loosely how to...
just escape.
I need to escape is what I'm being told. I'm not sure I know fully what that means. But by a show of hands, how many people... I'm not sure my slides are up here. I can't find them. I may go through them. Sorry. No, it'll take a second. Happy did they get loaded? So by a show of hands, how many people think that ACOs are the savior of our future? They're the panacea. So that's nobody. And they're doomed to failure like many other related buzzwords. They got 5 people. I could have done this voice votes like the Parliament, the British Parliament. Okay. So let me go through my slides that I happen to have, and maybe they will or won't get up on the screen. It doesn't really matter all that much. So I was going to start by sort of giving my definition of ACOs. And again, I think both definitions you've heard are sort of right. Part of it's an organization. Part of it's a payment model. My view is it's an entity capable of taking clinical and fiscal responsibility for care, and typically paid in a way where they're given a budget target. They get to share the savings if they spend less than the budget target, and in some models they have to pay more if they exceed the budget target. There's a question about how they differ from all the buzzwords that Bill mentioned a minute ago, HMOs, PPOs, EPOs. It's always 3 letters, mostly 3 letters. A few things. In ACOs, people are attributed to the model. They don't sign up like an insurance plan. And the ACOs don't set premiums. Insurance plans, other population models, they get to set the premiums. The ACOs don't get to set the premiums. The ACOs don't control benefit design, so it's hard to keep people in the network in a whole variety of ways. In an ACO, patients can generally go anywhere. In an HMO, there's a much stronger set of controls for where the patients can go in the network. And of course, ACOs, at least the organizations that are ACOs, they serve both ACO patients and a huge amount of fee-for-service patients, and that has ramifications for the economics of ACOs. We've done some evaluations of ACOs. We did an evaluation in Massachusetts of the alternative quality contract. By several years out, 3 or 4 years out, the ACOs in general across multiple cohorts were saving about 10%. Half of that was based on reductions in price. Now in the commercial market, which the AQC is in, there's wide variation in price. So the point is physicians shop if you give them the incentives to shop. So if you're concerned about price, there's a regulatory way of dealing with it, but there's also a market-based dealing with it. And you see in some of these models that ACOs will shop. In the Medicare program, where there's much less price variation and much less experience, we've seen results more similar to our very first year AQC results of a savings of a little bit more than 1%. So many people say with 30% waste, we're failing dismally. We've only saved a little more than 1%. My view is if someone offers you $1 and gives you a dime, take the dime. Maybe eventually you'll get $1, but the point is it's not a failure if you save a little bit. There's definitely better places to go. Interestingly, most of those savings have come by reductions in post-acute care and transferring site of care from hospital outpatient departments, which are very highly paid for the same service, to physician offices that are paid less for the same service. That's at least what the empirical result shows us. So there's this question about, actually I should add, the evidence is strong that quality does not go down in the ACOs. In fact, the sickest patients tend to do the best because the ACOs do, I think everything that Paul said, is they reach out to the sickest patients, and when they reach out to the sickest patients, they end up touching them more in a whole variety of ways. That's not a medical comment, but the patients end up being happier with that level of interaction, and so you get better quality and you get better patient satisfaction in these models. I'm good. I'm on a roll. And maybe are people understanding anything I'm saying?
Raise your hand if you do.
Oh, I'm sorry. It's totally my fault. I ran them by Fiona, but she's not the maven of everything that I thought. But maybe she is. I'm sorry. I'm sorry. It's my fault completely. The one with the wrong date and the misspelling? Yes, no, exactly. No, I don't. Do I get my time back? I'm joking. So anyway, the basic rule of thumb in ACOs, the way the idea is supposed to work is when organizations reduce utilization of healthcare services, they get to share the savings. The basic idea is the amount you pay for someone to go to a hospital is partly cost, partly profit. What you can do is by reducing utilization, you avoid the avoidable cost part. That avoidable cost part can be given back to the organization. So some portion of it can go back to the organizations, some portion of it can go to the payers, and you could end up with the organizations having a better financial profile and the payers of a better financial profile if you reduce the utilization of services that you otherwise wouldn't want to deliver. That's the basic model, the basic economics of how you can get these models to work. The key is to take the savings associated with more efficiency or price for that matter and spread that out across folks so everybody wins. There are some challenges with that, which is now really getting to the sort of main point of what I wanted to make and challenges with this sort of integration. The first one is, imagine that the ACO is hospital-based, and many, although certainly not all of them are. When you reduce the use of hospitalization, there's a lot of fixed costs that went in there. The hospital only gets rid of the variable cost, so the amount of money going back to the organization is really only the variable portion of it. If you have a non-hospital-based ACO and you reduce the hospitalization, from the ACO's perspective, you're saving the entire price that you would have paid for that hospitalization. It's much more lucrative to deal with it if you have hospitals outside of your ACO in that model. But there's some problems with that. There's a lot of reasons why you might want to have your hospital in the ACO. There's coordination efficiencies with the primary care and the specialists between the hospitals and post-acute. This whole theory of integration, it may or may not work better if you are sort of in a hospital. Hospitals have more access to capital, so there's a lot of data infrastructure that you might be able to do better if you're sort of hospital-based, although that requires some assumptions about capital markets and how well folks can get capital. There's certain questions about managerial talent, and I won't make any, normative adjustments about that, but the view is hospitals are big organizations with a lot of managers. Most of this is not a physician in their office deciding how to practice medicine. Most of these are sophisticated organizations with management in the middle working on a whole series of programs, and maybe or maybe not that can work better in big hospital systems. What I think the big concern is if you think the waste in the system is in the hospital, and it may or may not be, but if you think the goal to save money is to reduce hospitalizations, it turns out it's harder to do that in an organization that has a lot of hospital dominance around the table. So think about when you want to reduce services, what services you want to reduce, and whether or not you want the people who historically have made money providing those services around the table, recognizing that if you reduce those services, there's a whole bunch of other people that those organizations serve that you don't necessarily want to reduce their use. So for example, if a hospital puts in a readmission reduction program and makes a ton of money because their ACO patients are getting readmitted less, but now they're losing a lot of fee-for-service patient admissions, that's a complicated dynamic you have to work through the math of to decide what you want to do. It turns out empirically, we did an analysis of pioneer ACOs, and ACOs that were integrated with hospitals had the exact same savings as ACOs that were not integrated with hospitals, and my sense is, at least in the near term, those two forces loosely cancel out, and we will have to see in the long run which does better. But right now, empirically, it is not clear whether the access to capital, the managerial talent, the coordination activities, all that stuff of hospital-based ACOs outweighs sort of the fundamental incentive of greater incentives to save money if you're in a large physician-based but not hospital-oriented ACO. And that dynamic, I think, will just continue. in the end of the day, there is a question I just want to respond to some of the things Bill said about sort of what's new is I don't think people are running to these models because these models are great or we know how to do it or there's some sort of panacea to everything. They're going to be really hard. I'm not sure they'll be successful. But people are running towards them because the alternative looks so bad, right? And it's not just that we've screwed up the fee-for-service system, so I agree completely with Bob's comment, the fee-for-service system is screwed up and getting it better would be better, right? But that's not the biggest problem in fee-for-service. The biggest problem in fee-for-service is we've placed the trajectory of fees on a very low level. And while I agree we pay a lot and have very high fees in this country, it is not clear if we cut the fees, we will end up exactly where we want to be. We don't know what the response is going to be if we cut fees dramatically. The ACO model can have some type of shopping. It remains to be seen how far and how fast we can cut certain fees. But for organizations that are not in these types of models, you're constantly going to have to provide more services to keep revenue. These models allow organizations that do what we want them to do to capture the efficiencies associated with that. And that, I think, is the strongest case for these type of models. They allow us to integrate across the population span what happens, and then if we do that, there's a possibility of success, and frankly, we can put ourselves on a more sustainable global population-based budget, but that requires all the transformation that Paul talked about that is really hard. It requires a lot of cultural change. I really have no idea how well we'll be able to make that pivot, but it strikes me that the alternative looks particularly bad. So that's my take on ACOs. Thank you. My slides were brilliant.
Krumholtz is going to comment on going to give them a grade of A through F.
So Mike knows now what happens when we invite people from Harvard to come to. We just diss their slides.
No,
you did a great job. Anyway, I wanted to extend, I thought Bill articulated well, I wanted to extend my thanks to the Solomon family and to Abby and Fiona for putting together a great conference. I do think it's one of the special features of Yale that scholarship matters, but it's scholarship combined with action, and that we have an intimate community where people get to know each other well. We work well across places. We try to treat people nice. Mike, we'll do better next time. But
I was nice. You guys have been wonderful.
But it's a great environment to work in. It's a great place to be, and it's a great honor to be part of this conference. So what a terrific panel. I'm a commenter. I really wanted to at least take a moment to say that I learned something from each of the speakers, and I just wanted to say the highlights for me were, as Bob sort of reflects, sometimes we're working on the wrong thing, or we have to make sure that we're working on the right thing all the time. And driving down utilization is not just a particular goal. We want to bring value to the healthcare system. We want to make sure the patients are getting what they need, and we also have to pay attention to the prices. And somebody tweeted that price eats utilization for lunch. That actually we have to pay attention to where the prices are being driven from and what's being responsible from it. I thought Cecilia, the one thing that I'll remember from her talk in particular, and she has this broad-based experience from one of the most successful organizations in healthcare that there is the idea of culture and infrastructure. And I don't think we can diminish the importance of this. As we're starting to talk about new models and change management, we have to pay a lot of attention to the ingrained behaviors and approaches that we've accepted as being normative and we've rarely questioned. And yet really to be able to reach the highest levels, it's a cultural shift that will have to occur. The places that are achieving the best have to do that, supported by an infrastructure that puts people in the strongest position to succeed. I think Paul gave a nice explanation of what goes on the ground, and I think he said two things that again, they had many good things to say, but the particular thing for me was there is often this discordance between these high-level talks and actually trying to implement on the ground, where day to day you're trying to make change in an embedded system that exists the way it exists for particular reasons. There are strong forces that are keeping a system in the way that it is, and the other issues that he said, trust. You've got to have trust that this is going to go the right way. Bill, remarkable talk, eloquent about how we need to be thinking about how these new structures fit with changing ways in which medicine will be practiced, our changing assumptions about the way things are, in a spirit of generosity, in a culture of teamwork, in a way in which we think about a patient's episode of the way that they experience illness, not a venue of care, not a billing episode, but rather a way that their lives are intersecting with the illness that they're experiencing. an ACO-type construct makes a lot of sense and actually creates a very different way of thinking from one that's less generous, more about what's in it for each of the actors in the system, and more about putting the patients first. And then Michael, I thought, and we were kidding you, but it is hard to stand up without slides. He did a great job. He's got a lot to say, and principally a lot about the incentives and trade-offs, I think, that exists here, and thinking about what the consequences are, what are the various forces pushing in different directions, what can be what we're trying to achieve, what can be the unintended consequences, what's the best way to structure these things. These are all remain to be open questions. My 2 cents about this are that I think that we shouldn't be having talks, and this is my own view, about what is an ACO exactly, but what's the future state we're trying to get to, and how do we construct a healthcare system that best achieves that future state. The ACO as a construct, as a vision, which can be understood in many different ways, depending on who you're talking about, is about trying to shift from an area where people are fighting each other for RVUs, relative value units. What have I done? What am I going to get paid? To a notion of actually putting the patient's experience and their results firmly in front and saying, how are we going to configure the system to do that? I can't succeed unless the rest of my team does well. I can be the very best at what I do in the world, but if I'm not surrounded by people who are also excelling, the patient's not going to get the very best result. When people are scurrying around trying to get their own credit for what they're doing, they're not thinking about it from the patient perspective. This is going to take our understanding of putting the patients in the center, clearly understanding the patient's rights in all this as all this gets moved. They're often outside of this. I thought another important thing you heard here, patients are being attributed to ACO without their choice. So where are the patient's rights? How can they be expressed? How can we ensure that their agency over their bodies and over their choices are maintained? How can that be strengthened so that they're firmly in front? Second, and getting to the point where Paul was saying, the data, having a smart system, being accountable and transparent, ensuring that the data are clear, crisp, and that they're helping us improve. We've got the learning that's going on. And in addition, we're willing to share, and we're allowing patients to have their own data and to move it. I think all of these are important facets. And finally, in the last minute, we can't forget the frontline providers in this. There are stark numbers about the burnout that's occurring within the provider community, the kind of experience that people are having every day by trying to keep up, being forced to look into monitors instead of patients' eyes, being forced to account for every minute. The way that the pressures are accumulating are not the old-time pressures where it's hard to work with an individual as I try to help them on their journey through their illness, but they become organizational pressures that are extraordinarily frustrating. And if a third of our people are so burned out that they answer a question about empathy, saying, I cannot feel empathy for my patients anymore because I'm just trying to get through the day, then we're eliminating the possibility that we're truly going to have a high-quality system. So the provider's experience within this system also has to be taken into account, because in order to really reach where we're trying to reach, people have to be motivated, excited. They have to find joy in the work that they're doing. We have to figure out ways in which our organizations are going to configure that, incentivize it, reward it, and ultimately deliver it for everyone's benefit. Thank you.
So on listening to this, I have 2 questions I want to ask, and this panel, I'm really interested in their answers, and then maybe we can open it up to the audience. So the first question, so there is no disagreement that a payment system that pays to do more is broken and will never control the cost of health care. And nobody would ever argue with the fact that a payment based on value is what we should be doing. So value is the quality divided by cost. And the fear that I have, that I think many of my peers have, is we have learned how to measure cost, but we're not so good at measuring quality. And if you can't measure quality, then you end up just basing it on cost. And so when you look at quality indicators and you look at hospital ratings based on qualities, you'll see in one rating system the hospital's top 5%, the next rating system they're the bottom 20%. So I want to ask the panel, do you think we will ever be able to really have metrics on quality to the point where ACOs will not just be spend less?
Yes.
My concern is less that we will only have costs and therefore will ignore quality, but that we'll take a few quality measures that are pretty lousy and believe that they're real, and important, and then give credence to what doesn't deserve to be credence. Now, in a paper that Harlan and I and Peter Pronovost wrote a few years ago, we do talk about needing to move performance measurement away from the individual to the organization. And we have better metrics, more statistical validity, population health. I think we can approach measurement. And I still have the concern that we will be missing some things. But I think we can be much better off if we actually give up the idea that we can measure every individual Medicare physician and put a rating on them. I find it extraordinary that, in particular, that 20 Republican doctors went along with the idea that Medicare, that CMS should be putting a rating on every doctor in this country. It's really quite extraordinary. That's what's in this legislation. But I do think we can move to measuring at the organizational level for populations, and that's where where we can make a lot of progress. That is a yes. That's my goal.
I'll add a yes. I agree with Bob on everything he said. What I'd add is that in kind of the first generation of measurement in the managed care of the 90s, one of the colossal mistakes that we all made was having all of the scientific and clinical outcomes be generated from the expert side and having the patient side only be things like satisfaction measures. And I think one of the most promising trends now is to have a set of patient-reported outcome measures that are both subjective and extremely clinically relevant at the same time.
Well, so our conflict is, my conflict and my group's conflict is we developed some of the ACO measures for CMS. And, you know, I mean, I think we believe that rigorously developed measures, I want to highlight Elizabeth Dry, who's in the audience, who's been leading that effort for us. And we believe that rigorously developed measures that capture organizational characteristics can be quite powerful as a catalyst for improvement. And, you know, these have to apply the strongest scientific principles. They can't be perfect. There are no perfect measures, but the issue is that we're inundated with measures from different directions that are of various quality. And we have to come together as a group to decide what's most important. I also think that as the quality of data available improves and the basic infrastructure of data across institutions of transparency improves, we'll get there. We're developing PROM measures for CMS also, and we're developing electronic health record measures, so we'll reduce the burden on that. But, you know, I think it has to be that we find what's important to patients and we reflect back how we're doing in those areas, and we make that clear and transparent. I just don't think we have a choice, and it's not good enough for us to say it's difficult. We've got to find the ways to do it, and we've got to overcome some things. As Bob said, my final thing about this is I do think measuring individual physicians, as we said in that report, and I've said many times publicly, is folly because the physicians are very different in the kinds of patients they see. Their numbers are too small to come up with really highly reliable and estimates, and it goes against the grain for what we're trying to create in team-based care. So really what we want to say is that the institution's accountable, like United Airlines is accountable, and let them figure out who the good pilots are and make sure that the people are in the right position doing the right work, the engineers, people filling the plane with fuel, but don't put us in a position where we're fragmenting each individual physician and you have to get on a flight and decide who the pilot is and look up that pilot's record. I think you want to know that you're confident about the airline, and that's where we should be. Our own institutions need to be accountable, and our own numbers will reflect the net sum of the people who are in there.
My answer is also yes, but I want to pick up on a point that Ben made this morning, which is that I think you really get quality data when you marry claims data with clinical data. And there's been limited options for doing that at usually provider delivery system level. They have not historically had electronic medical records. Now that they do, they don't have the claims data. So I think in this era of big data, we will absolutely get there, but it's just going to require more integration.
I make one additional very quick point is I think one of my concerns about reliance on measuring everything is that if something can't well be measured, it's ignored. So I was on an Institute of Medicine panel recently on diagnostic errors. It turns out pretty good research shows that everywhere you look in health delivery, 5 to 15% of encounters results in a misdiagnosis or a misdiagnosis, many of them serious. We can't measure misdiagnoses. It's not on a claim form that I did putting the wrong diagnosis. You can do some decent work and research. It is on nobody's policy agenda, even though most doctors would agree that a fundamental core responsibility they have is to make accurate diagnoses. It's multifactorial. We should be working on it, but I think we now have a tendency to give so much credence to what we can measure that we ignore issues that are not susceptible to easy measurement.
So I think in the end, I was too brief before, it's about the measurement system, not the measures. And I think you could build a measurement system around a set of measures where you could begin to figure out where you have to look if you think organizations are providing substandard care, as opposed to measuring it nationally in a variety of ways. And so I think we're really on the right path towards coming up for a measurement system, and the measurement systems will vary based on how you intend to use the measures. So we have a long way to go, but you said ever, so yes, we'll do it.
Should have been a lawyer. So, okay, here's my second question. So this is obviously a transition. Kaiser started there, but most other health systems are making this transition. And I think it was maybe Bob who said this. When I look at the CEOs of the large health systems, they pay their bills with fee-for-service, and they have accountable care organizations so they can speak at meetings like this. And so the question is, how does a organization, how does a physician sit there when they're halfway through that transition and half of their patients they're getting paid to do more, and the other half of their patients they're in a system where it's in their interest to do less? How can we make that transition?
You know, I talked to a couple of very, what I consider to be people who have been very successful in doing this, and all of them said that it's about a couple of things. One is about an absolute commitment and vision from the top, is that, yes, you've got all kinds of things going on, all kinds of incentives, but if leadership and the governing board is committed to an end state that is very different from today, I think the transition is a lot smoother. The other thing I would say is there's a tipping point. I don't know what the right number is, but it's not 5%. You have to get up into 30, 40. I don't even think you need to be at 50 or more. I just think it has to be significant enough that you can start to change your business model around it.
Let me go, because I've thought about this a fair amount. I saw the results of the physician group practice demo, which was the precursor, the forerunner to the whole ACO program and the Affordable Care Act, which sort of described what the 9 or 10, I forget which, organizations were doing to try to generate savings to get an upside-only bonus. And it was all about basically doing congestive heart failure clinics and some home care. Heart failure patients are not particularly lucrative to hospitals. Nobody was calling in their orthopedist or their cardiologist and saying you're doing too many joint replacements or too many stent placements in people with stable coronary disease. When the incentives are such that that happens, I will believe that we then have a new set of incentives. Right now, which is why I'm sort of frustrated by the current payment models, which use the terms like people need on-ramps, they need training wheels, they need to get into this slowly. I understand why an organization that hasn't been taking risks doesn't want to be taking 100% risk, so you use risk corridors, but the marginal incentive should be different than it is under fee-for-service, and I don't think that an upside-only shared savings model built on fee-for-service gets you there. So I don't think, for the most part, the ACO people now have to worry about costs, but the docs on the line, I don't think, are worrying about it.
Michael.
Yeah, so I think in the end of the day, success isn't going to be because of the incentives facing docs on the line. And I think this is really the fundamental challenge. The incentives are going to be, you're going to be successful or not based on where the organizations can change. And the organizations can have a separate level of management, will work better to some extent if both the organizations are big enough to support that level of management. And frankly, then you have this problem of fragmentation of the insurers. So the problem you raise is real. There's a lot of free riding and spillover potential. It turns out the more fragmented the insurance market is, the harder it is to necessarily get that right, although there's some real reasons why you might want a competitive, note the subtle shift in language, insurance market. And so
I don't think we have actually figured out how to do this except in places where there has been a strong role for policy to push things along, because there is a coordination component, and more thought about the interplay between the behavior and the structure of the financing market and the behavior and the structure of the delivery market is going to be crucial if we're going to solve this basic problem. And it is not going to be because there's a physician on the ground that's deciding to practice a certain way. It's because of the incentives that the associated organizations place around that physician, and that's complex.
Let me offer a friendly amendment to what Bob Berenson said, and then two quick observations. The friendly amendment is, Bob said the marginal incentives have to change, and I think what he really meant was that the modal incentives have to change. This can't be an add-on. This can't be one thing just at the edge of a system that is based on traditional payment models, but kind of the heart of the model has to change, even if there are cushions in transition. The two quick thoughts. One is in terms of the big picture incentives for system change, the political climate has to be relatively stable and have a relatively clear direction, which it has had for the last 5 to 10 years. But if people get the sense that we are going to quickly reverse course on major aspects of the healthcare system and the way it's heading, then the innovative generation goes away, maybe with generous severance packages, and the people who just keep the bills paid and the lights on take over again. And we've seen that happen in the last 20 years, and I don't want to see it happen again. And then the related last thought comes back to generational change. I mean, I think this transition period is actually a good one because we are having a nice repopulation of health system leadership, especially at the physician level, from the newer generations. I was at a medical education reform meeting that Victor Fuchs held a couple of years ago, and someone very authoritative, who meets with many medical deans very often, said, look, right now, almost all the people I know who are running major academic medical centers are just hoping they can reach retirement age before they have to change. And that was a very sad, but I think quite honest observation. We now are in enough of, I think, transition period with some direction that we're getting a replenishment of the leadership.
Yeah, I think the last comment on this topic is I do agree the system has to be, forthcoming in how it redeploys even its capital. So the physician, certainly the specialist, isn't going to change what they do when they see the patient. At the end of the day, you're going to do the right thing regardless of the payment structure. I think if the system is organized in such a way that patients who come in are assessed and sort of driven in the right way, for example, dealing with an issue we haven't talked about like social determinants of care, whether they're primary care providers or even in the ED, how we manage that patient way before they come in is going to have a huge impact on the system. So once they get to the surgeon or the ENT, they're probably going to do whatever needs to be done. So I think the commitment has to be very early in the process of the population itself to really get people all rowing in the same way.
Nancy.
Yeah. So I think some of you know that I work with medical students. And I want to say, first of all, thank you to Harlan for bringing in the factor of the satisfied caregiver and making sure that in all these systems that the people who are actually delivering care to the patients, which, by the way, I mean, we talk about patients as if they're some faraway entity. They're actually us. They're the people in this room, and they're the relatives of the people in this room. And I think when we get to the hospital or we get to the clinic or we get to the ACO or the caregiver, what we really wish for is somebody who cares deeply about us, enjoys their work, and wants to do the good job. So my question has to do with the fact that I've been sitting in the back row there with some of my students. And so I want to ask you, what is it about the healthcare future that you've painted for us or that you think we might be able to achieve that makes them feel that they made the right decision? To medical school rather than law school or business school, which any of them could have made that choice as well, and to accrue $100,000 or more of debt because they want to care about people. And also, something that has not been said is the fact that there are no additional residency training programs, and there are more and more people in that pipeline. So it's you know, if we leave here on a dismal note for the future practitioners of medicine, it would really not be good. So give them some hope.
Yeah, I agree. So I think, yeah. So I guess I'd say a few things. The first one is law and business stink. The real point is everything's relative. And I think compared to the world that they would be in a fee-for-service world where you have to do more and more and more and more and visits get shorter and shorter, there's a lot more flexibility in all of these models for well-run organizations to structure care in the workday in ways that are rewarding to providers relative to a world in which you're driven by ever-increasing demands on volume. So I actually think this is likely to be a better environment to practice in, relatively speaking, than where we would go otherwise. That's a personal view.
Applications to medical school are up, so.
Yeah, because the alternatives.
So I just got a message from the director of the Solomon Center that I can take one more question. So you're it, Gail.
Okay, sorry. Gail Denoff from Mercy Medicine. So we heard a lot today from all different disciplines, but one of the things that we didn't even talk about much were that most of healthcare costs are end of life in the last year of life. We didn't discuss anything about what we're going to do about that, because as an emergency physician, I'm usually doing the discussion way after when I should be. From the legal system, because I get a lot of pushback from conservators who really don't know anything about the patient, to whether from the families, to other doctors who not addressed it, to what are we going to do when I get you in a very information poor, fast-paced, having to make decisions. So we haven't talked about that. I'm just opening it up to think about what any of you think about that.
I'll go first. The data for Medicare has been consistent now for a couple of decades that about 27% of spending occurs in the last year of life, and most of that is in the last month of life, and that's somewhat understandable. To me, one of the positive things, I tend to be a gloomy guy about a lot of these changes, but one of the very positive things is I don't believe baby boomers are going to accept a world in which they wind up dying in an ICU. They are going to, we've had hospice. There's going to be a movement for adding a palliative care benefit in Medicare, so it doesn't have to be part of, so you don't have to agree to not get any ongoing medical or clinical care while you're in hospice. People are going to want home visiting models. In fact, one of the successful demonstrations in Medicare, there haven't been a lot of clearly positive results, but one has been in something called Independence at Home, which is very basically geriatric home visiting with doctors and nurses who go to patients at their home. This is not somebody who's at the end of life necessarily, but they are frail, meet the home, and many often meet the criteria for being homebound. So I just think there will be a cultural change, essentially, that is going to force Medicare rules to change and for providers to respond. So I actually have some hopes in that area.
Okay, you go first, William, then Michael.
So, I mean, I'll agree with Bob, and I'll make, since it was a personal question, I'll give a personal answer. Personal stories help here. I mean, so someone was talking about HIPAA. Well, I had 2 hips replaced in the last 7 months, and I've given talks on volume to value at the American Academy of Orthopedic Surgeons, and I get to lead with a slide showing my hospital bill. Because I can show my own records without violating HIPAA. But with respect to end of life, you know, I helped my dad, a retired physician at 96, get through a last year of life with heart failure. And together we managed it exceedingly well. And he died peacefully at home in his apartment on the east side of Manhattan. Which is an enormously hard thing to do, actually, but we managed it, and I agree with Bob that a cultural change hopefully will make that a much easier thing to do in the future.
So 2 quick responses. The first one is, it's not as big a deal what share of spending any particular category is, it's how rapidly it's growing. We're not trying to cut spending, we're actually trying to control the rate of growth in spending. So I think there's room to spend on things. That said, end of life is particularly challenging. And again, I want to come back to the theme of what's the alternative, and I'll tell a personal story of my grandmother who died in hospice. She was 95, it was her 2nd hospice stay. She was first at a level 4 hospice, and then they decided she might live too long, and she had to drop down to a level 1 hospice, and the
reimbursement for level 1 fee-for-service hospice is lower than the reimbursement for level 4 fee-for-service hospice. So the wonderful hospice she was in that had workers that were angels, I aspire to raise my children as nicely, to be as good as people as the hospice workers were not, she was going to have to leave there. So even though her life expectancy was somewhere around a week or 2, maybe 3, they were going to have to kick her out of her nice hospice, which was part of an inpatient facility, to some other hospice because the reimbursement was changing because the fee-for-service code that she had to certify was actually that she was going to live maybe longer than they actually thought for the level 4 hospice as opposed to level 1 hospice. So then we had to have a conversation about what we wanted to do and when we were going to rent her apartment and how that fit into the coding structures in the fee-for-service end-of-life hospice system. The point is not about my grandmother. The point is, in a broader model that doesn't require you to justify how long someone's going to live and change the payment rate based on your perception of whether they're going to live 1 week, 2 weeks, or 4 weeks, and gives you some flexibility what you do under sort of a fixed budget, you can have a lot more flexibility to do what you want than you can in the alternative fee-for-service system that, because of concerns about excess use of volume with incredible explosion of hospice care, ends up putting in administrative rules that will drive wonderful people absolutely bonkers to try and get them to work. So I think although there are a lot of risks and concerns about these models and a real need to provide better quality measures, they offer the potential for rationalizing the aspects of care compared to an alternative, which I have to say is a stunningly low bar, and particularly a low bar around aspects of end-of-life care.
So let me close by saying the most common expression I heard during this panel was, "I agree with Bob." As I just want to say, as a dean whose name is Bob, I've never heard anyone say that. I want to thank the panel. I think this was an excellent discussion, a lot of wisdom up here, and a lot to do for accountable care organizations. I think there's a coffee break now and return here at 4 o'clock. Thank you.
I have strict instructions from Abby that we should get started. And anybody who knows Abby knows if you get a strict instruction, you damn well better follow it. So I'm going to do that. I'm very happy to welcome you to the final panel on vertical integration, the new frontier in consolidation, the competitive implications and enforcement. I can assure you that all the panelists are well aware that they are the only people standing between you and the reception. They will adhere to the timing, and we will conclude the session at an hour and 15 minutes from now. To set a little bit of the context, vertical integration, which entails the integrating the moving together of firms at different stages of a production process. So either integrating backward into suppliers or integrating forward into customers, has an interesting history. There have been those who have said that the vertical integration, if you see it, must be the result of efficiency. It must be because it's making everything better for everyone. And then there are those who say that if you see a company stretching either forward or back, it has to be for malevolent reasons. The discussion of this area is being informed and enlightened by two Nobel Prize winners in particular, Ronald Coase and Oliver Williamson, and their work encapsulated in another enterprise at the law school, which joins together law, economics, and organization, and the central insight being one of comparative institutional analysis, that sometimes it is better to run relations through markets, and sometimes it is better to run relations within firms. So our panelists today will talk about this important area, in particular the hospital acquisition of physician practices and the challenges that poses. And this is truly a frontier issue. One way in which one can see that is that the horizontal merger guidelines of the Antitrust Division and the Federal Trade Commission jointly have been in existence since 1982 and have gone through several revisions. The non-horizontal or vertical merger guidelines have in fact appeared only once and not been revised. So this is a frontier issue not only in healthcare but throughout, and the key question of weighing the costs of this integration and the benefits of this integration are at the heart of the discussion we'll have this afternoon. And we have an excellent group of panelists to talk to us about this. So first is Deborah Haas-Wilson, who is a visiting professor of public policy at the Kennedy School, and the Marilyn Carlson Nelson Professor of Economics at Smith College. Excuse me. Henry Sue, who is in the office of the chair, Edith Ramirez at the Federal Trade Commission, Toby Singer, who is a partner at Jones Day, Brent Henry, a vice president and general counsel of the Partners Healthcare, and two folks making a joint presentation, Erin Fuse-Brown, an assistant professor of law at Georgia State University College of Law, and Jamie King, professor of law at UC Hastings College of Law, and associate dean and co-director of the University of California, San Francisco, University of California, Hastings Consortium on Science, Law, and Health Policy. If you'd like further information about the speakers, you will find that in the biographical statements that were distributed to you. So with that, we'll start with Deborah.
Thank you so much for inviting me, Abby and Fiona. You guys have put together a fantastic day of sessions. Thank you, other panelists. You've done a great job. You've actually set the bar very high, so hopefully we can keep up. We are going to be talking about the issue of vertical integration, different than what we have been hearing about up to this point, where it's been more about horizontal integration, horizontal being when a hospital integrates or merges with another hospital, or a physician practice integrates through acquisition or merger with another physician practice. We're going to be focusing particularly on the vertical integration between hospitals and physicians. In particular, I'm going to start off by telling you about a vertical acquisition. I had the privilege of working with the attorneys on the plaintiff's side in this case, and it was all about vertical integration. It was a very large hospital system acquiring a very large practice of physicians. But before I dive into that, the term competition has been tossed around all day long, and Marty Gaynor started to talk a little bit about it. I just want to emphasize some of the points that he made, because I think it's really crucial to understand how this type of vertical integration would actually impact markets. So he mentioned that it's a two-stage process, that we're not selling paper clips here. And in that two-stage process, the price that is paid, reimbursed to the hospital or the physician practice is actually determined in stage one. Stage one being when the health insurers sit down at the negotiation table with the healthcare providers, whether that's hospitals or physicians or other kind of healthcare providers, and they negotiate over the reimbursement rates and other terms of the contract. That negotiation results in competitive prices when there are both many providers and many insurers. The reason you need many insurers is that if there aren't many insurers, then the hospital, say, can't say in the negotiation, we won't contract with you if you don't pay us more, because that's not a credible threat if there aren't other insurers. That hospital system would be dependent on that insurer to have sufficient customers. Similarly, for the insurance company to have a credible threat, saying if you don't accept these lower prices, these lower reimbursement rates from us, we're going to take our business to a different hospital. Well, that's only going to happen if there are other hospitals in the market. So you really need both multiple hospitals, multiple physician groups, and multiple healthcare insurers for the competition at the first stage to work. And then at the second stage, it's all those providers that have gotten into the insurance company's provider network that are then competing, not based on price, but usually on other factors like quality of care, convenience, and whatnot. So it's really, when you're thinking about healthcare prices, it's really that first stage that's determining the prices, and it has been most recently the focus of antitrust analysis. Someone else mentioned there was that 10-year period where the Department of Justice and the Federal Trade Commission, they were striking out. They were losing all of their challenges to hospital mergers. And it was when the agencies really shifted their focus to thinking about this two-stage model and thinking in terms of the first stage being so important that the tide turned. So the St. Luke's case happened out in Idaho, the largest hospital system in a two-hospital system area. So this was happening in the Boise MSA. The St. Luke's system had just over half of the market, and then the St. Alphonsus system basically had the other half of the market. And what the St. Luke's system did, they already were employing quite a few physicians. Out in the western part of the MSA, so about 22 miles and a half-hour driving was the smaller city of Nampa. They acquired the largest group of physicians, and this group of physicians was so important because they were almost all of the primary care doctors in the western part of the MSA. So the first challenge came from the St. Alphonsus system, and then after the St. Alphonsus system had successfully won not a preliminary injunction, but a speedy trial, then the Federal Trade Commission and the Attorney General stepped in as well. So the hospital was facing 3 plaintiffs. So in terms of that market share, you can see out in the Nampa area, the combined market share, 68% of the adult primary care physicians and 89%, 8, I think, of the 9 pediatricians were now part of the St. Luke's system. So Abby and Fiona asked me to give you a sense of how important is this kind of vertical integration, and just take a look at the purple bar in the histogram, and you can see it is very steadily increasing. The purple bar represents those physician organizations that are owned by hospitals or where the physician is employed by hospitals. More recent data didn't make it into the chart, but this trend is continuing. So how might this sort of hospital-physician integration lead to anti-competitive impacts? 3 main ways. First, rather than the hospital system negotiating with insurers separately and the physician group negotiating with insurers separately at the first stage, you now have the hospitals and the physicians negotiating together. So in other words, there are going to be fewer substitutes for this now larger hospital physician organization, which weakens the position of the health insurer at the negotiating table, strengthens the position of the integrated hospital physician group, which could lead to higher prices, higher than competitive prices. The second way, and what we actually focused on a lot in the case, was what's called vertical foreclosure. And what that is that's economic term jargon for when a competitor is able to foreclose its rival from a sufficient number of customers, in this case, patients. So how might that work? Well, when the hospital acquires the physician practice, those physicians then are employed by the hospital. Those physicians play a very prominent role in determining, in consultation with their patients, where their patients are going to get their care. Some people refer to it as they're the air traffic controllers. So it's the physician who decides which specialist physician to refer to. Sometimes the physician refers directly to the hospital, directly to the outpatient facility. But if you get these physicians changing their referral patterns so that they're referring only to their employer, you're going to get a huge change in where patients are going for their care. And if it's such a great change that the rival hospital system or a rival group of specialist physicians or a rival outpatient facility doesn't have a sufficient base of consumers, that could raise their costs. They could have to cut back services, provide fewer kinds of services, and that would hurt competition in the market for hospital services. So this is hard to see. This is actually out of the first declaration that I wrote in the case, but it gives you a sense, and that's the only thing that was public in the case. The rest of the reports are behind for attorneys' eyes only. But I bolded one column here. And what you're seeing here, each row is a physician practice that St. Luke's had gobbled up prior to St. Luke's. Now, these physician practices were in the Boise area, where there are a greater number of physicians, so none of these practices, the acquisitions, were considered anti-competitive. But what you can do is you can see the pattern here. So even though St. Luke's does not include in their contract with physicians any requirement that they refer only to St. Luke's facilities, In effect, that's what happens. So look, say, at the second line there, the Idaho Cardiology Associates. Before their acquisition, they were admitting in a year 500 plus patients to St. Alphonsus, the rival. This is all St. Alphonsus, the rival's data. A year after the acquisition, admissions had fallen to 0. I don't here have the St. Luke's data, but guess where these patients were going? Also, let me speak briefly. It is possible that the sort of vertical acquisitions between hospitals and physicians could lead to efficiency gains in the form of higher quality and lower costs and spending. In the St. Luke's case, that's exactly what the hospital argued was going on. But the judge, and I know my colleagues here are going to talk more about this, and I've been told to wrap it up, so let me just say the judge did not agree with the hospital. He did not find that the efficiencies were merger specific, and therefore decided that it was an anti-competitive acquisition, and St. Luke's has had to spin off the Salter medical practice.
So good afternoon, everyone. My name is Henry Sue, and as Professor Klevorek said, I work with the Federal Trade Commission with the chairwoman. I want to thank Fiona and Abby for inviting me to be here. Congratulations to Yale Law School and the Solomon family on launching the Center for Health Law and Policy. And then finally, thanks to all of you who were able to stick around for the last panel. And there is a reward at the end, as the professor said, in the form of drinks. So I want to start off with a personal story. If you've looked at my bio, you'll see that I went to Yale College. And when I was at Yale College, I was actually pre-med. I majored in biology and remembered all those treks up Science Hill for my classes. But after the 4 years were done, I ended up going to law school. And that disappointed my late father, who was a doctor. But he used to tell people, as a consolation, he would say, well, at least my son isn't out there suing doctors. Now, obviously, he was thinking about, plaintiffs, medical malpractice lawyers, but he never envisioned that I might become a healthcare antitrust enforcer. So like Peter McEddy, I also have to give the standard disclaimer, which is although I am here as a representative of the Federal Trade Commission, my views are my own, and they're not necessarily those of the commissioner or any commissioner. Now, just like the Department of Justice's Antitrust Division, the FTC is charged with enforcing the antitrust laws, which includes Section 7 of the Clayton Act, which applies to mergers. In reviewing mergers, the FTC carries out a very specific mandate from Congress, which is to examine the effect of these transactions on competition and consumer welfare. And in fact, if you go back to the 1951 Supreme Court decision in Standard Oil versus FTC, there, the court said that the heart of our national economic policy long has been faith in the value of competition. And then I would also direct your attention to the Supreme Court's decision in 1978 in National Society of Professional Engineers versus United States, where the court said that other concerns like public safety do not justify doing away with competition and conferring monopoly privileges on certain firms. In sum, following these cases and other precedent, we have long adhered to the view that competition in healthcare markets can lead to lower prices, higher quality, better choices, and more innovation. So Section 7, lest there's any doubt, does apply to what we're calling vertical mergers. As the language of the statute says broadly that it prohibits mergers where the effect may be to lessen competition or to tend to create a monopoly. So what you need to know is that before Congress amended that statute in 1950, the Section 7 prohibited only mergers that lessen competition between the merging parties. So by changing the statute in that way, it made very clear, and you can see this in the legislative history as well, that within our jurisdiction are what we're calling vertical mergers. Now, as Professor Klevorek has explained, broadly speaking, when we talk about vertical mergers, We're talking about transactions involving firms at different levels of production or distribution. We similarly analyze mergers involving firms that produce complementary products in the same way. And so in this light, we view provider consolidations in the healthcare industry, such as the acquisition of a physician practice group or an ambulatory surgery center or a long-term care facility by a hospital, as essentially vertical in nature, even though the firms themselves aren't necessarily in a buyer-seller relationship. Relatedly, we're also seeing provider consolidations in non-overlapping product and geographic markets, such as when a city center hospital acquires a rural hospital that's outside in a neighboring county. And if we have time, we may get to those as well on this panel. Now, given all these permutations of transactions, I really prefer to refer to these consolidations as non-horizontal, because it's basically anything that doesn't have a horizontal overlap. Now, in terms of what we're doing at the FTC, we are continuing to learn more about the competitive impact of these non-horizontal consolidations. Importantly, we recently held 2 workshops examining various aspects of healthcare competition. The first was in March 2014, and then the second one more recently jointly with DOJ in February 2015. So what have we learned about non-horizontal consolidations? Are they competitively benign, or are they competitively harmful? To simplify the discussion, I'm going to focus on the acquisition of physician practice groups by hospitals and relate my observations to the St. Luke's case as appropriate. What you should know also is that I was on the trial team that worked on the St. Luke's case, so I actually have some personal experience and spend a good deal of time with Deborah in Nampa and Boise, Idaho. So I'll start with the competitively benign explanations. And what you need to understand is that these acquisitions of physician groups aren't new. The healthcare industry went through a similar wave of these acquisitions in the early 1990s in response to managed care. So been there, done that, right? I mean, that's what I would ask. And 2 long-touted reasons for doing these acquisitions are to coordinate care and to engage in risk-based contracting. Both are obviously good things. But what hospitals discovered during the 90s was that it was very expensive to purchase and maintain employed physicians, and very difficult to realize the goals of coordinating care by simply moving to a tighter form of structure. They also faced 2 bureaucratic costs common to large firms: diminished individual incentives and internal politics. So at the end of the day, my view is that the integration that the industry should be striving towards is the integration of clinical and patient care, not structural integration of firms. Put another way, an integrated delivery system does not necessarily lead to integrated delivery of care. There are other less restrictive ways in which hospitals and physician groups can work together. For instance, physician hospital organizations, independent practice associations, affiliations, alliances, you name it. So my challenge today to those of you who are students of organizational behavior is to identify what core functionalities, internal processes, and norms will best foster physician engagement and collaboration and promote patient-centered care. In St. Luke's, we put on evidence that the purported efficiency benefits weren't merger-specific. Relationship-specific investments, such as the investment in an EHR system, can be accomplished through arm's-length contractual relationships. And alliances between providers can engage in risk-based contracting. Now, what about the competitively harmful, or at least worrisome, explanations for acquisitions of physician groups? Put another way, if these acquisitions aren't necessarily leading to greater coordinated care or facilitating risk-based contracting, then why are providers still doing them? And you saw Deborah's chart where there's the trend again towards more acquisitions of physician groups. So what's going on? Well, 2 other touted reasons for doing these acquisitions are to gain leverage with health plans and to bring in more admissions. Now, in the interest of time, I'm going to focus on the former, which is bargaining leverage. Deborah has already discussed with you the other theories, vertical theories of harm, input foreclosure, and also reduction in network competition. When we review and investigate mergers, we routinely ask why the parties are doing the transaction. And in St. Luke's case, the parties had internal documents that talked about market share in primary care being critical to sustaining a strong position relative to payer contracting and getting the benefit of the clout of the entire network. In an option demand market where providers compete for inclusion in a health plan network, there isn't just competition between providers of the same service line, but also competition among pairings and other groupings of providers. Some pairings may be significantly more attractive than others, such that a merger that cements a particular pairing may foreclose the possibility of other desirable, commercially desirable pairings and leave only the undesirable ones. Now, an analog to this sort of theory of harm can be seen in our recent challenge in the merger of Cisco and US Foods. In that case, we alleged that the parties stood out among other food service competitors as broadliners that could offer one-stop shopping in foods and food-related products, particularly for customers that had operations that were national in scope. We can see how hospital systems with certain captive physician groups, such as cardiology or oncology, might be viewed as more attractive and command a higher willingness to pay than competing hospitals that don't have these groups. Of course, at the end of the day, we need to make sure that any theory of bargaining leverage has to distinguish between the leverage that results from the loss of competition and the leverage that results from other reasons, such as superior bargaining skill or risk aversion. So my challenge to health economists like Limor and Marty is to help us tease out those effects that can be traced back to a decrease in competition from the ones that, because those are the ones that ultimately count. So to conclude, I will note that in the St. Luke's case, the defendants told the court that they were engaging in a grand experiment to reform healthcare. And honestly, the trial court credited that. But the trial court also agreed with us that that experimentation should not require that consumers tolerate the risk of anti-competitive exercise of market power. There are other ways that the defendants can achieve coordinated value-based care without the likely harms that flow from a merger. In short, experimentation is wholly consistent with competition. Thank you.
Thank you, and thank you for inviting me, Abby and Fiona, to this terrific conference. It's really a nice change for me to be in the midst of academia, and I hope to come back here again and again as you do this conference over again. I feel a little bit like the lonely voice in the wilderness, although I'm glad that Brent is here sitting next to me too, because I've been sitting here all day long listening mostly to academics talk about how healthcare providers are evil and they only want bargaining leverage over health plans and all they want to do is raise prices. And I'm here to say there really is another side to this story. And I think the St. Luke's case is a great way to illustrate all of this because it's like a law school antitrust exam. It's got every issue you can imagine. One thing I'm not sure that came clear from the discussion up till now is that the FTC joined the case after St. Alphonsus brought the case along with some other plaintiffs, but chose not to join the plaintiffs in their theory that vertical foreclosure was the harm of the transaction. The FTC litigated the case entirely on the notion that it was a horizontal combination of two sets of physician groups that would raise prices in a very traditional antitrust sense. And I think it's very telling that that's the way the FTC chose to try the case, and it's also very telling that the courts chose not to reach that. So there is no finding of a violation based on a vertical theory. And that's because I think that everybody is struggling with what is the right way to bring a vertical foreclosure case and when do you really have harm from vertical foreclosure. And so to take the St. Luke's case as an example, and I'd like to bring a little bit more of a practical bent to it because my world is how do you take the facts on the ground, how do you work with hospital systems, physician organizations, health plans to make sure that the government agencies and the courts understand what is really going on in healthcare and what drives people to engage in these transactions. So I start from the premise that There absolutely are situations in which a vertical transaction like this can cause problems. St. Luke's Salzer may have been one of them. We don't know. But before you get to the question of whether it was justified and whether this case should survive, you really ought to ask the question of, well, what is the alternative to the other people in the market? So St. Alphonsus went to court, obviously, but that's a huge step. So they obviously believe they didn't have much of an alternative there. But for other situations, when a large hospital system acquires a large physician group, well, what can the competing hospital do? Well, perhaps they can recruit some more physicians. Physicians are mobile. Maybe they don't want to move to Nampa, Idaho. I'm not going to comment on that. But just to contrast that with some of the allegations in the St. Al's complaint, they talked about how St. Luke's went out and recruited physicians. So you got to ask yourself, really, is there an alternative? Can the market be more dynamic? You also have to look at what are the alternatives that health plans have. The allegation in all of these cases, of course, is that the vertical foreclosure, the requirements that this acquired set of physicians admit to the acquiring hospital is going to ultimately lead to higher prices because they're going to be able to demand higher prices from health plans. Well, how is that? Is it that there's the combination of the hospital and the physicians gives them some power they didn't have before? And what are the weapons that the health plans have? We talked about the two stages of competition, which is, we could spend a whole day on that probably, but okay, the health plans put the hospitals and the physicians, everybody's in the same network. What can they do if the prices go up to steer patients to the lower priced set of hospitals and physicians? So let's say that the other hospital in the market recruits its own cadre of physicians or is left with a certain set of physicians who presumably have the capacity to take on the patients that may have gone to the other hospitals. Well, in this world of tiered products, in this world of higher deductibles, in this world of high deductible health plans where patients pay more money out of their pocket, can't the health plans just tell their members, well, yeah, you could go here, but we've got a whole set of high quality doctors over here and it'll cost you less. Your choice, you go to the doctor you want, but here's an alternative. And I don't know that anybody has really explored the viability of those alternatives because I think that unfortunately the cases that are brought are in situations where the government or private parties feel on firm ground saying those aren't really alternatives at all. But as I said, in this new world of what's going on in healthcare, I think that could lead to a different conclusion. The other point that's sort of a little bit off topic that I feel like I have to make because of what Bill Baer said this morning is that there's a lot of talk about the impetus for a lot of these acquisitions of physician practices is the ability to charge higher rates because now it's a hospital-based practice. And that really is a function of the way Medicare reimbursement used to work and still works in some cases, and the commercial health plans have adopted that. And the theory there is that, well, if you're a hospital, you have higher costs, you're providing a different service, you ought to get paid more. And the counter to that, of course, is, well, wait a minute, if you just acquire a physician practice and you're doing actually exactly the same thing, should you get paid more? The point I want to make is that's a policy debate. That's not an antitrust problem because that can happen in a market where there are a dozen hospitals, hundreds of physicians, and there's one acquisition and the prices go up. So I think we need to be careful to make sure that we're not targeting a regulatory issue with the antitrust brush. Last point I want to make is the efficiencies. Everybody here agrees, as far as I can tell, there's huge momentum towards physicians leaving private practice and a huge momentum towards hospitals acquiring physicians. I was very startled by the statistics I saw this morning. I think something like only 35% of physicians are now in private practice. And if you ask my sister, who just retired from practicing medicine for 30-some years, nobody wants to be in private practice anymore. But anybody that you talk to that is actually engaged in the business side of healthcare these days is going to tell you that there really are actual legitimate business reasons to have everybody under one umbrella. And it's not just pie in the sky. It's not just, oh, we think if we acquire physicians and hire them, that they'll be able to manage care better. I think what Michael Dowling said this morning is if you're not on the ground, you don't really get it. And hospital after hospital after hospital will say, dealing with physicians, and I apologize to all the physicians in the room, is like herding cats. And if you don't have the same financial and institutional incentives, it's much, much harder to manage care in the same way than if you are all under the same roof and you really have the same mission. So I think that the enforcers need to give a little bit more credence to that. I think the antitrust laws are flexible enough to take that into account. Not only did the FTC not bring the St. Luke's case on a vertical theory, they've never brought a vertical case in a hospital acquisition of a physician. So I think that tells you that there's a lot of room for thinking about what the real implications are and what the real ability is of the industry to come up with efficiencies. I'd like to conclude with reading to you from the St. Luke's case because it really is sort of the microcosm of this debate that everybody's having. And you could tell that the district court judge was having a very difficult internal debate with himself. What side do I come down on? So what he said was, St. Luke's saw this major shift, referring to all the changes in healthcare, coming a long time ago, and they're to be complimented on their foresight and vision. They started purchasing independent physician groups to assemble a team committed to practicing integrated medicine in a system where competition depended on patient outcomes. So the court is giving St. Luke's a lot of praise and credence to trying to do the right thing here. But after going through all the facts in the case and struggling with what the antitrust laws say, the court, I believe, somewhat reluctantly concluded that it had to enjoin the transaction. So the conclusion of the court's preliminary ruling was, the acquisition was intended by St. Luke's and Salzer primarily to improve patient outcomes. The court is convinced that it would have that effect if left intact, and St. Luke's is to be applauded for its efforts to improve the delivery of health care in the aptly named, I should say, Treasure Valley. But there are other ways to achieve the same effect that do not run afoul of the antitrust laws and do not run such a risk of increased costs. For all of these reasons, the acquisition must be unwound. Thank you.
I too want to thank you, Abby, and the Yale Law School and the School of Management for putting on this conference. As a Yale Law graduate who's been in healthcare for over 20 years now, I echo the feeling that it's long overdue, but a very welcome arrival. So I look forward to future affiliations and associations. I want to thank Toby for kind of leading the way. I'll talk a little bit about our vertical integration with physician practices and vertical integration generally, but I also, before I sit down, want to sort of make a case for academic medical centers generally, because I think we've taken a beating today, particularly at Partners Healthcare. And so if you allow me a few minutes, I'll start out by telling you a little bit about what we look like as partners, and then talk a little bit about our vertical integration strategy, and then pose a few questions that I think are worth thinking about. So Partners was formed less than 20 years ago, but it was formed by two hospitals who have a combined age of about 400 years. So the biggest challenge that we continue to have is how you integrate two legacy academic medical centers who were fierce competitors into an organization that truly does provide cutting-edge, integrated, effective care. And I must say, I think we've done a pretty remarkable job at that, mainly because we have pretty remarkable colleagues. And Partners right now as I said, was formed by two hospitals, Mass General and Brigham and Women's. We're the only system in the country that boasts two of the top 10 U.S. News of World Report hospitals in it. But we are also a little bit larger than that. We have 6 community hospitals, a psychiatric hospital. We have also a continuing care organization that features rehab hospitals, home care, a few long-term care institutions. We have a pretty extensive network of community-based physicians. I should also say that our academic medical centers also employ their own physicians. We have physician organizations, and they're pretty good size. And so whenever we go out and acquire more physicians, the fact that we are a several thousand physician organization gets a lot of attention. But we also have urgent care centers that we're currently developing. And a few years ago, we acquired a health plan. And I have to say that it's important to understand that this organization is based on the mission of its founding institutions. And a lot of people hear about the three-legged stool of academic medical centers. We actually have a four-legged stool mission, and that is teaching, research, clinical care, and community service. And the reality is that only one of those services pays for itself, and that's clinical care. The others don't. And as a result, the clinical care subsidizes those others. So we're in an environment in Massachusetts where we had to grow, and we grew from a position of obviously strength because these institutions that we had were very much in demand. But now we're faced with a situation in Massachusetts as a result of not just the Affordable Care Act, but the Massachusetts precursor of that, which I think everybody now touts as having been a very good thing. But the focus, frankly, has been on cost. And there's no question that we are a costly institution. We can't escape that. Just a few words about about vertical integration, physician practices. We, as part of the South Shore acquisition attempt that got rebuffed, we did end up acquiring a 70-plus physician practice called Harbor Medical Associates, and that didn't get opposed by the Attorney General. We also acquired, as I said before, a health plan, which hasn't been opposed. And for a long time, even before we were organized, there was some vertical integration among the academic medical centers. And I think it's important to understand that we view the fact that we are vertically integrated in the way that I just mentioned as a real strength, because now what we're faced with in Massachusetts is a statute that virtually encourages us to take on more risk, hospitals to take on more risk. And when you're in a situation where you have to take on more risk for patients, you want to make sure that you are able to interface with the patient at almost every step of the way, because as we contract with our payers, we're obviously now going to be going more at risk for that patient care. And there's no secret that part of going at risk is it means that we have to keep those patients within our network, or at least we have to keep them within our sites so that we're able to deliver care in a very cost-effective way. And when you think about doing that, as Alex Azar put up on the screen, you saw that we just a few years ago decided to make a major investment in an electronic health record system, $1.2 billion, okay? That took a lot of thinking about, and obviously we took the plunge. Now, the reality is that a lot of other hospitals in our region have come knocking on our door saying, we want access to that. We would like access to that electronic medical record system, but we don't have the money to put one in. And part of being a successful system, frankly, is that they come to us and they ask us to help them invest in electronic health medical records. And so we see, as we look at the future and take on more risk, we see the reality of two things. Number one, if we are going to be able to take on more risk, we have to do it over an increasingly large population. And you do that by being able to shift some of the acute care from your tertiary care hospitals into community hospitals. And we've begun to do that successfully, but obviously we have large tertiary care hospitals, and one of the incentives for us to grow horizontally has been to try to shift some of that care into the community hospitals. That's obviously become more of a challenge, but I think that's not a challenge that's unique to us. Just like we are a high-cost provider, we mirror every other academic medical center in the country that are high-cost providers, and I think that's frankly why you see a lot of academic medical centers growing into vertically oriented systems for the idea of soup to nuts care. Before I come to a close, I do want to just suggest that there are other benefits that academic medical centers bring to the market that I think we don't always appreciate. Number one is research. While there is an appreciation for the fact that we do a lot of research, I only think in the recent years people have begun to appreciate how that research, particularly now coupled with big data, really has the potential to transform care and lower costs. And you don't hear many people talk, when we talk about efficiencies or the benefits of looking at mergers and acquisitions from a rule of reason perspective, you don't hear people giving us much credit for what the research that we do yields. And keep in mind, the research doesn't pay for itself. The second thing, and this has been talked about a lot, is how are we going to be measuring quality? Again, if it's a benefit that comes with growth, then there ought to be measures of quality that really are effective. And one of the factors I think that many of us have been looking at as we have grown is the emphasis that has been placed on cost. Now, that's clearly a concern. It's been a real concern in Massachusetts, and since we are a high-cost payer, we understand that concern. But we also feel that it's important for us to be able to demonstrate that we bring value, and we've had a mixed record in being able to do that. And so I think going forward, as you heard the last panel talk, there's really got to be much greater emphasis placed on patient-reported outcome measurements, because that's really, in our view, the countervailing, or not just the countervailing factor on cost, but it's also the key ingredient on cost when you measure value. Let me just close by saying that we've heard a lot today about the challenge of antitrust in healthcare, and I'm not here to say that academic medical centers really are going to lead the way to lower cost, but I do want to put a stake in the ground and say that academic medical centers and systems like ours really have a unique role to play, and if we continue to focus primarily on cost, then what's going to happen to the other parts of our mission? Is research going to dry up? Are community services going to shrink? And how is that going to affect our teaching mission? So at some point, I think we have to balance all of those things, particularly at academic medical centers, when we decide whether they should be permitted to grow or stay or not. Thank you.
Good afternoon. Oh, I'm going to figure out my slides here. Okay. Good afternoon. So I'd like to thank Abby and Fiona for having me here to speak today and to just congratulate them on the start of the Solomon Center. What a wonderful beginning to such an auspicious entity, and I can't wait to see all the things that this organization does and watch it grow over time. I know it's going to make a huge contribution. So as the very last speakers on the very last panel, Aaron and I know better than to keep all of you from your wine, so we're going to keep it quick and we are going to keep it fun. So we have heard from a lot of the speakers today that federal antitrust law is just one of several policy tools that could be used to help control healthcare costs, promote competition in the space. And what we're going to do is tell you that we think states have a role, both an opportunity and an obligation, in fact, to engage in some regulation and oversight over vertical integration efforts. And so what we're going to do is tell you a little bit about that and then give you 5 policy options to think about and what states can do. So as everybody knows, there are powerful economic, regulatory, and clinical incentives for vertical integration. And yet, all of the healthcare entities that seek to vertically integrate are not all going to do it for those benevolent reasons. Some of them will be doing it to gain market power, and some of them may be doing it because they want to do the good things and get the benefits of the market leverage as well. And so, unfortunately, what we're starting to see in the very initial, and I want to stress that this is the preliminary data that we're starting to see come out on hospital ownership of physician organizations, is that that model is starting to correlate quite highly, or to correlate with higher prices and higher spending at all different kinds of levels. So higher hospital prices, higher per patient expenditures, higher physician prices for the integrated entities. And what we're also starting to see in a recent study that just came out is in metropolitan statistical areas where there's higher hospital physician integration, the cost per patient throughout the area, the geographic area, goes up. So we're starting to see sort of spillover effects as well in that space. The other thing that we're starting to see is that physician hospital integrations are not being associated with lower utilization rates, things that we had hoped to see there. And again, I want to stress that these are just the preliminary studies, and some of them, all of them have limitations, but there's starting to be a body of evidence that's being built that suggests that these may not produce the results that we'd hoped for. And so, unfortunately, when we start to see competition being lessened and lost in these spaces, the market forces aren't working properly, and there are few systemic checks on private prices in this space. And so it's creating a big question about if we allow these vertical integrations to go forward, what happens? Well, the natural question in this space is, well, what about antitrust? Isn't that what antitrust law is there to do? And so we think that federal antitrust law has an incredibly important role to play in this space, but it also has limitations. And so what this is this is the timeline that everybody's been talking about over the course of the day, that there was this lull, a series of losses by the FTC and DOJ, where you can see in red, and then a long history where there was not a lot of challenges. And then at the end, we've seen a lot more activity lately, but none, and a lot of little green dots are FTC, DOJ wins. None of those have been challenges in vertical integration cases. And so this is where it gets complicated for vertical integration, because one of the things that we want to see is we want to allow for these vertical integrations to have the potential to gain the pro-competitive effects that they've promised. We want to give them a chance. You don't just want to impose a structural remedy and say that the merger can't go through. But at the same time, we need to monitor them. We need to oversee them in a way that is long-term and oftentimes quite resource-intensive. And so given these limitations, we think that states are uniquely situated to complement and supplement these federal antitrust efforts to control the potential threat of vertical integration. And as such, they have both an opportunity and an obligation to participate in cost control. So one of the most important things that we think states can do is to start to collect healthcare price, utilization, and quality data for analysis and reporting. One way to do this is to create an all-payer claims database. We've seen a lot of states start to do this. I think about 18 of them currently have legislation implementing it. About 20 or more are looking at it. But all-payer claims databases are large-scale, state-run databases that collect healthcare claims data and provider data from all across the state. And they're often thought of as price transparency tools, ways of getting pricing information to consumers, but they can do so much more. They can provide the kind of empirical evidence base that we need to form the policies of the future. It's really difficult to know what kinds of problem you're having, or if this proposed policy is working, if you don't have the data to back it up. Furthermore, if you can pair that claims data with outcomes data, then you can really know where you're driving value and when you're not. And so there are some challenges to creating APCDs. I would be lying if I said there weren't. There are resource barriers, there are technical barriers, there are practical barriers, and there are some legal barriers, as we know in the Gobet case that's coming down. Oral arguments are going to be heard in that case on December 2nd, so we'll be all, I'm sure, listening quite acutely. But these are surmountable challenges, and they have to be for us to get control over healthcare costs. And so what we're going to do now is I'm going to hand the mic over to Erin and let her tell you a little bit about some of the 5 policy proposals that we have for states.
Great, thanks, Jamie. So can states have their cake and eat it too? Is there a way to reap the potential benefits of vertical integration and and control the risks, the downside risks to consolidation and price. So we think that there is a way for states to do this. And the way to do this is to encourage beneficial integration, but with a quid pro quo. And the quid pro quo is that the integrating entity has to submit to price and quality oversight. And so here are the models that we're going to talk about. The first, I'm actually not going to spend a lot of time on because we've heard a lot about it today, and that's the state enforcement of the antitrust laws. We heard from Attorney General Maura Healey this morning. But I do want to highlight that some states are doing that, but some states are doing the opposite, which is granting state action immunity to these vertically integrating entities because they want to encourage this integration, maybe with some oversight, but this is also seen as a highly risky endeavor if we don't know that this will in fact promote competition or protect competition in the space. You've essentially immunized these integrating entities from antitrust scrutiny. But the next model is what are called certificates of authority, or ACO certification. So we know in the Medicare ACO program that there's like this whole regime of oversight that you have to comply with if you're going to be a Medicare shared savings program ACO. There is no similar regime of oversight for the over half of the commercial ACOs that are out there. All the ACOs out there, half of them are commercial, and there's no oversight for that. So 3 states have developed an ACO certification program where ACOs have to submit to, or may voluntarily submit to certification, basically by offering these regulatory carrots, either antitrust immunity or maybe state fraud and abuse immunity or other types of certification seals of approval from the state in exchange for more searching antitrust review up front and ongoing oversight of the ACO entity's price and quality data. So that's one way to do it. Another way is to sort of say, okay, well, let's not concern ourselves just with ACOs. Yes, that's the thing of the day, but what we're concerned about are provider prices sort of all across the board and all the types of vertical integrations that may not be under the auspices of an ACO. Well, in that case, maybe a state could implement more widespread oversight. And again, we heard from Attorney General Healey this morning about Massachusetts Health Policy Commission. So many states, or a handful of states, are implementing rate oversight commissions, which basically vest in an expert independent body the ability to study these APCD data and then make recommendations and policies and also study mergers. So that would be one way to do it, and you could also give this oversight commission rate regulation authority if you have a particular problem in your state. Another way to do it, though, is to use what is already in existence in the insurance commissioner. Every insurance commissioner already has the ability to engage in premium rate review or insurance rate review of insurance prices. So of course there's a large variation among the 50 states about how strong this authority is or what it looks like, but you could envision, as Rhode Island has done, to really strengthen this insurance rate review to put some pressure on provider price increases that insurers can contractually agree to when they ask for premium rate increases. And so Rhode Island's done this, and it's essentially an bold experiment in provider rate regulation through the insurance commissioner. So another way is if you sort of move down the spectrum, obviously you're getting more interventionist, more direct authority, and again, I guess I'll have to be like the 20th person to say I agree with Bob Berenson, that there is something to be said about maybe we shouldn't be so afraid of the final options of rate regulation. And the reason is that in places, yes, competition is the best mechanism, but in places where competition is already gone, and we are very, very consolidated, very concentrated, maybe the only option left are some form of rate regulation. And there are lots of ways to do it. One way to do it would be to cap the highest provider prices. I've seen this cap proposed at 125% of Medicare, 200% of Medicare. And basically, you're still allowing there to be competition below the cap, but the most must-have powerful providers would have to face some sort of limit on the prices they could charge. It's seen as an intermediate step toward rate regulation. And then finally, you have the Maryland solution, or even the no one ever talks about West Virginia. The West Virginia solution, which is either all-payer rate setting, which includes Medicare and Medicaid in the price setting, or you look at either just private rate setting where there is a rate review procedure for hospitals. Included in both of those models is a general oversight over hospital revenues, sort of total global budgets, and we're moving to that because you can't just have rate regulation on its own without some mechanism to control the incentive to ramp up volume. So you really need both halves of the equation, and states have lots of options. So here is a quick takeaway of our key points. Healthcare integration, vertical integration in particular, is a double-edged sword. We know that there may be some benefits to care coordination, quality, efficiency. There also may be some huge downside risks to competition and price. States, however, are critical. We haven't heard a whole lot about what states can do because there are currently few systemic checks, and frankly, we can't expect the FTC and the DOJ to ride in and save the day. So we need states to step up and do what they can to regulate in this area. And then finally, to manage the double-edged sword, what states can do is encourage beneficial integration, let them get big, but then regulate them with some quid pro quo of price and quality oversight. And in the one clear recommendation that we have is that for states to do this, all states need an all-payer claims database or some data collection mechanism to study what's going on in their state. And then beyond that, they have lots of different options, sort of on a sliding scale of regulation that they can choose from depending on the dynamics within their own state. So thank you very much.
So since the hour is late, I suggest that we have one or two structured questions for the panel, and then open it to the audience. So one issue about vertical integration, and in particular in the merger, when it's considered in the merger context, is that it's all done prospectively. We had in the last speaker's presentation the possibility of using regulation ex post to come to grips with problems. But there is a concern of a long history of problems with regulation in this area and in others about which one might be concerned. But the question I want to put to the panel is, if we're looking at it prospectively, and if we don't want to have to unscramble the eggs after the merger takes place, then the idea of having the merger has to revolve around predictions about the costs and the benefits of the integration. And it is possible to look at historical data and look at other experiences, but each of these is really unique. So in your efforts, how do you think we can marshal this evidence, gather the evidence, and in particular go down into things that Brent came close to mentioning, which is that these mergers may well, and we haven't talked much about it, but if Abby were up here, she would, may well have an impact on the way in which the doctors practice their medicine. And these elements seem to me to be at the core of these predictions, which I think are incredibly hard to make.
So I guess I'm probably the one with the bullseye, so I'll start with that.
No.
I guess two things. One is that we do, when we investigate mergers, we have this process that allows us to essentially take the equivalent of discovery, and we do, in that phase of our investigation, we do, probe the claims, the arguments for the efficiencies from this transaction. And I think part of it is, but it's a two-way street. I mean, the parties have to, if they're coming to us, they have to come to us prepared to talk about that and prepared to have some idea of, well, what, beyond just, well, we're going to, save costs on, consolidating, billing or something like that. They really need to have something for us about what the story is for doing this. So that's one response. I guess the other is that that's correct. I mean, for better or for worse, Section 7 is structured as a prediction. For most cases, unless we're dealing with a consummated transaction or a transaction where maybe the court allows it to go forward under some sort of hold separate or whatever, but in most cases we are dealing with a prediction, and it's not perfect. It's not perfect, which is why one of the things we're doing as an agency right now is this retrospective study on merger remedies. And hopefully through that and other processes, we can learn more about the effectiveness of some of the remedies that we put into place, including not only divestitures, but as I know some people will talk about, what we call conduct or behavioral remedies. So.
I have some thoughts on that because I'm in the business of trying to make predictions too. And there's especially in the horizontal merger context, there's a huge body of law about what gives rise to the presumption of anti-competitive effects. And the FTC and the Justice Department staff spend a lot of time pulling together the case to decide whether or not there's that presumption. And so they come up with their market structure, or whatever it is that leads to the presumption, and then sit back and say, aha, we predict anti-competitive effects. Well, then we come in and we say, well, here are all the benefits and here are all the reasons that the anti-competitive effects are really not going to occur. And by the time you get to that point in the process, it's, oh, no, we're convinced anti-competitive effects. And there isn't really a lot of structure and a lot of learning around when can you rebut that presumption. Because, of course, the cases that come to court are the ones where the presumption has not been rebutted in the eyes of the government. So I really think that there's a huge opportunity out there for people who study these things to really focus on what it is that is persuasive. These are all, the ones that don't get brought are, of course, all non-public. So we need some learning around what is it that can predict the lack of anti-competitive effects. And picking up on what he said about retrospectives, that may be a way to do it. And I'd love to hear Deborah's thoughts because she's done some of these in the horizontal context. And I know one set that you did came out two different ways. One merger was problematic and one was not. So I think, and that one doesn't get any attention. So I think there really is room for some additional work and research to figure out how you can predict a lack of anti-competitive effects.
Anybody else? Okay, no takers. So I have one last question, which actually has two parts. So one complaint or one concern that vertical mergers raise, which didn't appear in any of the talks this afternoon, is that it makes entry difficult. It makes entry difficult because if the merger takes place and you have the vertically integrated firm, then whoever is going to enter, in fact, has to enter at more than one level, and it's hard enough to enter an industry at one level than multiple. So I wonder what your concerns are about that, and combined with the tension that seems to be in the healthcare area, and in particular in this vertical integration, because we have an act that a law that in fact encourages the building of systems, but at the same time we're concerned about the vertical integration having an effect on competition. And so is there an inherent tension there? And if so, how do we address it? And second of all, what about this problem about the difficulty, if you're going to have competition, of having to enter at both of these levels? As I say, I mean, that's one of the common complaints about vertical integration, and I didn't hear that in this discussion.
Should I start again?
And in particular, I might say, if you have an academic medical center that has all the virtues that Brent is talking about, imagine trying to enter that versus a vertically integrated entity.
Yeah. So I guess my response to that is, some other people have talked about how there are differences between healthcare and other markets, and I guess one of the ones is we aren't talking about the classical buyer-seller relationship. So you don't have an issue like, for instance, what we would see in the petroleum industry, where if a refiner's vertically integrated with the wholesaler, then there is a kind of a raising rivals cost theory with the wholesaler, a new wholesaler coming in, because you're not going to get the benefit of the efficiencies that come from being able to buy, to produce the product itself. So I guess, I'd be interested in hearing what the theory is, but I guess when I think about entry in healthcare markets, I think about particular service lines and particular groups rather than another system coming in. And then, I mean, if there's already another system like St. Alphonsus, then they're already in the market in a sense, and I'm not sure that that the transaction makes it harder for them necessarily.
But interesting, in the St. Alphonsus case, that was one of the defenses. So if St. Luke's ties up these Salzer physicians, no big deal. St. Al's can recruit new doctors into the Nampa area. But there was all sorts of evidence. St. Al's had been trying to recruit physicians to Nampa for years. And to get physicians to be willing to locate in Nampa, granted, that's not your average place. I don't think I'd want to live there either. But even for those doctors that they were able to recruit to Nampa, it took years to ramp up their practices to the point where they didn't need subsidies from the hospital, because there is so much patient loyalty to the physicians that are already there. And if you're in an area where there's not a lot of new people moving in, it's really hard to bring up a physician to a level of the practice where they're actually, holding their own.
But that's a very traditional barriers to entry argument. It's not a function of the vertical integration. And I think the reason you don't hear about it in healthcare, at least in the hospital physician world, is that it's pretty well accepted that it's really hard to enter the hospital industry. Nobody's building new hospitals these days, or if they are, it's not the kind of hospital that's going to, it's going to be a little specialty heart hospital or something. It's not going to be Mass General. So I think that while in other industries the vertical merger raising entry barriers is a really important question, I just don't see it arising any differently than just sort of normal barriers to entry at one of the levels.
I don't know. I mean, you could imagine a situation, though, where a provider group, like say you had a very dominant integrated entity and a small provider group wanted to come in and they couldn't get referrals from the hospital who referred all of their mothers down to the pediatricians in their system. And so getting referrals for them would be a pretty challenging thing. And furthermore, with insurance companies, it would be hard for them to negotiate decent rates because they wouldn't have the practice or they wouldn't have the networks that were there. I think you can imagine a situation. I haven't seen data on this at all where it would be pretty challenging to bring in those groups, though.
Okay, I think we should give the audience a chance to ask questions, and the audience includes the organizer.
So I think we'll collect our questions, right? So we'll pose, let me pose our questions, and then the panel can answer their questions. How's that?
Sounds good.
Go first.
Okay. So, one thing that I was interested in was, so Henry mentioned the possibility of having contracts for spreading risk and, other methods of achieving similar goals without, running afoul of antitrust concerns. And I did want to press, Toby and Brent on that to sort of ask if there is a middle ground there, if there's some reason why those approaches couldn't be followed, and in other words, if there's some approach that could keep providers, payers, consumers, and the government all happy.
I think I'm going to take my prerogative to make mine the last question.
I just wanted to add something quickly to that.
Yes.
Which is, I think one perspective to keep in mind is that contractual arrangements are
Sorry,
really
can
hard.
you pick the mic up?
Sorry. One of the things to keep in mind about contractual arrangements is that they're really hard. One of the benefits of an acquisition, M&A agreement is pretty straightforward, right? The certain forms exist, you pay your money, you acquire it, and then you can move on. Trying to negotiate a term sheet in a complicated relationship like these, where the parties have trust issues, is really hard. And if you're trying to build something for all the reasons that we've mentioned that might have positive effects, doing it through contractual negotiations, it's going to take you forever.
This person, Adam's name tag says Aetna underneath it, so just so you understand. Speaking. My question is really for Brent, and then maybe quickly to Henry, is that, first of all, I want to thank you for bringing in the academic medical center perspective, because I don't think we've really talked about that enough today, and how the ACO model may be inconsistent with the teaching mission in some ways of academic medical centers, the whole sort of testing, the idea that we're telling residents and medical students to sort of try things out that may not actually be in line with the less testing model of the ACOs. But my question for you is really, this has sort of been a state-federal panel, like our very first panel of the day, and to bring it full circle is to ask Brent, how does it feel to be in a state like Massachusetts, where the state is really on top of you, in addition to the federal regulator? And then to ask Henry how you feel about a state like Massachusetts getting on top of Brent, when maybe that's your job, right? And so I just wanted to hear a little about the federalism part of it at the end of the day.
Let me start, because I think I can answer both. In terms of the question of contract with or own, I mean, we started out with, several thousand physicians in our 2 academic medical centers. And as we expanded our contracting network, we did contract with groups. We owned some and we didn't own others. And the reality is when it's a lot easier to incentivize employed physicians than it is non-employed physicians. And if you're not employed, you also have to follow certain fraud and abuse guidelines that make it very difficult. And in this world of things being changed very quickly and in terms of having more risk imposed and having cost ceilings imposed via the state law, which is a good segue, it's been a lot easier for us to own physicians. So we are moving much more in that direction. On the question of state regulation, I think there are pluses and minuses, frankly. On the whole, being in Massachusetts in healthcare is a plus. It's a state that recognizes the importance of healthcare, and it generally supports its healthcare providers, sometimes to a fault. And what I mean by that is when you look at the percentage of the state budget that's going to healthcare, it's a lot. And what's happening? The percentage of education is going down, the percentage of other state budget services are going down. And so that's what's creating the cost pressure, clearly, on healthcare. And as a result, you've got this state overlay that we as an academic medical center system, find it hard to navigate. But when you step back and look at this from a policy perspective, the real question is, we don't have a cost ceiling, but we certainly have a total medical cost target. And what happens if you exceed that, you get pressure from the state to correct that. And so being a high-cost provider, one concern is that cost target, if strictly enforced, then creates possible challenges for us, as I alluded to, in terms of what you sacrifice. Do you sacrifice the mental health care that we provide more than any other system? Because that doesn't pay for itself. Do you begin to cut back on your research? And so, that's the minus side. And I'm not suggesting that the scheme has to be thrown out, but it's got its limitations.
So to answer your question, Abby, I mean, my perspective is that the states are definitely our partners in this mission. What I didn't talk about was all the help, all the support that we got from the state of Idaho, for instance, in the St. Luke's case. And in my view, unlike other markets, for instance, petroleum, or distribution, food distribution, which are national in scope. In healthcare, we do deal with some very, very tiny markets. And somebody, in Washington is going to say, well, why does the FTC care about Nampa, Idaho? Well, part of it is the Attorney General, Lawrence Wasden, cares as well. And so it is very much a partnership. And I do, and to, Jamie and Aaron's work, I mean, I do, makes me think about, the Supreme Court's decision in New State ICE about states being laboratories for experimentation. I mean, there is states as sovereigns do have this ability to decide what kind of environment they want to be in. And obviously, we've been trying to push that envelope on the state action front, but at some point there is this issue about whether, how far federal antitrust policy should go, and whether, this really has to be something that the states solve on their own. But I think until then, we definitely enjoy a lot of collaboration, a lot of sharing of information, and even, bringing cases together.
So I think one thing that this last panel, and indeed that all the panels have shown, is that there are bodies of knowledge about law, about economics, about organization. But there's a distinctive aspect to the application of those bodies of knowledge and to those elements governing the society and the character of law and regulation that is distinctive to healthcare. And that's what's wonderful about having the Solomon Center for Health Law and Policy to take up these important issues that Steve Brill talked about at the post-lunch talk. And I think that it is a great launch with this conference, and I know that you all will, the remaining remnant, will join me in thanking our organizers, Abby Gluck and Fiona Scott Morton, their able staff of timekeepers, Renee DiMatteo, who took care of the arrangements for many of you, for maybe all of you, and Mike Thompson, who made sure that the facilities were all working well. So if you join me in a round of applause for that. And with that, I invite you and our hardworking and successful panel to the reception in the alumni reading room.